With metabolic acidosis, acidosis refers to a process that lowers blood pH below 7.35. And metabolic refers to the fact that it's a problem caused by a decrease in the bicarbonate concentration in the blood. Normally, blood pH depends on the balance or ratio between the concentration of bases, mainly bicarbonate or HCO3-, which increase the pH, and acids, which decrease the pH. The blood pH needs to be constantly between 7.35 and 7.45. And additionally, the blood needs to remain electrically neutral, which means that the total cations, or positively charged particles, equals the total anions, or negatively charged particles. Now, not all of the ions are easy or convenient to measure, so typically only 3 get measured. The dominant cation, sodium, or Na+, which is typically around 137 milliequivalents per liter, and the 2 dominant anions, chloride or Cl-, which is about 104 milliequivalents per liter, and bicarbonate, which is around 24 milliequivalents per liter. The rest are unmeasured. So just counting up these 3 ions, there's usually a difference or gap between the sodium concentration and the sum of the bicarbonate and chloride concentrations in the plasma, which is 137 minus 128, which comes from adding chloride and bicarbonate. And so you end up with 9 milliequivalents per liter. This is known as the anion gap, and normally it ranges between 3 and 11 milliequivalents per liter. The anion gap largely represents unmeasured anions, like organic acids and negatively charged plasma proteins, like albumin. So basically, metabolic acidosis arises either from a buildup of acid in our blood, which could be because it's produced or ingested in increased amounts, or because the body can't get rid of it, or from excessive bicarbonate loss from the kidneys or gastrointestinal tract. The main problem with all of this is that they lead to a primary decrease in the concentration of bicarbonate in the blood. Now, this can be broken down into 2 categories, based on whether the anion gap is high or normal. So the first category of metabolic acidosis is a high anion gap metabolic acidosis. In this case, the bicarbonate ion concentration decreases by the binding of bicarbonate ions and protons, which results in the formation of carbonic acid, which subsequently breaks down into carbon dioxide and water. These protons can come from organic acids which have accumulated in the blood, but they can also come from increased production in our body. One example is lactic acidosis, which is where decreased oxygen delivery to the tissues leads to increased anaerobic metabolism and the buildup of lactic acid. Another example is diabetic ketoacidosis, which can happen in uncontrolled diabetes mellitus, where the lack of insulin forces cells to use fats as primary energy fuel instead of glucose. Fats are then converted to keto acids, like acetoacetic acid and beta-hydroxybutyric acid. Another way acids can build up in our blood is due to an inability of the kidneys to throw them away, even though they're produced in normal amounts. This can happen in cases of chronic renal failure, in which organic acids like uric acid or sulfur-containing amino acids can accumulate because they aren't excreted normally. In other cases, organic acids don't come from inside our bodies at all, but instead they're accidentally ingested. These include oxalic acid, which can build up after an accidental ingestion of ethylene glycol, which is a common antifreeze, as well as formic acid, which is a metabolite of methanol, which is a highly toxic alcohol, or hippuric acid, which comes from toluene, which is found in paint and glue. All of these organic acids have protons, and at a physiologic pH, they dissociate into protons and the corresponding organic acid anions. The released protons attach to bicarbonate ions floating around, which decreases its plasma concentration and shifts the pH towards the acidic range. The key here is that the plasma maintains its electroneutrality, because for each new negatively charged organic acid anion, there's one less bicarbonate ion. And because the organic acid anions are not part of the anion gap equation, the anion gap will be high. In contrast, in other cases of metabolic acidosis, the decrease in bicarbonate ions is offset by the buildup of chloride ions, which are part of the anion gap equation, so the anion gap remains normal. The most common cause is severe diarrhea, where bicarbonate-rich intestinal and pancreatic secretions rush through the gastrointestinal tract before they can be reabsorbed. Another cause is type 2 renal tubular acidosis, which is the most common type of renal tubular acidosis, and develops because the proximal convoluted tubule, which is a part of the nephron, is unable to reabsorb bicarbonate. Other types of renal tubular acidosis also result in a normal anion gap metabolic acidosis, but the underlying mechanism is an inability to excrete protons in the urine. The excessive loss of bicarbonate results in a low plasma bicarbonate concentration, which ends up lowering the pH. In response, the kidneys start reabsorbing more chloride ions. So for each bicarbonate ion that's lost, there's a new chloride ion. This is why normal anion gap metabolic acidosis is sometimes called a hyperchloremic metabolic acidosis. Now, if there's a decrease in the bicarbonate concentration in the blood, which threatens to decrease the blood pH, the body has a number of important mechanisms to help keep the pH in balance. One of them is moving hydrogen ions out of the blood and into cells. To accomplish this, cells usually have to exchange a hydrogen ion for a potassium ion, using a special ion transporter located across the cell membrane. So in order to help compensate for an acidosis, hydrogen ions enter cells and potassium ions leave the cells and enter the blood. This might help with the acidosis, but it results in hyperkalemia. In cases, though, when there's a metabolic acidosis from excess organic acids, like lactic acids and keto acids, protons can enter cells with the organic anion, rather than having to be exchanged for potassium ions. Another important regulatory mechanism involves the respiratory system, and starts with chemoreceptors that are located in the walls of the carotid arteries, and in the wall of the aortic arch. These chemoreceptors start to fire when the pH falls, and that notifies the respiratory centers in the brainstem that they need to increase the respiratory rate and depth of breathing. As the respiratory rate and depth of each breath increases, the minute ventilation increases, which is the volume of air that moves in and out of the lungs in a minute. The increased ventilation helps more carbon dioxide move out of the body, which reduces the partial pressure of carbon dioxide in the body, which increases the pH. An additional mechanism is that if metabolic acidosis isn't caused by some renal problem, then several days later the kidneys usually correct the imbalance. The kidneys excrete more hydrogen ions while also reabsorbing bicarbonate ions, so that it's not lost in the urine. Alright, as a quick recap. Metabolic acidosis is usually caused by a decreased bicarbonate concentration in the blood. It can be classified into high anion gap cases, which are caused by the accumulation of organic acids, either due to their increased production in the body, decreased excretion, or exogenous ingestion. And the other type is normal anion gap cases, which are caused directly by a loss of bicarbonate ions, as is the case in diarrhea or type 2 renal tubular acidosis. With metabolic alkalosis, alkalosis refers to a process that raises blood pH above 7.45, and metabolic refers to the fact that it's caused by an increase in the concentration of bicarbonate, or HCO3- in the blood. Normally, blood pH depends on the balance or ratio between the concentration of bases, mainly bicarbonate, which increases the pH, and acids, which decrease the pH. The blood pH needs to be constantly between 7.35 and 7.45. Now, metabolic alkalosis can typically happen from two main causes: loss of hydrogen ions and gain of bicarbonate ions, or most often a combination of these two. Loss of hydrogen ions can happen either from the gastrointestinal tract or from the kidneys. The first case most commonly happens during vomiting, because the gastric secretions are very acidic, meaning that they have lots of hydrogen ions. On top of that, normally as gastric secretions flow into the pancreas, they're met with bicarbonate secretions, which neutralize the acid so that the various pancreatic enzymes like trypsin and chymotrypsin can work effectively. So during vomiting, not only is the stomach acid lost, But in addition, the pancreas doesn't secrete bicarbonate into the intestines, and so it builds up in the blood instead. Another way that hydrogen ions can be lost is through the urine, in the context of having too much of the hormone aldosterone. This can happen when there's an adrenal tumor that secretes excess aldosterone. The aldosterone makes the alpha intercalated cells of the distal convoluted tubule and collecting duct dump out hydrogen ions and reabsorb more bicarbonate. The result is that the urine becomes more acidic, and the blood becomes more basic. Now, the second cause, a primary gain of bicarbonate, is usually caused by an increased reabsorption of bicarbonate from the kidneys. There are various things that could stimulate the kidneys to do this. One of them is volume contraction, or excessive loss of extracellular fluid, which can happen with loop diuretics and thiazide diuretics, as well as in cases of severe dehydration. The resulting alkalosis is called a contraction alkalosis. Sometimes dehydration happens in combination with other causes of metabolic alkalosis, like prolonged vomiting. Another stimulus is hypokalemia, or decreased levels of potassium in the blood, which can be due to excessive loss from the gastrointestinal tract, like in diarrhea, or from the kidneys, due to diuretic use. In any case, when there's less volume or less potassium in the extracellular space, it triggers the renin-angiotensin-aldosterone mechanism. As a result, angiotensin II and aldosterone levels rise, and the kidneys start to retain water and reabsorb more bicarbonate in the proximal convoluted tubule. In addition, the alpha intercalated cells of the distal convoluted tubule and the collecting ducts secrete more hydrogen ions into the urine. But most importantly, they also make new bicarbonate ions, which will again get reabsorbed. Now, in other cases, excess bicarbonate ions don't come from within our bodies at all, but are ingested in large amounts, usually in the form of antacids, like sodium bicarbonate. These are typically used to neutralize stomach acid and relieve indigestion. Excess use of antacids, though, can result in more bicarbonate ions than hydrogen ions in the stomach, and the excess bicarbonate ions can get absorbed into the blood. All these processes have a net result of increasing the bicarbonate ion concentration in the blood, which increases blood pH. But in addition, there's often a hypokalemia. In vomiting, for example, potassium ions in the gastric secretions are lost. In other situations, there's an increase in aldosterone, like during a contraction alkalosis or when there's an adrenal tumor. The aldosterone can affect principal cells which line the distal convoluted tubule and collecting ducts, making them excrete potassium into the urine. So essentially, hypokalemia can be both a cause and a result of metabolic alkalosis. Now, if there's an increase in the bicarbonate concentration in the blood, the body has a few important mechanisms to help keep the pH in balance. First, cells throughout the body have a special type of ion transporter that exchanges hydrogen ions for potassium ions across the cell membrane. Using this transporter, the cells can shift hydrogen ions out of the cells and into the blood, and in exchange pull potassium ions out of the blood and into the cells. And this can contribute to the hypokalemia. Another mechanism involves the respiratory system, and starts with chemoreceptors that are located in the walls of the carotid arteries and in the wall of the aortic arch. These chemoreceptors fire less often when the pH rises, and that notifies the respiratory centers in the brainstem that they need to decrease the respiratory rate and depth of breathing. As the breathing becomes slow and shallow, the minute ventilation decreases, and that's the volume of air that moves in and out of the lungs in a minute. The decreased ventilation slows down how much carbon dioxide leaves the body, increasing the partial pressure of carbon dioxide in the body, which decreases the pH. A final mechanism is that if metabolic alkalosis isn't caused by some renal problem, like the use of diuretics, or extracellular fluid volume contraction, then several days later the kidneys usually correct the imbalance. The kidneys retain more hydrogen ions while also reabsorbing less bicarbonate ions, so that it's more easily dumped into the urine. Alright, as a quick recap, metabolic alkalosis is caused by an increased bicarbonate ion concentration in the blood that elevates blood pH above 7.45. This most frequently results in loss of hydrogen ions due to vomiting or adrenal tumors, and less commonly from a gain of bicarbonate ions from antacids or volume contractions. With respiratory acidosis, acidosis refers to a process that lowers blood pH below 7.35. And respiratory refers to the fact that it's a failure of the respiratory system carrying out its normal pH balancing job. Now, normally during an inhalation, the diaphragm and chest wall muscles contract to pull open the chest, and that sucks in air like a vacuum cleaner. Then, during an exhalation, the muscles relax, allowing the elastin in the lungs to recoil, pulling the lungs back to their normal size and pushing that air out. Ultimately, the lungs need to pull oxygen into the body and get rid of carbon dioxide. Carbon dioxide binds to water in the blood and forms carbonic acid, which then dissociates into hydrogen ions and bicarbonate ions. So, in order to prevent pH fluctuations, the carbon dioxide concentration, or the partial pressure of carbon dioxide, called PCO2, needs to be kept within a fairly narrow range. For this reason, the lungs maintain the ventilation rate they need to get rid of carbon dioxide, at the same rate that it's created by the tissues. If PCO2 starts to rise and pH starts to fall, chemoreceptors that are found in the walls of the carotid arteries and in the wall of the aortic arch start to fire more. And that notifies the respiratory centers in the brainstem that they need to increase the respiratory rate and the depth of breathing. As the respiratory rate and the depth of each breath increases, the minute ventilation increases. And that's the volume of air that moves in and out of the lungs in a minute. The increased ventilation helps move more carbon dioxide out of the body, which reduces the PCO2 in the body and raises the pH. In respiratory acidosis, the normal mechanism of ventilation is disturbed, and minute ventilation becomes inadequate to balance the pH. This can be due to a number of problems. Sometimes the problem's not in the lungs themselves, but in the respiratory centers of the brainstem. After a stroke or a medication overdose, like with opioids or barbiturates, the respiratory centers can slow their rate of firing, so breathing becomes extremely slow or stops entirely. It could also be due to a neuromuscular disorder, like myasthenia gravis, where the nerves don't effectively stimulate the muscles to contract. Sometimes the diaphragm or chest wall muscles don't work properly, which can happen after severe trauma, or due to obesity when the chest wall is too heavy for the muscles to lift it. Another reason is airway obstruction, which might happen if a child swallows an object like a peanut and it lodges in the right mainstem bronchus, preventing the lung from fully ventilating. Finally, there might be impaired gas exchange between the alveoli and the capillaries. That might happen if alveoli are damaged from chronic obstructive pulmonary disease, or if fluid accumulates within the alveoli like in pneumonia, or if fluid collects between the alveoli and the capillary walls, like in pulmonary edema. In all these situations, the result is that the lungs can't efficiently get rid of carbon dioxide. The carbon dioxide accumulates in the blood, so the partial pressure of carbon dioxide rises, usually above 45 millimeters of mercury. This causes a decrease in blood pH, often reducing it below 7.35. To compensate for this decrease, the body has designed several mechanisms. If the respiratory centers are working, then they try to increase the rate and depth of ventilation. If that doesn't work, then some of the excess carbon dioxide diffuses across cell membranes, especially into red blood cells, where it reacts with water molecules and forms carbonic acid, which eventually gets converted into hydrogen ions and bicarbonate ions. The key here is that this bicarbonate can quickly escape to the circulation, trying to counteract the increased partial pressure of carbon dioxide and keeping the pH from getting too low. At the same time, though, free hydrogen ions are generated, which could very well make the intracellular environment acidic. Fortunately, they can be bound and neutralized by various basic molecules within the cells, mainly exposed NH2 or amine groups in proteins like hemoglobin. The concentration of these proteins, though, is too low compared to the amount of excess carbon dioxide molecules floating through the blood. What this means is that if all of the carbon dioxide molecules tried to hide inside the cells, they'd give rise to a whole lot of hydrogen ions that have no spare protein to bind to, and therefore this would mess with the intracellular pH. So essentially, only a small amount of carbon dioxide molecules find their way into the cells. As a result, the amount of bicarbonate that's generated is too little, about 1 milliequivalent per liter for each 10 millimeters of mercury increase in partial pressure of carbon dioxide, in order to have a substantial effect on pH. For example, if partial pressure of carbon dioxide has an acute rise of 20 millimeters of mercury, let's say it moved from 40 to 60, then this mechanism could only result in a rise of plasma bicarbonate by 2 milliequivalents per liter, from its reference value of 24 up to 26, which doesn't have a big impact on pH. Therefore, the pH remains very low during this acute phase of the disorder. Fortunately, if minute ventilation hasn't decreased to life-threatening levels, then within about 3 to 5 days, the kidneys start sensing that pH is too low and step up to help correct the imbalance. More specifically, the cells of the proximal convoluted tubule start generating and reabsorbing more bicarbonate into the bloodstream. In fact, the kidneys are pretty effective in doing this, since they manage to increase the concentration of bicarbonate about 4 milliequivalents per liter for each 10 millimeters of mercury increase in partial pressure of carbon dioxide. So if partial pressure of carbon dioxide went up from 20 to 40 millimeters of mercury, which is a 20 millimeter of mercury increase, plasma bicarbonate would increase by 8 milliequivalents per liter, going from its reference value of 24 to 32 milliequivalents per liter. This can lead to a substantial increase in the pH, bringing it closer to its normal range again. Alright, as a quick recap, respiratory acidosis happens when the lungs fail to eliminate excess carbon dioxide, which builds up in the blood, causing blood pH to fall below 7.35. It's divided into an acute and a chronic phase, according to the absence or presence of renal compensation, respectively, which raises bicarbonate concentration in the blood. With respiratory alkalosis, alkalosis refers to a process that causes alkali accumulation or acid loss, and respiratory refers to the fact that it's a failure of the respiratory system carrying out its normal pH balancing job. Now, normally during an inhalation, the diaphragm and chest wall muscles contract to pull open the chest, and that sucks in air like a vacuum cleaner. Then during an exhalation, the muscles relax, allowing the elastin in the lungs to recoil, pulling the lungs back to their normal size and pushing that air out. Ultimately, the lungs need to pull oxygen into the body and get rid of carbon dioxide. Carbon dioxide binds to water in the blood and forms carbonic acid, which then dissociates into hydrogen ions and bicarbonate ions. So, in order to prevent pH fluctuations, the carbon dioxide concentration, or the partial pressure of carbon dioxide, called PCO2, needs to be kept within a fairly narrow range. For this reason, the lungs maintain the ventilation rate they need to get rid of carbon dioxide, at the same rate that it's created by the tissues. If PCO2 levels start to fall and pH levels start to rise, peripheral chemoreceptors that are found in the walls of the carotid arteries and in the wall of the aortic arch start to fire less. And that notifies the respiratory centers in the brainstem that they need to decrease the respiratory rate and depth of breathing. As the respiratory rate decreases and breaths become more shallow, the minute ventilation decreases, which is the volume of air that moves in and out of the lungs in a minute. The decreased ventilation means less carbon dioxide moves out of the body, which increases the PCO2 in the body and lowers the pH. In respiratory alkalosis, the normal mechanism of ventilation gets disturbed, and the minute ventilation goes higher than what's needed to balance the pH. For ventilation to increase, the respiratory centers have to start firing more than usual. This increased firing might be a normal compensatory response, or an abnormal response to a situation that doesn't really call for increased ventilation. Increased ventilation is a normal response to things like hypoxia, which is a low oxygen level that happens with diseases like pneumonia or a pulmonary embolism. or even when a person climbs a high mountain like Mount Everest. Increased ventilation, though, can be an abnormal response that sometimes happens in situations like anxiety and panic attacks, as well as in sepsis or in overdoses with salicylates. Rarely, brainstem disorders can irritate the respiratory centers and make them fire more. Sometimes increased minute ventilation is iatrogenic, meaning that it's a result of a medical intervention. For example, a person might be intubated and on a ventilator. If the ventilator settings aren't correct, it can cause a respiratory alkalosis. In all of these situations, the result is that the lungs get rid of too much carbon dioxide. The carbon dioxide gets depleted from the blood, so the partial pressure of carbon dioxide falls, usually below 35 millimeters of mercury. This causes an increase in blood pH, often raising it above 7.45. To compensate for this increase, the body has designed several mechanisms. First of all, minutes after the onset of respiratory alkalosis, acidic molecules from within the cells, especially red blood cells, like exposed carboxyl groups from proteins like hemoglobin, give off a whole bunch of hydrogen ions. These hydrogen ions diffuse into the blood, where they grab bicarbonate ions in order to form carbonic acid, which will eventually break down to carbon dioxide and water molecules. This leads to a slight decrease in the plasma bicarbonate concentration, which is the main alkaline molecule in the blood. The concentration of these intracellular proteins, though, is too low compared to the amount of bicarbonate floating around in the blood. So essentially, only a limited amount of hydrogen ions are available to bind and neutralize these bicarbonate molecules. As a result, most of the time the decrease in free bicarbonate ions is too little to have a substantial effect on pH, since it's only about 2 milliequivalents per liter for each 10 millimeters of mercury decrease in partial pressure of carbon dioxide. As an example, if PCO2 has an acute drop of 20 millimeters of mercury, let's say it moved from 40 to 20, then this mechanism could only decrease plasma bicarbonate by 4 milliequivalents per liter, from its reference value of 24 to 20, which does not have a big impact on the pH. Therefore, the pH remains high during this acute phase of the disorder. Fortunately, within about 3 to 5 days, kidneys start sensing that pH is too high, and step up to help correct the imbalance. More specifically, the major way they do this is by making the cells of the proximal convoluted tubule decrease reabsorption of HCO3-, so it's being excreted more in the urine. In fact, the kidneys are pretty effective in doing this, since they manage to decrease the concentration of bicarbonate about 4 to 5 milliequivalents per liter for each 10 millimeters of mercury decrease in PCO2. So just like before, if PCO2 went down from 40 to 20 millimeters of mercury, plasma bicarbonate this time would decrease by 8 milliequivalents per liter, from 24 to 16. This can lead to a substantial decrease in the pH, bringing it closer to its normal range again. Alright, as a quick recap, respiratory alkalosis happens when lungs blow off more carbon dioxide than needed, which causes blood pH to increase above 7.45. It can be divided into an acute and a chronic phase, according to the absence or presence of renal compensation, respectively, which decreases bicarbonate concentration in the blood.
With acute kidney injury, or AKI, there's a decrease in kidney function that typically happens over a few days. This leads to the retention of urea and other nitrogenous waste products, such as ammonia and uric acid, and dysregulation of extracellular volume and electrolytes. The most commonly used diagnostic criteria for AKI are the Kidney Disease Improving Global Outcomes, or KDIGO guidelines. The KDIGO guidelines define AKI as an increase in serum creatinine of at least 0.3 milligrams per deciliter within 48 hours, or as an increase in serum creatinine by 1.5 times the baseline serum creatinine within the last 7 days, or when the urine volume has been less than 0.5 milliliters per kilogram per hour for 6 hours. Based on these criteria, there are 3 stages of AKI, where stage 1 is mild and stage 3 is severe AKI. In stage 1 AKI, there's an increase in serum creatinine to 1.5 to 1.9 times the baseline serum creatinine, or an increase in serum creatinine by 0.3 milligrams per deciliter, or a decrease in urine output
to below 0.5 milliliters per kilogram per hour
for 6 to 12 hours. In stage 2 AKI, there's an increase in serum creatinine to 2 to 2.9 times the baseline serum creatinine, or a decrease in urine output
to less than 0.5 milliliters per kilogram per hour
for more than 12 hours. In stage 3 AKI, there's an increase in serum creatinine to 3 times the baseline serum creatinine, or an increase in serum creatinine to more than 4 milligrams per deciliter, or a decrease in urine output
to less than 0.3 milliliters per kilogram per hour
for more than 24 hours, or anuria, meaning less than 100 milliliters per day of urine, for more than 12 hours, or where renal replacement therapy has been initiated. All individuals are classified according to whichever criteria places them in the most severe stage of injury. Once diagnosed, the causes of AKI can be split into pre-renal, intrarenal, and post-renal causes. In pre-renal AKI, there's decreased blood flow into the kidneys. This can happen in hypovolemic states like an acute hemorrhage, gastrointestinal losses, like with diarrhea and vomiting, renal losses, like with diuretics or osmotic diuresis in hyperglycemia, dermal losses, like with burns, and finally, sequestration of fluid, also known as third spacing, like with acute pancreatitis or sepsis. On the clinical examination, there's tachycardia, hypotension, reduced skin turgor, and cool extremities. Now, pre-renal AKI can also happen with hypervolemic states, where there's a low effective circulating volume. One example is severe systolic heart failure, leading to pump failure, and when this happens, it's called cardiorenal syndrome. In this situation, there are signs of heart failure, like hypotension, fatigue, dyspnea, and peripheral edema. Another hypervolemic situation, due to a low effective circulating volume, is hypoalbuminemia from decompensated liver disease. When that leads to AKI, it's called hepatorenal syndrome. The individual has hypotension and signs of liver disease, like splenomegaly, caput medusae, ascites, and peripheral edema. Additionally, some medications like NSAIDs, ACE inhibitors, ARBs, cyclosporin, and iodinated contrast can damage renal blood vessels, leading to ischemia and causing pre-renal AKI. Next, there's intrarenal AKI, which is due to damage to the tubules, the glomerulus, or the kidney interstitium, which is the space between tubules, or vascular damage. The most common cause of intrarenal AKI is acute tubular necrosis, or ATN, which causes damage to the tubules due to ischemia. Often, ATN is due to ischemia from a pre-renal acute kidney injury. The other way tubules can necrose is by nephrotoxins, such as aminoglycosides, antibiotics, methotrexate, heavy metals like lead, myoglobin from damaged muscles, like in rhabdomyolysis, ethylene glycol, radiocontrast dye, and uric acid. Typically, the individual has been exposed to a nephrotoxin and has associated symptoms. For example, if they've been exposed to ethylene glycol, the individual might also be confused and have dilated pupils. Whereas if the cause is myoglobinuria, they may have had a recent crush injury. Another type of intrarenal AKI is glomerular disease, which is anything that damages the glomeruli. Glomerular disease can cause isolated gross hematuria, like immunoglobulin A nephropathy. It can also cause signs of nephrotic syndrome, such as peripheral or periorbital edema, even ascites. This can happen with membranous nephropathy or membranoproliferative glomerulonephritis. Labs here show that proteinuria that's above 3.5 grams per day, protein to creatinine ratio greater than 3 grams per gram, hypoalbuminemia that's typically less than 3.5 grams per deciliter, and hyperlipidemia, with levels of low-density lipoprotein, or LDL, above 130 milligrams per deciliter, and levels of triglycerides above 150 milligrams per deciliter. On urinalysis, specifically microscopy, there's lipiduria, which is identified based on the presence of fat droplets. Or it can present signs of nephritic syndrome, such as arterial hypertension and peripheral edema. This can happen with systemic lupus erythematosus. Labs here show moderate proteinuria, between 1 and 3 grams per day, and on urinalysis, there are more than 5 dysmorphic red blood cells per microliter, and also red cell casts. Finally, it can also present with signs and symptoms of a more severe systemic condition, such as malaise, arthralgia, and fever, like with Goodpasture disease. Another cause of intrarenal AKI is acute interstitial nephritis, which is inflammation of the interstitium over the course of days to weeks. This is thought to be a type 1 or type 4 hypersensitivity reaction, and is typically a response to a medication like NSAIDs, penicillin, and diuretics, such as thiazide diuretics, like chlorothiazide. Early symptoms include fever and rash. Now, vascular damage can be caused by renal artery stenosis, which is when one or both renal arteries are narrowed. This can be caused by atherosclerosis in older individuals and by fibromuscular dysplasia, which is a non-inflammatory and non-atherosclerotic condition that usually affects the internal carotids and renal arteries in younger individuals. Symptoms include persistent arterial hypertension despite taking antihypertensive medications, and sometimes peripheral edema. Finally, there's post-renal AKI, which is due to an obstruction to the outflow of urine from the kidneys, which causes a buildup of urine and pressure that backs up into the kidney. This is most frequently due to benign prostatic hyperplasia or prostate cancer in a male, both of which lead to compression of the urethra. This can lead to frequent urination but a slow urinary stream. Other causes include intra-abdominal tumors that compress the ureter, in which case the individual can present with unintentional weight loss and fatigue. Finally, there are kidney stones that can get stuck in either ureter or in the urethra. Now, if only one ureter is obstructed, called unilateral obstruction, and the other kidney is working fine, then renal function is usually preserved. But if both ureters are obstructed, like when there are stones in both ureters, called bilateral obstruction, or if the urethra gets blocked, then we've got a recipe for post-renal AKI. With obstructive ureteral kidney stones, the individual has renal colic along with anuria if both ureters are completely obstructed. With urethral stones, the individual has pain in the urethra and anuria. Now, additional labs include creatinine levels in order to calculate the estimated glomerular filtration rate, or eGFR, BUN, CBC, and electrolytes to check for hyperkalemia. Hyperkalemia can develop because when the individual is oliguric, potassium isn't effectively removed from the blood. Also, if the individual is hyperventilating, this can be a sign of metabolic acidosis, so an ABG is also done. AKI can lead to severe metabolic acidosis, where the pH dips below 7.1, because acid excretion is impaired when there's a low eGFR. Next, urinalysis, both dipstick and microscopic examination of the urine sediment and urine sodium excretion, are done to help calculate the fraction of sodium excreted to sodium filtered, or Phen-A. In pre-renal AKI, the renin-angiotensin-aldosterone system is activated, leading to water and sodium retention. So, the BUN to creatinine ratio is usually over 20:1. The urine osmolality is over 500 milliosmoles per kilogram. The urine sodium excretion is less than 20 milliequivalents per liter, and the Phen-A is less than 1%. With intrarenal AKI, filtration, reabsorption, and secretion can all be affected. As a result, the BUN to creatinine ratio is usually below 20:1. Urinalysis results can vary based on the cause, but generally, the urine osmolality is below 500 milliosmoles per kilogram because water isn't as well retained. In acute tubular necrosis, on microscopy, there are muddy brown, granular epithelial cell casts, along with renal tubular epithelial cells. In glomerular nephritis, there's usually hematuria and proteinuria. Additionally, on microscopy, there are dysmorphic red blood cells and red blood cell casts. In glomerulonephritis, an additional workup includes a 24-hour urine collection, serology, and a kidney biopsy to identify the underlying cause. In acute interstitial nephritis, the CBC shows eosinophilia. On the urine dipstick, there may be hematuria, proteinuria, and pyuria. On microscopy, there are white cells, white cell casts, and red blood cells. With all types of intrarenal AKI, urine sodium excretion is typically above 40 milliequivalents per liter, and the Phen-A is above 1% because sodium isn't effectively reabsorbed. Finally, there's post-renal AKI. If the obstruction damages the tubules, then reabsorption is affected, so the BUN to creatinine ratio falls below 20:1, and the urine osmolality is below 500 milliosmoles per kilogram. Urine sodium excretion is typically above 40 milliequivalents per liter, and the Phen-A is above 1%, because sodium doesn't get reabsorbed. When the tubules are functioning, urea, water, and sodium can be reabsorbed, so the BUN to creatinine ratio is above 20. The urine osmolality is over 500 milliosmoles per kilogram. Urine sodium excretion is less than 20 milliequivalents per liter, and the Phen-A is below 1%. In both situations, on urinalysis, there can be hematuria. Sometimes, an obstruction can lead to an infection, so there may also be pyuria. An additional workup includes obtaining serum prostate-specific antigen, or PSA level, which is elevated with prostatic disease, both benign prostatic hyperplasia and prostatic cancer, as well as imaging. An abdominal ultrasound can help identify proximal ureter stones and hydronephrosis, and a non-contrast CT scan of the abdomen and pelvis can help identify abdominal tumors or stones along the urinary tract, including the urethra. AKI can lead to various complications, such as volume overload, hyperkalemia, severe metabolic acidosis with a pH that's below 7.1, and signs of uremia, like uremic pericarditis, where the pericardial sac gets inflamed, causing chest pain. In this case, an echocardiogram is done, and this typically shows a pericardial effusion. Treatment relies on urgent dialysis or temporizing measures until dialysis can be arranged. Temporizing measures include administering IV diuretics, like furosemide when an individual is fluid overloaded, administering IV bicarbonate when the pH is below 7.1, and administering IV calcium gluconate along with IV insulin plus glucose, and IV furosemide when there's hyperkalemia with potassium levels above 5.5 milliequivalents per liter. With any type of AKI, it's important to identify and treat the underlying cause. Now, with pre-renal AKI and intrarenal AKI that's caused by acute tubular necrosis and interstitial nephritis, the goal is to carefully manage the body's fluids while the kidneys heal and recover. With intrarenal AKI caused by glomerular disease, treatment relies on identifying and treating the condition. Finally, with post-renal AKI, treatment relies on identifying and removing the obstruction. Now, there are some general principles that are taken into consideration with any type of AKI, regardless of stage. First, all nephrotoxic medication is discontinued and radiocontrast procedures are avoided, since that can worsen the renal function. Next, the individual's hemodynamic status is monitored. If the individual has signs of hypovolemia, like hypotension, then IV saline is given to restore intravascular volume. Normally, that helps stabilize the blood pressure, but if an individual is persistently hypotensive, then vasopressors like IV norepinephrine may be needed. Now, on the flip side, if the individual is hypervolemic, then IV diuretics, such as furosemide, are given. In critically ill individuals, Invasive hemodynamic monitoring is done using an arterial line, central venous pressure, and cardiac monitoring. Serum creatinine levels and urinary output are usually monitored every few hours. Blood glucose is also monitored because hyperglycemia can cause an osmotic diuresis, which further damages the kidneys. Additionally, with stage 2 AKI and stage 3 AKI, the dosage of medication should be adjusted according to eGFR. Alright, as a quick recap, AKI is diagnosed and staged based on creatinine levels and urine output using the KDIGO criteria. Pre-renal AKI can be caused by either hypovolemia, like with acute hemorrhage, diarrhea, diuretics, or acute pancreatitis, or hypervolemia, like with cardiorenal or hepatorenal syndrome. Intrarenal AKI can be caused by acute tubular necrosis, which is either ischemic or caused by nephrotoxins, like aminoglycosides, glomerulonephritis, acute interstitial nephritis, that can be caused by the use of nephrotoxic medications and vascular damage like with renal artery stenosis. Postrenal AKI can be caused by prostatic disease, intra-abdominal tumors, or kidney stones. Additional lab work includes calculating eGFR, CBC, BUN, ABG, electrolytes, urinalysis, urine sodium excretion, and Phen-A. In pre-renal AKI, the BUN to creatinine ratio is greater than 20:1. Urine osmolality is greater than 500 milliosmoles per kilogram. Urine sodium excretion is less than 20 milliequivalents per liter, and Phen-A is less than 1%. With intrarenal AKI, the BUN to creatinine ratio is below 20:1, and the urine osmolality is below 500 milliosmoles per kilogram. Urine sodium excretion is above 40 milliequivalents per liter, and Phen-A is above 1%. When there's acute tubular necrosis, microscopy shows muddy brown granular epithelial cell casts and tubular epithelial cells. When there's glomerulonephritis, there's also hematuria and proteinuria, along with dysmorphic red blood cells. When there's acute interstitial nephritis, there's eosinophilia, hematuria, pyuria, along with white cells, white cell casts, and red blood cells. With postrenal AKI, when the tubules aren't working, BUN to creatinine ratio is below 20:1, urine osmolality is below 500 milliosmoles per kilogram, urine sodium excretion is above 40 milliequivalents per liter, and Phen-A is above 1%. When the tubules are working, BUN to creatinine is above 20:1, urine osmolality is above 500 milliosmoles per kilogram, urine sodium excretion is less than 20 milliequivalents per liter, and Phen-A is below 1%. Treatment of AKI is mainly about identifying and managing the underlying cause. The indications for urgent dialysis are volume overload, severe metabolic acidosis, hyperkalemia, and signs of uremia. Generally, all nephrotoxic medication is stopped and no contrast imaging is done, or the dosage is adjusted according to the renal function. When there's hypovolemia, IV saline is given, and after that, vasopressors like norepinephrine are used, if needed. When there's hypervolemia, IV furosemide is given.
Acute kidney injury, or AKI, is when the kidney's not functioning at 100%, and that decrease in function usually develops relatively quickly, typically over the course of a few days. Actually, AKI used to be known as acute renal failure, or ARF, but AKI is a broader term that also includes subtle decreases in kidney function. AKI can essentially be split into three types: pre-renal AKI, meaning the cause of the kidney injury is coming before the kidneys; post-renal AKI, meaning after the kidneys; or intrarenal AKI, meaning within the kidneys. Now, the kidney's job is to regulate what's in the blood, so they might remove waste, or make sure electrolyte levels are steady, or regulate the overall amount of water, and even make hormones. The kidneys do a lot of stuff. Blood gets to the kidneys through the renal artery. into tiny clumps of arterioles called glomeruli, where it's initially filtered, with the filtrate, the stuff that gets filtered out, moving into the renal tubule. Sometimes fluid or electrolytes can move back from the filtrate into the blood, called reabsorption, and sometimes more fluid or electrolytes can move from the blood to the filtrate, called secretion. Along with fluid and electrolytes, though, waste-containing compounds can also be filtered, like urea and creatinine, although some urea is actually reabsorbed back into the blood, whereas only a little bit of creatinine is reabsorbed. In fact, in the blood, the normal ratio of blood urea nitrogen, or BUN, to creatinine is between 5 and 20 to 1, meaning the blood carries 5 to 20 molecules of urea for every 1 molecule of creatinine. And this is a pretty good diagnostic for looking at kidney function. Ultimately, that filtrate is turned into urine and is excreted from the kidneys through the ureter into the bladder and peed away. Meanwhile, the filtered blood drains into the renal vein. Alright, so with post-renal AKI, there's some obstruction to the outflow from the kidneys. Reduced flow can be a result of something compressing the ureter, like intra-abdominal tumors, or compressing the urethra further down, like from benign prostatic hyperplasia, a non-cancerous growth of the prostate gland, both of which sort of pinch the ureter and urethra shut. Also, though, it could be from some blockage inside, like kidney stones getting stuck in the ureter or urethra, which can actually plug it up. Now, if only one ureter is obstructed, it's called unilateral obstruction. And if the other kidney's working fine, then renal function's actually usually preserved. If either both ureters are obstructed, which is called bilateral obstruction, or the urethra gets obstructed, then we've got a recipe for post-renal AKI. Whatever the obstruction is, it ultimately causes this buildup of urine and pressure that backs up into the kidney, all the way to the millions of tiny renal tubules. Normally, filtration moves fluid from the relatively high-pressure arteriole to the low-pressure renal tubule. But this backup causes an increase in renal tubule pressure, which reduces the pressure gradient and lowers the amount of fluid that filters across, which lowers the glomerular filtration rate, or GFR, which is how much blood the kidneys filter in milliliters through their glomeruli per minute. And this means that less waste products like urea and creatinine are filtered out of the blood, meaning more stays in the blood, which leaves people with azotemia, or high levels of nitrogen-containing waste compounds in the blood, as well as oliguria, low levels of urine. Now, if we follow the stuff that does make it into the tubule, which also includes things like sodium and water, it turns out that the high-pressure tubular system essentially forces more reabsorption of sodium, water, and urea, but not much creatinine because remember, little to no creatinine gets reabsorbed. Now, this increased urea reabsorption relative to creatinine increases the BUN to creatinine ratio in the blood, typically making it greater than about 15 to 1. Also, while the tubules aren't functioning normally and reabsorbing appropriately, the urine sodium is typically less than 20 milliequivalents per liter, since most of that sodium is being reabsorbed, which means that the fraction of sodium excreted to sodium filtered, or FeNA, is usually less than 1%. And finally, since most of that water and fluid is being reabsorbed as well, the urine's typically pretty concentrated, usually greater than 500 milliosmoles per kilogram. Alright, so I said normally before because over time that increased pressure damages the epithelial cells that are responsible for reabsorption in the tubules. When that happens, less and less urea gets reabsorbed back into the blood, and instead it stays in the tubule and then gets dumped out into the urine. And this causes the BUN to creatinine ratio in the blood to fall below 15 to 1. Also, in the same way, less sodium is reabsorbed, so more gets excreted and urine sodium goes above 40 milliequivalents per liter, and FeNA goes above 1% in mild cases, but in severe cases it can go above 2%. Finally, just as with the others, less water and fluid being reabsorbed causes the urine to be less concentrated, and urine osmolality falls below 350 milliosmoles per kilogram. Alright, so as a quick recap, post-renal acute kidney injury is where the kidneys aren't functioning at 100%, and this is due to some obstruction in the ureters that blocks the flow of urine. Now that you know all about post-renal AKI, Check out these other two videos on pre-renal AKI and intrarenal AKI. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Acute kidney injury, or AKI, is when the kidney is not functioning at 100%, and that decrease in function usually develops relatively quickly, typically over the course of a few days. Actually, AKI used to be known as acute renal failure, or ARF, but AKI is a broader term that also includes subtle decreases in kidney function. AKI can essentially be split into three types: pre-renal AKI, meaning the cause of the kidney injury is coming before the kidneys; post-renal AKI, meaning after the kidneys; or intrarenal AKI, meaning within the kidneys. Now, the kidney's job is to regulate what's in the blood, so they might remove waste, or make sure electrolyte levels are steady, or regulate the overall amount of water, and even make hormones. The kidneys do a lot of stuff. Blood gets to the kidneys through the renal artery, into tiny clumps of arterioles called glomeruli, where it's initially filtered, with the filtrate, the stuff that gets filtered out, moving into the renal tubule. Sometimes fluid or electrolytes can move back from the filtrate into the blood, called reabsorption, and sometimes more fluid or electrolytes can move from the blood to the filtrate, called secretion. Along with fluid and electrolytes, though, waste-containing compounds can also be filtered, like urea and creatinine, although some urea is actually reabsorbed back into the blood, whereas only a little bit of creatinine is reabsorbed. In fact, in the blood, the normal ratio of blood urea nitrogen, or BUN, to creatinine is between 5 and 20 to 1, meaning the blood carries 5 to 20 molecules of urea for every 1 molecule of creatinine. And this is a pretty good diagnostic for looking at kidney function. Ultimately, that filtrate is turned into urine and is excreted from the kidneys through the ureter into the bladder and peed away. Meanwhile, the filtered blood drains into the renal vein. Alright, so pre-renal kidney injury is due to a decreased blood flow into the kidneys. So you've got your total body fluid, with some fluid circulating in the plasma, as well as all the other intracellular and extracellular fluid. So a decreased blood flow could be due to an absolute loss of body fluid, where fluid actually leaves the body. And this could be caused by major hemorrhage or blood loss, vomiting, diarrhea, or with severe burns, where body fluid evaporates really fast without the protective skin. Decreased blood flow could also be due to a relative loss of fluid, where total body fluid stays the same. How can that happen, though? Well, one example of this is distributive shock, which is where the fluid moves from the blood vessels into the tissues, which keeps the total body fluid volume the same, but you have a relative decrease in blood volume. Another example is congestive heart failure, which is where the heart can't pump blood to the tissues. So a portion of that blood just pools in the venous side and isn't pumped to the body, meaning less blood is sent to the kidneys. Finally, the issue could be local to the renal artery itself. For example, it could become narrowed, as in renal artery stenosis, or blocked by an embolus, which is a blood clot from somewhere else in the body. Whatever the case, less blood's going to the kidneys, right? So less blood's going to the glomeruli, which means less blood's being filtered. So there's a decrease in the glomerular filtration rate, or GFR, which is how much blood, usually in milliliters, the kidneys filter through their glomeruli per minute. If less blood's being filtered, that means less urea and creatinine are filtered out, and more stays in the blood, which is called azotemia, high levels of nitrogen-containing compounds in the blood. This will also tend to cause oliguria, an abnormally low amount of urine production. Also, with less blood being filtered, the kidneys activate the renin-angiotensin-aldosterone system, which causes aldosterone released by the adrenal glands, which tells the kidneys to reabsorb sodium. When sodium gets reabsorbed, water gets reabsorbed as well. Water and sodium reabsorption is also tied to urea reabsorption. So in a pre-renal situation, urea gets reabsorbed and so even more urea gets into the blood, resulting in a BUN to creatinine ratio of greater than 20:1. Now looking at what gets excreted in the urine, more sodium and water being retained means that less is excreted. And the urine sodium is usually less than 20 milliequivalents per liter. And the fraction of sodium excreted to sodium filtered, or FeNA, is usually less than 1%. And finally, that urine is more concentrated, because remember, less water is excreted. So typically the urine's greater than 500 milliosmoles per kilogram, most of which is urea, which is why your pee smells so nitrogen-y when you're dehydrated. Alright, so as a super quick recap, pre-renal acute kidney injury is where the kidneys aren't functioning at 100%, and this is due to less blood flowing into the kidneys. Now that you know all about pre-renal AKI, check out these other two videos on post-renal AKI and intra-renal AKI. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Acute kidney injury, or AKI, is when the kidney's not functioning at 100%, and that decrease in function usually develops relatively quickly, typically over the course of a few days. Actually, AKI used to be known as acute renal failure, or ARF, but AKI is a broader term that also includes subtle decreases in kidney function. AKI can essentially be split into three types: pre-renal AKI, meaning the cause of the kidney injury is coming before the kidneys; post-renal AKI, meaning after the kidneys; or intra-renal AKI, meaning within the kidneys. Now, the kidney's job is to regulate what's in the blood, so they might remove waste, or make sure electrolyte levels are steady, or regulate the overall amount of water, and even make hormones. The kidneys do a lot of stuff. Blood gets to the kidneys through the renal artery, into tiny clumps of arterioles called glomeruli, where it's initially filtered, with the filtrate, the stuff that gets filtered out, moving into the renal tubule. Sometimes fluid or electrolytes can move back from the filtrate into the blood, called reabsorption, and sometimes more fluid or electrolytes can move from the blood to the filtrate, called secretion. Along with fluid and electrolytes, though, waste-containing compounds can also be filtered, like urea and creatinine, although some urea is actually reabsorbed back into the blood, whereas only a little bit of creatinine is reabsorbed. In fact, in the blood, the normal ratio of blood urea nitrogen, or BUN, to creatinine is between 5 and 20:1, meaning the blood carries 5 to 20 molecules of urea for every 1 molecule of creatinine. And this is a pretty good diagnostic for looking at kidney function. Ultimately, that filtrate is turned into urine, and is excreted from the kidneys through the ureter into the bladder and peed away. Meanwhile, the filtered blood drains into the renal vein. Typically, intrarenal AKI is due to damage to the tubules, the glomerulus or the interstitium, the space between the tubules. Starting with the tubules and the most common cause of intrarenal AKI, which is acute tubular necrosis, which is where the epithelial cells that line the tubules necrose, or die. One way this can happen is via ischemia, or a lack of blood supply to the cells. A lot of times acute tubular necrosis due to ischemia is caused by some pre-renal acute kidney injury, since pre-renal AKI results in less blood sent to the kidneys, and those epithelial cells need oxygen from blood just like any other cells. In fact, all that secretion and reabsorption in the tubules takes a lot of energy, and so these cells are particularly sensitive to a loss of blood supply, especially the cells in the proximal tubule and the medullary segment of the thick ascending limb. The other way epithelial cells can necrose is via nephrotoxins, which are substances that tend to damage the epithelial tubular cells. A few of the common ones being aminoglycosides, which are a group of antibiotics, heavy metals like lead, myoglobin released from damaged muscles, ethylene glycol, essentially antifreeze, which is naturally sweet tasting and therefore a risk for poisoning children, radiocontrast dye, and uric acid. That last one, uric acid, is a waste product that can build up when cells die during cancer treatment, called tumor lysis syndrome, and is the reason why staying well hydrated to improve flow through the tubules, as well as using medications like allopurinol and urate oxidase to lower uric acid levels, can be so important while on certain chemotherapy. Whatever the cause of cell death is, when those cells die, they slough off into the tubule and basically build up and plug the tubule, which, just like in post-renal AKI, generates higher pressures in the tubules, which means fluids essentially trying to flow from high-pressure arterioles to high-pressure tubules, which doesn't work very well, and the fluid filtered across is lowered, which lowers the glomerular filtration rate, or GFR, which is how much blood the kidneys filter in milliliters through their glomeruli per minute. With less blood being filtered, less urine's produced, called oliguria, abnormally low urine production, and less urea and creatinine get filtered out, so more stays in the blood, called azotemia, high levels of nitrogen-containing compounds in the blood. Along with that, dead cells aren't very good at reabsorbing or secreting molecules anymore, right? So other things start to build up in the blood as well, like potassium, called hyperkalemia, as well as acids, called metabolic acidosis. Also, these dead clumped up cells in the tubule form a brown granular cast, which will eventually get excreted in the urine. It's called a cast because it stays in essentially the same cylindrical shape as the tubule. If the underlying cause of acute tubular necrosis is addressed, people can recover because tubular cells can typically regenerate over the course of a few weeks. Alright, another type of intrarenal AKI is glomerulonephritis, or GN, which means inflammation of the glomerulus. GN is often caused by antigen-antibody complexes depositing in the glomerular tissue. This deposition activates the complement system, which is a cascade of enzymes that attracts other immune cells, like macrophages and neutrophils, to the site, which then release lysosomal enzymes, causing inflammation and damaging the podocytes, which are the cells that line the glomerulus. These normally have small gaps between them and have a negative electrical charge, both of which prevents large molecules from filtering through. When damaged, though, membrane permeability increases, and large molecules are allowed to be filtered into the urine, like proteins, called proteinuria, and even red blood cells, called hematuria. Also, this fluid leakage reduces the pressure difference that drives filtration of small molecules and electrolytes like sodium, and so the GFR actually goes down because of this leakage. Lower GFR means less blood gets filtered and so less urine's produced, causing oliguria, and that also means more fluid circulating in the blood, which leads to edema or fluid buildup in the tissues, as well as hypertension from excess fluid volume. Finally, if those nitrogen-containing compounds aren't being filtered out, more stays in the blood, which causes azotemia. Alright, finally we have damage to the kidney interstitium as a cause of intrarenal AKI. One key example being acute interstitial nephritis, which is inflammation of the interstitium over the course of days to weeks. This inflammation is caused by infiltration of immune cells, like neutrophils and eosinophils, which then cause inflammation. This is thought to be a type 1 or type 4 hypersensitivity reaction, and is typically a response to medications like NSAIDs, penicillin, and diuretics. Early symptoms include oliguria and eosinophiluria, which is eosinophils in the urine, but also general symptoms like a fever and a rash. These symptoms usually subside if the medication is stopped, but if the medication isn't stopped, then the immune cells continue to damage the connective tissue in the interstitium, and those kidney cells can start to die off, called renal papillary necrosis, where the renal papillae are destroyed. This can again cause hematuria, blood in the urine, as well as flank pain. Other potential causes of renal papillary necrosis are chronic use of analgesics, like aspirin, as well as diabetes mellitus, sickle cell disease, and pyelonephritis. In general, with intrarenal AKI, the kidneys lose the ability to filter the blood properly, and so the cells are often damaged such that reabsorption and secretion are impaired. If the urea isn't reabsorbed, less urea stays in the blood relative to creatinine, and the BUN to creatinine ratio falls to less than 15:1. Also, those cells can't reabsorb sodium, meaning that urine sodium goes above 40 milliequivalents per liter. And the FeNA, which is the fraction of sodium excreted in the urine to total sodium filtered, expressed as a percentage, goes above 2%. And finally, since water is not being reabsorbed as much, urine osmolality falls below 350 milliosmoles per kilogram. So as a quick recap, intrarenal AKI is kidney injury caused by something within the kidneys themselves, which could be the tubules as in acute tubular necrosis, the glomerulus as in glomerulonephritis, or the interstitium as in acute interstitial nephritis. Now that you know all about intrarenal AKI, check out these other two videos on prerenal AKI and postrenal AKI. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media. Horseshoe kidney, or sometimes renal fusion, is a congenital disorder where the two kidneys fuse together into one during fetal development, resulting in one large horseshoe-shaped kidney. Normally, during fetal development, the future kidneys develop in the pelvis as a structure called the metanephros, before finally migrating upward into the abdomen and becoming everyone's favorite organ duo. For people with horseshoe kidney, though, their kidneys fuse together at some point during development. And there are two main working theories on how this might happen. The first is mechanical fusion, which happens during the metanephros stage, which is about the 5th week of gestation. At this point, the two kidneys are still in the pelvis, and are therefore pretty close together, so close that it's thought that some flexion or growth of the developing spine and pelvic organs essentially pushes them together, causing the lower or inferior poles of the kidneys to touch and fuse together, forming what's called a fibrous isthmus. Fibrous because it's composed of connective tissue. The other theory involves a teratogenic event. Teratogenic means something that disrupts fetal development in some way. In this case, it's thought that the posterior nephrogenic cells, which are cells that help to form part of the kidney, migrate and rendezvous in the wrong spot, and therefore again form an isthmus connecting the two kidneys. But this time, since the isthmus is composed of kidney cells as opposed to connective tissue, it's called a parenchymal isthmus. Whichever one happens, now you've got this single horseshoe-shaped kidney in the pelvis. During about weeks 7 and 8, it tries to migrate up into the abdomen, but it literally hits a bit of a roadblock and hooks around the inferior mesenteric artery, which keeps it lower in the abdomen than normal. Horseshoe kidney is actually a relatively common congenital disorder, affecting about 1 in 500 people, and is about twice as common in men. Most people with horseshoe kidney are asymptomatic, although it does predispose someone to certain complications like hydronephrosis, backup of urine due to an obstructed ureter. Also, having a horseshoe kidney is associated with kidney stones, infection, and chromosomal disorders like Turner syndrome, trisomy 13, 18, and 21. And finally, it's associated with an increased risk of kidney cancer, especially Wilms tumor and carcinoid tumor. People with horseshoe kidney alone typically don't need treatment and have a normal lifespan. Although it's important to keep in mind the abnormal structure of the horseshoe kidney if surgical intervention is needed for one of the complications or some other abdominal procedure. Alright, so a quick recap. Horseshoe kidney is a congenital disorder where the kidneys fuse sometime during development, and as it migrates, it gets hooked around the inferior mesenteric artery, keeping it lower in the abdomen. Potter sequence is a rare disorder that's sometimes called oligohydramnios sequence, a term that helps define it because oligo means low and hydramnios means amniotic fluid. So in Potter sequence, there's basically very little amniotic fluid, and this makes the uterus a pretty hostile place for the fetus to grow. Typically, around the 20th week of gestation, the kidneys, ureters, and urethra develop and start producing and excreting urine. And this urine becomes the major source of amniotic fluid. Various conditions like renal agenesis, which is when one or both of the kidneys are missing, or atresia of the ureter or urethra, which is where those parts of the urinary tract are obstructed, can lead to an inability to produce or excrete urine, and therefore leads to oligohydramnios. Other common causes can include amniotic rupture, which is the leakage of amniotic fluid, or uteroplacental insufficiency, which is where there's low blood flow from the placenta, meaning the fetal organs, which includes the fetal kidneys, see less blood flow, which in turn leads to decreased urine production. When there's very little amniotic fluid, a couple things happen as a result. First, amniotic fluid's crucial for the development of the fetal lungs, by both helping the airways physically stretch out, as well as contributing amino acids, like proline, which helps with the formation of connective tissue and collagen in the lungs. With less amniotic fluid, though, there's pulmonary hypoplasia. Hypo means under, and plasia means formation, so the lungs basically remain underdeveloped. Not only that, though, with less amniotic fluid, there's less space in the amniotic sac, and so the fetus is literally compressed into a smaller space, which causes developmental abnormalities like a flattened face, wrinkly skin, widely separated eyes with epicanthal folds, low-set ears, as well as limb abnormalities like clubbed feet. Potter sequence usually affects boys, since they have a higher rate of urinary tract obstruction anomalies, like posterior urethral valves. Diagnosis of Potter sequence is usually done with ultrasound during the second trimester of pregnancy. Unfortunately, though, by the time this condition is diagnosed, the syndrome's usually very advanced, and in most cases result in a stillbirth, which is the delivery of a fetus that's already died. When babies do survive, the pulmonary hypoplasia leads to severe respiratory problems, which often leads to death shortly after birth. Alright, as a quick recap, Potter sequence is an often fatal condition that primarily affects newborn males, and it's caused by oligohydramnios, which is low or absent amniotic fluid. Potter itself is actually a mnemonic, and it stands for pulmonary hypoplasia, oligohydramnios, twisted skin for the wrinkles, twisted face, extremity deformities, and renal agenesis. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Alright, so renal agenesis. Genesis is the origin or formation of something, and the prefix a means not. And renal refers to the kidneys, so renal agenesis is when the kidneys don't form. Since there are two kidneys, renal agenesis can refer to just one kidney not developing, called unilateral renal agenesis, or URA, or neither kidney developing, called bilateral renal agenesis, or BRA. Alright, so during fetal development, first off you've got this structure called the mesonephric duct, which is involved in development of urinary and reproductive organs. And during the 5th week of gestation, a little guy called the ureteric bud starts pushing its way into another structure called the metanephric blastema. And together these two little embryologic structures go on to develop into a kidney. At about the 7th week, nephrogenesis, or formation of the kidneys, starts under the influence of the ureteric bud. By about 20 weeks, the ureteric bud has formed the ureters, the renal calyces, collecting ducts, and collecting tubules, while the metanephric blastema develops into the nephron itself, which includes the epithelial cells and the podocytes of the Bowman's capsule. In the 3rd trimester and throughout infancy, the kidneys continue to grow and mature. With renal agenesis, the ureteric bud fails to induce development of the metanephric blastema, and so either one or both kidneys don't develop. Although not completely known, it's thought that this is a result of a combination of genetic as well as in utero environmental factors, like toxins and infections. Newborns with unilateral renal agenesis are usually asymptomatic, if the other kidney is otherwise healthy. Now that one kidney is doing all the filtering though, over time unilateral renal agenesis can lead to hypertrophy, or growth of the kidney, which later in life can increase the risk of hypertension as well as renal failure. Alright, so let's move into bilateral agenesis, which is where there are no kidneys. Normally, as the kidneys start to function around week 16, they start to filter the fetal blood, which means that some fetal urine gets produced, some of which contributes to the amniotic fluid that the fetus floats around in. With bilateral renal agenesis and no kidneys, urine isn't produced and so there's less amniotic fluid, until they develop oligohydramnios, where oligo means low or less, and hydramnios refers to the amount of amniotic fluid. A couple things happen as a result of this. First, that amniotic fluid is crucial for development of the fetal lungs, by both helping the airways physically stretch out as well as contributing amino acids like proline, which helps with the formation of mesenchyme and collagen in the lung. So with less amniotic fluid, the lungs can't develop all the way, called pulmonary hypoplasia. Not only that though, with less amniotic fluid, there's less space in the amniotic sac, and so the fetus is literally compressed into a smaller space, which causes developmental abnormalities like a flattened face, widely separated eyes with epicanthal folds, low-set ears, as well as limb abnormalities like clubbed feet. Taken together, this set of consequences from oligohydramnios is called Potter sequence, or sometimes Potter syndrome. It's worth mentioning that bilateral renal agenesis isn't the only thing that can cause Potter sequence. It can also be seen with other causes of oligohydramnios, like a blockage in the urinary tract, or occasionally prolonged rupture of membranes. In general, bilateral renal agenesis is incompatible with life outside the womb, and is therefore usually fatal within the first few days after birth. Although, depending on lung development and overall health, some newborns might be put on dialysis until they're strong enough to have a kidney transplant. Okay, so as a super short review, unilateral renal agenesis is where only one kidney develops, and is usually asymptomatic. And bilateral renal agenesis is where neither kidney develops, which results in oligohydramnios and the characteristic features of Potter sequence. With hypercalcemia, hyper means over and calc refers to calcium, and emia refers to the blood. So hypercalcemia means higher than normal calcium levels in the blood, generally over 10.5 milligrams per deciliter. Now, calcium exists as an ion with a double positive charge, Ca2+, and it's the most abundant metal in the human body. So I know what you're thinking. Yeah, we're all pretty much cyborgs. Anyways, about 99% of that calcium is in our bones in the form of calcium phosphate, also called hydroxyapatite. The last 1% is split so that the majority, about 0.99%, is extracellular, which means in the blood and in the interstitial space between cells, whereas 0.01% is intracellular, or inside cells. High levels of intracellular calcium causes cells to die. In fact, that's exactly what happens during apoptosis, also known as programmed cell death. For that reason, cells end up using a ton of energy just to keep their intracellular calcium levels low. Now, calcium gets into the cell through two types of channels, or cell doors, within the cell membrane. The first type are ligand-gated channels, which are what most cells use to let calcium in, and are primarily controlled by hormones or neurotransmitters. The second type are voltage-gated channels, which are mostly found in muscle and nerve cells and are primarily controlled by changes in the electrical membrane potential. So calcium flows in through these channels, and to prevent calcium levels from getting too high, Cells kick excess calcium right back out with ATP-dependent calcium pumps, as well as sodium-calcium exchangers. In addition, most of the intracellular calcium is stored within organelles like the mitochondria and the smooth endoplasmic reticulum, and is released selectively just when it's needed. Now, the majority of the extracellular calcium, the calcium in the blood and the interstitium, is split almost equally between two groups: calcium that's diffusible and calcium that's not diffusible. Diffusible calcium is separated into two subcategories: free ionized calcium, which is involved in all sorts of cellular processes like neuronal action potentials, contraction of skeletal, smooth, and cardiac muscle, hormone secretion, and blood coagulation, all of which are tightly regulated by enzymes and hormones. The other category is complex calcium, which is where the positively charged calcium is ionically linked to tiny negatively charged molecules, like oxalate, which is a small anion that's normally found in our blood in small amounts. The complex calcium forms a molecule that's electrically neutral, but unlike free ionized calcium, it's not useful for cellular processes. Both of these are called diffusible because they're small enough to diffuse across cell membranes. Finally, though, there's non-diffusible calcium, which is bound to negatively charged proteins like albumin. And the resulting protein-calcium complex is too large and charged to cross membranes, leaving this calcium also uninvolved in cellular processes. When the body's levels of extracellular calcium change, it's detected by a surface receptor in parathyroid cells called the calcium sensing receptor. This affects the amount of parathyroid hormone that gets released by the parathyroid gland. The parathyroid hormone gets the bones to release calcium and gets the kidneys to reabsorb more calcium so it's not lost in the urine, as well as synthesize calcitriol, also known as active vitamin D. Active vitamin D then goes on to cause the gastrointestinal tract to increase calcium absorption. Altogether, these effects help to keep the extracellular levels of calcium within a very narrow range, between 8.5 to 10 milligrams per deciliter. Sometimes, though, total calcium levels in the blood, which includes diffusible and non-diffusible, can vary a bit, depending on the blood's pH and protein levels. This happens because albumin has acidic amino acids, like glutamate and aspartate, and these have carboxyl groups that are in the form of COO- or COOH. Overall, the balance of COO- and COOH changes based on the pH of the blood. Now, when there's a low blood pH, or acidosis, there are lots of protons, or H+ ions, floating around. And a lot of those COO- groups pick up a proton and become COOH. More COOH groups means that albumin generally becomes more positively charged. And since calcium's positively charged, these two repel each other. And this decreases bound calcium and increases the proportion of free ionized calcium in the blood. So as more protons bind albumin, more free ionized calcium builds up in the blood. And so even though total levels of calcium are the same, there's less bound calcium and more ionized calcium, which, remember, is important for cellular processes, meaning that this can lead to symptoms of hypercalcemia. Also, though, any condition that results in hyperalbuminemia, or high albumin levels, causes there to be a higher concentration of protein-bound calcium, while free ionized calcium concentrations stay essentially the same due to hormonal regulation. This is therefore called false hypercalcemia, or pseudo-hypercalcemia, since the concentration of bound calcium increases, but the concentration of free ionized calcium stays the same. Even though this is rare, it can happen in people with dehydration, where albumin gets really concentrated. Now, true hypercalcemia might be caused by increased osteoclastic bone resorption, which is actually the most common cause. And this is where osteoclasts, which are little bone-eating cells, frantically break down the bone and release calcium into the blood. This might happen when the parathyroid gland becomes overgrown and releases more parathyroid hormone. Another well-known cause of hypercalcemia are malignant tumors, some of which secrete parathyroid hormone-related protein, or PTHrP, a hormone that mimics the effect of parathyroid hormone, which stimulates the osteoclasts. Alongside these osteoclast cells, there are also osteoblast cells, which are bone-building cells, and some tumors cause osteoblasts to die off. Overstimulated osteoclasts without enough osteoblasts can result in lytic bone lesions, which are commonly seen in some malignancies. Another cause of hypercalcemia is excess vitamin D, either through the diet or through supplements, which can cause there to be too much calcium absorbed in the gut. Finally, there are some medications, like thiazide diuretics, which increases calcium reabsorption in the distal tubule of the kidney, which contributes to hypercalcemia. High levels of ionized calcium affect a variety of cellular processes, in particular electrically active neurons. Normally, calcium ions stabilize the resting state of the sodium channels, which prevents them from spontaneously opening and letting sodium ions enter the cell. With high levels of extracellular calcium, voltage-gated sodium channels are less likely to open up, which makes it harder to reach depolarization and makes the neuron less excitable. And this is what causes slower or absent reflexes, which is a classic symptom of hypercalcemia. The sluggish firing of neurons also leads to slower muscle contraction, which causes constipation and generalized muscle weakness. In the central nervous system, hypercalcemia causes confusion, hallucinations, and stupor. In most cases, when there's too much calcium in the blood, the kidneys try to dump it into the urine, causing hypercalciuria, or excess calcium in the urine. Hypercalciuria leads to a loss of excess fluid in the kidneys, causing an individual to get dehydrated. And the combination of hypercalciuria and dehydration can lead to calcium oxalate kidney stones. Hypercalcemia is diagnosed based on high levels of calcium in the blood, generally above 10.5 milligrams per deciliter. An electrocardiogram might have changes like tachycardia, AV block, shortening of the QT interval, and sometimes in precordial leads the appearance of an Osborn wave. To identify the cause, lab tests are typically done, looking at parathyroid hormone, vitamin D, albumin, phosphorus, and magnesium levels. In hypercalcemia, the main goal is to lower calcium levels using medications that reduce calcium in the blood. One approach is to increase urinary excretion of calcium, which can be done by rehydrating an individual, which causes more calcium to get filtered out. In addition, loop diuretics can be helpful because they inhibit calcium reabsorption in the loop of Henle, leaving calcium in the lumen of the nephron to get excreted. Another approach is to increase gastrointestinal excretion by using glucocorticoids to decrease intestinal calcium absorption, which allows it to instead simply pass through the gut without getting absorbed. Finally, you can prevent bone resorption by using biphosphonates, or calcitonin, to inhibit osteoclasts. Alright, as a quick recap, hypercalcemia describes a high concentration of free ionized calcium in the blood, which most commonly results from excess parathyroid hormone, as well as malignancies. High calcium levels cause excitable cells to be less excitable, which results in slow reflexes, muscle weakness, and constipation.
With hyperkalemia, there's too much potassium in the extracellular fluid, generally over 5 milliequivalents per liter. Common causes include metabolic acidosis, a hyperglycemic hyperosmolar state, the use of medication, like potassium-sparing diuretics, and tissue breakdown, like with a crush injury. In addition, individuals with acute or chronic kidney disease can develop hyperkalemia when there's a high potassium intake. Hyperkalemia is often asymptomatic, but it can cause symptoms like palpitation, paresthesias, and muscle weakness. Ultimately, if hyperkalemia is severe enough, it can lead to a flaccid paralysis that starts in the lower extremities and spreads upward. In addition, severe hyperkalemia can affect renal function, causing a person to become oliguric, meaning their daily urine output can fall below 400 milliliters. When potassium levels are above 5 milliequivalents per liter, the first thing to do is an EKG. If the EKG is normal and the individual doesn't have symptoms of hyperkalemia, and if there's no apparent cause of hyperkalemia, then it may be due to pseudohyperkalemia. This happens when potassium moves out of the cell during or after a blood draw. For example, potassium gets released from muscle cells during muscle contraction. So, if a person repeatedly clenches their fists during the blood draw, then potassium levels can rise. In fact, they can go up by up to 2 milliequivalents per liter in that forearm. Also, during blood drawing, some of the red cells can be harmed and release potassium. Pseudohyperkalemia can also happen when there's thrombocytosis or leukocytosis. For example, in chronic lymphocytic leukemia, the lymphocytes are frail, so they break easily and release potassium. The key is to simply repeat the serum potassium level and to obtain a CBC. If pseudohyperkalemia is ruled out, then there's a true hyperkalemia. There may be EKG changes, but they don't always correlate with the severity and progression of the disease. Oftentimes, a potassium level between 6 and 7 milliequivalents per liter will cause peak T waves with a narrow base in the precordial leads V1 through V6. A potassium level between 7 and 8 milliequivalents per liter can cause even taller T waves and a prolonged PR interval, so a first-degree atrioventricular block, flattened P waves, a depressed ST segment, and a wide QRS complex. When the potassium level goes above 8 milliequivalents per liter, the T waves get even taller, the QRS complex gets wider, and there's no P wave anymore. Eventually, the EKG shows a sinusoid wave pattern, and a person can die of ventricular fibrillation. But given that these cardiac changes don't align perfectly to the level of hyperkalemia, everyone with hyperkalemia should be continuously monitored because ventricular fibrillation can occur anytime. In addition to an EKG, a basic metabolic panel is done to identify the cause of hyperkalemia. This includes a BUN, creatinine, bicarbonate, glucose levels, serum potassium, sodium, calcium, and chloride. In renal impairment, the BUN levels can go above 20 milligrams per deciliter. Based on creatinine, age, gender, and sometimes weight and height, the estimated glomerular filtration rate, or EGFR, is calculated. With mild renal impairment, EGFR is between 60 and 90 milliliters per minute per 1.73 square meters. With moderate renal impairment, EGFR is between 30 and 60 milliliters per minute per 1.73 square meters, and with severe renal impairment, EGFR is below 30 milliliters per minute per 1.73 square meters. With a hyperglycemic hyperosmolar state, there can be glucose levels as high as 800 milligrams per deciliter. When sodium levels are below 135 milliequivalents per liter, or calcium levels are below 8.5 milligrams per deciliter, the cardiac effects of hyperkalemia are precipitated. If there's metabolic acidosis, then bicarbonate levels are below 22 milliequivalents per liter. In that situation, an ABG can be done. In metabolic acidosis, it would show a pH below 7.35 and a bicarbonate, or HCO3 level, below 22 milliequivalents per liter. In order to find the cause of metabolic acidosis, the anion gap will be calculated using serum sodium, chloride, and bicarbonate. One cause of metabolic acidosis is diabetic ketoacidosis, and typically the glucose levels are above 350 milligrams per deciliter. Now, if an individual has symptoms or EKG changes, or if serum potassium is over 6.5 milliequivalents per liter, then treatment is started right away. Another emergency is when the serum potassium is between 5.5 milliequivalents per liter and 6.4 milliequivalents per liter, and the person has renal impairment and ongoing tissue breakdown, like in the aftermath of a crush injury. After the initiation of therapy, serum potassium needs to be monitored every 2 hours. Individuals should be given IV calcium gluconate, 10 milliliters over 3 minutes, in order to protect the cardiac muscle. And this can be repeated every 30 to 60 minutes if hyperkalemia persists. Rapid-acting therapies can help move potassium back into the cells. This doesn't lower total body potassium, but moving the potassium out of the serum and into the cells helps stabilize the cardiac muscle. One way to do this is to give 10 to 20 units of regular insulin in 500 milliliters of 10% dextrose intravenously over 60 minutes. The effect of insulin begins in 20 minutes and can last for 6 hours, and over that time the potassium can drop by 0.5 to 1.2 milliequivalents per liter. Blood glucose is measured every hour for about 6 hours after initiation of insulin therapy. Beta-2 adrenergic agonists like nebulized albuterol can be given to help shift potassium into the cells. In metabolic acidosis, the body tries to raise the pH by getting the excess hydrogen ions to enter the cells. That's done by exchanging them with potassium ions, which leave the cells and enter the blood to maintain electroneutrality, resulting in hyperkalemia. So, in hyperkalemia, if there's associated metabolic acidosis with a pH level below 7.1, then sodium bicarbonate can be given as well. Now, to remove potassium from the body, there are a few options. In individuals without renal impairment, loop diuretics like furosemide can be used to dump more potassium into the urine. To prevent dehydration in euvolemic or hypovolemic individuals, isotonic saline solution can be used. In hypervolemic individuals, isotonic saline isn't needed. In individuals with impaired renal function, furosemide can be dose adjusted for renal function and can be given with isotonic saline solution. Another option for removing potassium is the use of gastrointestinal cation exchangers. One exchanger is pataromer, which binds potassium in the colon in exchange for calcium, and can be given orally or through an enema. If pataromer is not available, then Kayexalate can be used instead. Kayexalate binds potassium in exchange for sodium or calcium, and can also be given orally or through an enema. Finally, in individuals with severe renal impairment, hemodialysis may be needed. Usually, if dialysis cannot be done within 6 hours, then gastrointestinal cation exchangers are used until hemodialysis can be done. Now, if serum potassium is between 5.5 and 6.4 milliequivalents per liter, and the individual doesn't have any symptoms or EKG changes, but does have severe renal impairment, then the potassium needs to be lowered within 12 hours, and it can be done using hemodialysis. If hemodialysis is not available within 12 hours, then a gastric cation exchanger can be used until it is. Finally, if serum potassium is between 5 and 5.4 milliequivalents per liter, and the individual doesn't have any symptoms or EKG changes, then potassium can be lowered through dietary modifications. These individuals should avoid foods that are rich in potassium, especially fruits, like bananas, oranges, watermelons, and vegetables, like eggplants, peas, and potatoes. Now, this is the one time when we're going to say it's not a good idea to eat all your fruits and vegetables, at least for a little while. In addition, if the individual is hypertensive or hypervolemic, then loop diuretics can be used. If serum potassium remains elevated in spite of dietary changes, then pataromer can be given until the underlying cause of hyperkalemia is identified. Now, there are many underlying causes of hyperkalemia. It can be due to both acute and chronic kidney disease because both can impair potassium excretion. With acute kidney injury, some associated clues include oliguria, volume overload, uremia, and metabolic acidosis. With chronic kidney disease, some associated clues include oliguria or anuria and uremia in advanced stages. Treatment of these underlying conditions depends on the stage of the renal disease. In both diabetic ketoacidosis or hyperglycemic hyperosmolar state, there's insulin deficiency, which leads to hyperglycemia and hyperosmolality. The hyperosmolality pulls water out of the cells, and the loss of water in the cells raises the intracellular potassium concentration, creating a potassium gradient so that it leaves the cells as well. Since there's not enough insulin to stimulate the sodium-potassium pump, which normally pushes potassium back into the cells, the potassium levels climb. Individuals are usually dehydrated and have nausea, vomiting, and even mental status changes. Also, a lot of the potassium gets lost through urine, So total body potassium is low, even though they may initially have hyperkalemia. Treatment of uncontrolled diabetes relies on giving plenty of fluids, which helps with dehydration, and insulin, which helps lower blood glucose levels, both of which help reverse the acidosis. Once the potassium is below 3.5 milliequivalents per liter, then IV potassium chloride is given. After that, a long-acting insulin like glargine or detamir can be given subcutaneously. Now, hyperkalemia can also be caused by certain medications. Some examples include potassium-sparing diuretics, like spironolactone. Potassium-sparing diuretics induce mineralocorticoid or aldosterone resistance, either by competing with aldosterone for receptor sites, like spironolactone, or by directly blocking the sodium channels in the collecting tubule, like amiloride. Some medications induce hyperreninemic hypoaldosteronism by blocking the renin-angiotensin-aldosterone system at different levels, such as ACE inhibitors, like enalapril, and angiotensin II receptor blockers, or ARBs, like candesartan. Other medications induce hyporeninemic hypoaldosteronism, such as NSAIDs, like aspirin, and calcineurin inhibitors, like cyclosporine or tacrolimus. In rare cases, beta blockers, like propranolol, cause hyperkalemia because they interfere with beta-2 adrenergic activity, which slows potassium entering the cells. This is particularly relevant in individuals with renal impairment because the excess potassium isn't excreted properly. The key here is stopping the offending medication until renal function is normal. Now, if the cause of hyperkalemia is due to ongoing tissue breakdown, like with a crush injury associated with rhabdomyolysis, then the individual will also have muscle pain and dark urine. Blood tests would show high levels of creatinine kinase, and urinalysis would show myoglobinuria. To prevent acute kidney injury, it's important to give isotonic saline and sodium bicarbonate. Radiation or cytotoxic therapy for leukemia or lymphoma can cause tumor lysis syndrome, which can also lead to hyperkalemia. In addition, there's hyperuricemia, hyperphosphatemia, and hypocalcemia as well. Another cause of hyperkalemia is primary adrenal insufficiency, or Addison's disease, which is when the adrenal glands are unable to make sufficient cortisol and aldosterone. This leads to hyperreninemic hypoaldosteronism, because the low levels of aldosterone will stimulate renin secretion. Primary adrenal insufficiency can be acute or chronic. When acute, it's called adrenal crisis, and there's usually a dramatic clinical picture, with hypotension or shock, vomiting, abdominal pain, fever, and mental status changes. The chronic presentation is nonspecific, with fatigue, weight loss, abdominal pain, muscle, and joint pain. Diagnosis is confirmed by a high serum ACTH, low serum cortisol, and low aldosterone levels, and high levels of renin. Replacement treatment with fludrocortisone should be started, with a daily dose of 50 to 100 micrograms. Hyperkalemia can sometimes be iatrogenic. One example is when too much potassium is given to treat hypokalemia, and the pendulum swings too far the other way. Another example is when excess mannitol is given for a brain injury. The mannitol causes hyperosmolality, which pulls water out of the cells and increases the potassium gradient, leading to hyperkalemia. This usually happens when there's also renal impairment. If acute kidney injury develops, then hemodialysis is needed to remove the excess mannitol. Finally, a rare case of hyperkalemia is hyperkalemic periodic paralysis, which is a genetic disorder where a mutation causes the sodium channels to remain open longer. The result is that there are more positive sodium ions in the cell, and as a result of that, more potassium is pushed out of the cell to maintain electroneutrality. Individuals can have brief episodes of muscle weakness and paralysis precipitated by triggers like the cold, exercise, fasting, or the ingestion of excess potassium. Usually potassium levels are normal or only slightly elevated, so the diagnosis is made during an acute attack using electromyography and genetic testing. Treatment of an acute attack is generally not necessary as they're so brief, but they can be prevented by avoiding triggers. Alright, as a quick recap, hyperkalemia is a potassium level above 5 milliequivalents per liter, and it can be asymptomatic, or cause symptoms like palpitations, muscle weakness, and paralysis. First, an EKG is done. EKG abnormalities include peaked T waves with a narrow base, as well as a shortened QT interval and ST segment depression. A based metabolic panel is done to assess renal function and determine eGFR, electrolytes like sodium, potassium, calcium, and chloride, glucose, and bicarbonate. If serum potassium is above 6.5 milliequivalents per liter, or if there are symptoms and EKG abnormalities, or if there's ongoing tissue breakdown and renal impairment, then treatment is started right away. IV calcium gluconate is used, along with insulin plus glucose and inhalatory beta-2 adrenergic agonists, and bicarbonate if there's metabolic acidosis and the pH is below 7.1. To remove potassium from the body, in individuals without renal impairment, loop diuretics like furosemide can be used. Another option is gastrointestinal cation exchangers, like patoromer or Kxalate. In individuals with severe renal impairment, hemodialysis is used. If potassium is between 5.5 and 6.4 milliequivalents per liter, but there are no symptoms or EKG abnormalities, but there is renal impairment, then potassium can be lowered within 12 hours using hemodialysis or gastric cation exchanger if hemodialysis isn't available right away. If potassium is between 5 and 5.4 milliequivalents per liter, then potassium can be lowered slowly through dietary modifications by avoiding foods that are rich in potassium. In hypertensive or hypervolemic patients, loop diuretics are used. If serum potassium remains the same, then the individual can receive patoromer chronically.
With hyperkalemia, hyper means over and cal refers to potassium, and emia refers to the blood. So hyperkalemia means higher than normal potassium levels in the blood, generally over 5.5 milliequivalents per liter. Now, total body potassium can essentially be split into two components, intracellular and extracellular potassium, or potassium inside and outside cells, respectively. The extracellular component includes both the intravascular space, which is the space within the blood and lymphatic vessels, and the interstitial space, the space between cells where you typically find fibrous proteins and long chains of carbohydrates, which are called glycosaminoglycans. Now, the vast majority, around 98%, of all the body's potassium is intracellular, or inside of the cells. In fact, the concentration of potassium inside the cells is about 150 milliequivalents per liter, whereas outside the cell it's only about 4.5 milliequivalents per liter. Keep in mind that these potassium ions carry a charge, so the difference in concentration also leads to a difference in charge, which establishes an overall electrochemical gradient across the cell membrane. And this is called the internal potassium balance. This balance is maintained by the sodium-potassium pump, which pumps 2 potassium ions in for every 3 sodium ions out, as well as potassium leak channels and inward rectifier channels that are scattered throughout the membrane. This concentration gradient is extremely important for setting the resting membrane potential of excitable cell membranes, which is needed for normal contraction of smooth, cardiac, and skeletal muscles. Also, though, in addition to this internal potassium balance, there's also an external potassium balance, which refers to the potassium you get externally through the diet every day. On a daily basis, the amount of potassium that typically gets taken in usually ranges between 50 milliequivalents per liter to 150 milliequivalents per liter, which is way higher than the extracellular potassium concentration of 4.5 milliequivalents per liter. So your body has to figure out a way to excrete most of what it takes in. This external balancing act is largely taken care of by the kidneys, where excess potassium is secreted into a renal tubule and excreted in the urine. Also, though, a small amount of dietary potassium is also lost via the gastrointestinal tract and the sweat. So, in order for there to be too much potassium in the blood, or hyperkalemia, there are two possibilities. The first is an external balance shift, which is most often caused by a decrease in potassium excretion in the kidneys, which raises the level of potassium in the blood. The second is an internal balance shift, where potassium moves out of cells and into the interstitium and blood. One potential cause of an internal potassium balance shift is insulin deficiency. This is because after a meal, glucose increases in the blood, and at the same time insulin is released, which binds the cells and stimulates the uptake of that glucose. Insulin also increases the activity of the sodium-potassium pump, which pulls potassium into cells. People with type 1 diabetes don't make enough insulin, so when they eat a meal, especially a meal with a lot of potassium, that potassium sits in the blood instead of being taken into cells, and this causes hyperkalemia. Another cause of an internal potassium balance shift could be an acidosis, which is when the blood becomes too acidic. In other words, there's a higher concentration of hydrogen ions, which means a lower blood pH. One way the body can increase the blood pH is by moving hydrogen ions out of the blood and into cells. To accomplish this, cells use a complex series of multiple ion channels, exchangers, and pumps to exchange hydrogen ions for potassium ions across the cell membrane. So in order to help compensate for an acidosis, hydrogen ions enter cells and potassium ions leave the cells and enter the blood, which might help with the acidosis but results in hyperkalemia. Now, this isn't always the case for acidosis, though. For example, in respiratory acidosis, potassium levels aren't affected because CO2 is lipid soluble and freely moves into cells without being exchanged for potassium. Therefore, no hyperkalemia. Similarly, when there's a metabolic acidosis from excess organic acids like lactic acid and keto acids, protons can enter cells with the organic anion rather than having to get exchanged for potassium ions. Certain catecholamines can also shift potassium out of cells, and this is via beta-2 adrenergic and alpha-adrenergic receptors on cell membranes. When activated, beta-2 adrenergic receptors stimulate the sodium-potassium pump, which pulls potassium from the blood into cells. Meanwhile, alpha-adrenergic receptors cause a shift of potassium out of cells via calcium-dependent potassium channels. So that said, beta-2 adrenergic antagonists, also known as beta blockers, and alpha-adrenergic agonists both cause a shift in potassium out of the cells and into the blood. Another important mechanism is hyperosmolarity, which is where there's an increased extracellular osmolarity relative to the intracellular space. This osmotic gradient pulls water out of cells and into the extracellular space. Less water in the cells increases the intracellular potassium concentration, which increases potassium's concentration gradient and pushes more of it out of the cell and into the interstitium and blood. Cell lysis is yet another cause of hyperkalemia. Since so much potassium is kept within the cell, when a large number of cells die or lyse, potassium is released into the blood, which causes hyperkalemia. Examples of large-scale cell lysis are severe burns, rhabdomyolysis or breakdown of skeletal muscle, and tumor lysis as a result of chemotherapy. A final example of internal potassium balance leading to hyperkalemia is exercise. During exercise, while the body and the body's cells are working harder, more cellular ATP, which is the molecular unit of currency, gets consumed. The depletion of ATP triggers potassium channels on the membrane of muscle cells to open up, which allows potassium to move down its electrochemical gradient and out of the cell. Usually this shift is small, but if combined with beta blockers or kidney issues, strenuous exercise can lead to hyperkalemia. Alright, on to external potassium balance shifts resulting in hyperkalemia, which has to do with potassium intake and excretion. That said, simply taking in too much potassium can lead to hyperkalemia, but this would typically be from rapid, excessive infusion of potassium into the bloodstream, like in patients receiving intravenous fluids. And this would be considered an iatrogenic cause, which means that it results from a medical treatment or procedure. Most other cases, though, have to do with the kidneys and their ability to regulate what stays in the blood and gets excreted into the urine. The kidney does this by the processes of filtration, reabsorption, and secretion in the nephron. First off, potassium is freely filtered from the blood into the urine at the glomerulus. After that, about 67% is reabsorbed in the proximal convoluted tubule, and an additional 20% is reabsorbed in the thick ascending limb. And that leaves about 13% of the initial amount, right? And at this point, the distal tubule and collecting ducts of the nephron can either reabsorb or secrete potassium depending on what the body needs. Now, reabsorption in this area is taken care of by the alpha intercalated cells, while secretion is controlled by the principal cells. Typically, for people on a normal diet, more potassium is secreted than reabsorbed at this stage, and it could even be that all of the remaining potassium is secreted out if it's simply not needed. Now, an important hormone that helps regulate potassium reabsorption or secretion in the kidneys is aldosterone. Aldosterone increases the number of sodium channels and the number of potassium channels on the lumen side of the principal cell, as well as sodium-potassium pumps on the basolateral side of the principal cells. This allows sodium to move from the tubule into the cell, and then get pumped into the blood by the sodium-potassium pumps. As the pumps collectively move more sodium into the blood under the influence of aldosterone, more potassium gets pumped into the cell, which raises the intracellular potassium concentration. Having more intracellular potassium and also having more potassium channels promotes potassium secretion. All that being said, in situations where somebody's unable to produce enough aldosterone, or hypoaldosteronism, also known as adrenal insufficiency, then there's less potassium secretion by the principal cells, and therefore more potassium is retained, which leads to hyperkalemia. Along the same lines, drugs that reduce the effect of aldosterone can also cause hyperkalemia, and these are drugs like renin inhibitors, ACE inhibitors, angiotensin II receptor antagonists, selective aldosterone blockers, and potassium-sparing diuretics. Now, acute kidney injury can cause a low glomerular filtration rate, which is the volume of blood filtered through the kidney over a period of time. And this can lead to oliguria and hyperkalemia. In these situations, the nephron tries to hold on to salt and water. So by the time the filtrates moved into the distal tubule, there's very little of both sodium and water remaining in the lumen. Having little water in the lumen creates a relatively high potassium concentration in the lumen. In addition to this, because less sodium's in the distal tubule, less of it moves through the luminal sodium channel into the principal cell, and gets pumped over to the other side by the basolateral sodium-potassium pump. And this means less potassium gets into the principal cell, and this leads to more potassium in the blood and hyperkalemia. Alright, so there are all these ways to develop hyperkalemia. But what happens when somebody has hyperkalemia? Well, remember that the concentrations of potassium inside and outside the cells is really super important for maintaining the resting cell membrane potential, and ultimately for allowing a cell to depolarize and a muscle to contract. And that includes all muscles, skeletal, smooth, and cardiac. So with too much potassium outside the cell, the membrane potential can become more positive, to the point of even causing contraction. Initially, this might cause mild intestinal cramping, but eventually the resting membrane potential gets so high that it's above the threshold potential, meaning that once the muscle depolarizes and contracts, it can't repolarize to allow another contraction. In skeletal muscles, this can cause weakness and flaccid paralysis that starts in the lower extremities and ascends upward. Hyperkalemia, though, also affects cardiac muscle contractions, which can lead to cardiac arrhythmias and cardiac arrest. Hyperkalemia is diagnosed based on the presence of elevated potassium levels in the blood, generally over 5.5 milliequivalents per liter. It's also important to get an electrocardiogram, which typically shows tall, peaked T waves with a narrow base, best seen in the precordial leads V1 through V6, as well as a shortened QT interval and ST segment depression. In severe cases, it can also cause a prolonged PR interval, a diminished or absent P wave, and a widened QRS complex. With severe hyperkalemia, treatment might be done by using calcium to stabilize the myocardial cell membrane, using insulin, glucose, beta-adrenergic agonists, and sodium bicarbonate to shift potassium into the intracellular space, using resins that bind potassium to promote potassium elimination in the gastrointestinal tract, using potassium-wasting diuretics to promote potassium elimination in the kidneys, and in severe cases, dialysis. Alright, as a quick recap, hyperkalemia describes a high concentration of potassium in the blood, which can be the result of shifts in internal potassium balance where potassium moves out of the body's cells, as well as external potassium balance problems having to do with the intake of potassium and typically the kidney's ability to regulate its excretion. Either way, the high potassium leads to issues with muscle contractions, which can be issues with the smooth, skeletal, or cardiac muscles. With hypermagnesemia, hyper means over, and magnes refers to magnesium, and emia refers to the blood. So hypermagnesemia means higher than normal magnesium levels in the blood, and symptoms typically develop at levels over 4 milliequivalents per liter. An average adult has about 25 grams of magnesium in their body. About half is stored in the bones, and most of the other half is found within cells. In fact, magnesium is a really common positively charged ion found within the cell, second only to potassium. A very tiny fraction, roughly 1% of the total magnesium in the body, is in the extracellular space, which includes both the intravascular space, the blood vessels and lymphatic vessels, and the interstitial space, the space between cells. About 20% of the magnesium in the extracellular space, which would be about 0.2% of total magnesium, is bound to negatively charged proteins like albumin, but the other 80% or 0.8% of total magnesium can be filtered into the kidneys. So inside the kidney, that magnesium gets filtered into the nephron, and about 30% gets reabsorbed at the proximal convoluted tubule, 60% gets reabsorbed in the ascending loop of Henle, and 5% gets reabsorbed at the distal convoluted tubule. And that leaves only about 5% to get excreted in the urine. So, in order for there to be too much magnesium in the blood, this normal balance has to be disturbed. The most common reason is when those nephrons in the kidneys can't excrete magnesium properly, and so it starts to build up in the blood. And this can happen in renal failure, when the kidneys typically aren't able to excrete anything properly. Another cause of hypermagnesemia is ingesting more magnesium than the kidneys can excrete. Sometimes this can be due to an intravenous infusion of magnesium that isn't prepared right. Other times it can be due to a magnesium-containing medication like magnesium hydroxide, which can be used to treat symptoms like constipation and heartburn. If these medications are taken in excess over a long period of time, it can lead to hypermagnesemia. There are also some less common causes of hypermagnesemia. One of these is tumor lysis syndrome, which results from a large number of cancer cells dying at the same time, releasing their contents at the same time, which includes magnesium. Now, hypermagnesemia can cause some serious complications. At the neuromuscular junction, there are voltage-gated calcium channels on presynaptic neurons which need to open and let calcium in to cause the neuron to release neurotransmitter and ultimately cause muscle contraction. Under normal circumstances, magnesium seems to inhibit calcium influx a little bit, which actually helps stabilize the axon. But with too much magnesium floating around, it tends to inhibit calcium influx even more, which interferes with neurotransmitter release and ultimately slows muscle contraction. Also, normally the parathyroid hormone from the parathyroid gland usually stimulates calcium release into the blood. High levels of magnesium in the blood, though, seems to inhibit release of parathyroid hormone, which causes calcium levels to fall, leading to hypocalcemia, low calcium in the blood. Typically, the resulting hypocalcemia is transient and asymptomatic. Really high levels of magnesium also alter the electrical potential across the cardiac cell membrane, which can lead to cardiac arrhythmias like heart block and even asystole. Now, anytime hypermagnesemia is causing symptoms, the level of free magnesium ions in the blood is usually over 4 milliequivalents per liter. Treatment for those symptoms depends on the cause, and if it's due to excessive intake, then you'd want to interrupt the source. Because of the interaction with calcium, some of the symptoms of hypermagnesemia can be countered by injecting calcium, usually in the form of calcium gluconate, which acts as a physiological antagonist. Sometimes furosemide can be used to promote kidney excretion of magnesium, and hemodialysis can also be used in severe cases. Alright, as a quick recap, hypermagnesemia refers to elevated levels of magnesium in the blood, which usually causes symptoms once it's over 4 milliequivalents per liter. This can be caused by impaired excretion by the kidneys or by increased intake of magnesium. The high levels of magnesium antagonizes calcium and can lead to a neuromuscular blockade, which causes symptoms like vasodilation, muscle weakness, and even cardiac arrhythmias.
With hypernatremia, there's a higher than normal concentration of sodium in the blood, above 145 milliequivalents per liter. However, since the concentration of sodium depends on both sodium and water levels in the body, hypernatremia actually translates as too little water in the extracellular compartment. Okay, now remember that total body water is distributed either in the intracellular compartment, meaning inside the cells, or the extracellular compartment, meaning outside the cells. Now, both the intracellular and extracellular compartments have the same amount of solutes dissolved in that water, so the same osmolality. Normally between 275 and 290 milliosmoles per kilogram. Serum osmolality can be calculated using the formula twice the concentration of sodium measured in milliequivalents per liter plus the serum concentration of glucose divided by 18 measured in milligrams per deciliter plus BUN, which stands for blood urea nitrogen, divided by 2.8, also in milligrams per deciliter. So if you remember one thing from this formula, it should be that sodium is the major determinant of serum osmolality. Now, just to make matters more interesting, some of these solutes, like sodium and glucose, can't freely cross cell membranes, so they generate an osmotic pressure inside the compartment, which is a measurement of how likely it is that this compartment will draw water out of the other one. Normally, the intracellular and extracellular compartments are isotonic to each other, meaning they have the same concentration of osmotically active solutes. However, small variations in solute concentrations, like having more sodium in the extracellular compartment, can alter that equilibrium. So, water moves across cell membranes in order to restore the balance. Water moves according to the rules of osmosis, or from the hypotonic compartment, where there's more water, to the hypertonic compartment, where there's less water. And water does that until the two compartments once again become isotonic. So with hypernatremia, there is too much sodium in the extracellular fluid. This can happen because a person has gained more sodium than water or has lost more water than sodium. Sodium gain usually happens because of an iatrogenic overload, like in individuals who received hypertonic saline following a traumatic head injury or sodium bicarbonate solutions used for the treatment of metabolic acidosis. The other possibility is salt poisoning, which is a rare scenario. But if it is seen, it's typically in infants and young children who have been abused. Unreplaced water losses, on the other hand, are the most common clinical situation, and there are three possible sources: skin, gastrointestinal, and urinary losses. Let's start with the skin. Normally, some water is lost through the skin, either insensibly through transdermal diffusion or sensibly through sweating. Increased insensible water losses can occur in individuals with extensive burns who will lose a lot more water through transdermal diffusion. Increased sensible losses occur in situations like fever, exercise, and exposure to high temperatures. In both cases, hypernatremia can occur if the lost water is not replaced. Then we have the gastrointestinal losses, like vomiting or diarrhea, which can also result in hypernatremia if not enough water is administered. Finally, too much water can be lost through the kidneys because of an osmotic diuresis. This can happen because of uncontrolled diabetes mellitus when too much glucose builds up in the blood, during recovery from acute kidney failure when urea builds up, or during treatment with mannitol, an osmotic diuretic. But bear in mind that even though all of these situations can cause hypernatremia, they don't always cause hypernatremia because there's usually a physiologic compensatory response that lowers blood osmolality by engaging the hypothalamus and the pituitary, as well as the kidneys. The hypothalamus has osmoreceptors that sense changes in blood osmolality. One response to high blood osmolality is thirst, with the thirst center also being located in the hypothalamus. Another response is that the pituitary secretes antidiuretic hormone, or ADH, into the bloodstream. When that reaches the kidneys, ADH binds to specific V2 receptors, and this makes the kidneys retain more water in order to dilute the blood. So usually, for hypernatremia to develop, along with water loss or sodium gain, the physiologic compensation might be out of order as well. For example, there may be a hypothalamic lesion, insufficient ADH secretion, or a diminished thirst response, which is common in elderly individuals. In some people, a central nervous system lesion, like a tumor, may impair hypothalamic function more extensively, leading to both abolished thirst, called adipsia, and decreased ADH secretion. This condition is called adipsic diabetes insipidus, and individuals suffering from it are prone to repeatedly developing hypernatremia because they lack the appropriate physiologic compensation for it. Finally, while it may seem obvious, it's worth to mention that access to water and the ability to obtain and drink water are also crucial to prevent hypernatremia. So, this condition more frequently affects people who don't have access to drinking water, like those in extreme conditions or those who depend on others for fluids, like infants, individuals in the ICU, and the elderly in nursing homes. Diagnosing hypernatremia is fairly straightforward. A level of serum sodium higher than 145 milliequivalents per liter. Sodium is the major determinant of serum osmolality, so this also leads to high blood osmolality, usually over 300 milliosmoles per kilogram. Hypernatremia pulls water out of the cells, so it causes intracellular dehydration. Brain cells are particularly sensitive to water loss, so hypernatremia is mostly accompanied by neurological symptoms. Symptoms depend on the value of serum sodium, on whether it's acute hypernatremia, which develops within 48 hours, or chronic hypernatremia, which develops over more than 48 hours, and on the cause of hypernatremia. Acute hypernatremia causes neurological symptoms that range from lethargy, weakness, altered mental status, and irritability to severe symptoms like seizures and coma, with severe symptoms usually occurring with a serum sodium above 160 milliequivalents per liter. Acute hypernatremia rapidly pulls water out of the brain cells, so the brain as a whole shrinks, and this can rupture blood vessels and cause intracerebral and subarachnoid hemorrhages. This leads to focal neurological findings like muscle weakness or loss of sensation in the left arm or right leg. Chronic hypernatremia, on the other hand, causes milder symptoms because the process happens more gradually, and so there isn't the same rapid shift of water out of the brain tissue. Finally, depending on etiology, symptoms of hypernatremia may also include polyuria and polydipsia, like in hypervolemic causes like diabetes insipidus and osmotic diuresis, or signs of dehydration like orthostatic hypotension, decreased skin turgor, and dry mucous membranes like in gastrointestinal or skin losses of water. Sometimes the cause of hypernatremia is obvious, like when there's history of vomiting, diarrhea, excessive sweating, or extensive burns without proper fluid replacement. But if there's no clear cause, then volume status, urine osmolality, and sometimes urine sodium can help find it. If an individual is hypervolemic, they clinically present with edema, and the cause is most likely sodium overload. Since the kidneys function properly, they'll respond to the high serum sodium by retaining more water and eliminating more sodium. So urine will be concentrated, meaning urine osmolality is usually above 600 milliosmoles per kilogram. And urine sodium will be high, usually above 100 milliequivalents per liter, reflecting that the kidneys are doing their job and eliminating the excess sodium the best they can. Hypervolemic individuals, on the other hand, may present with signs of dehydration. However, subtle clinical signs of dehydration can make it hard to discriminate between hypovolemic and euvolemic individuals, so in practice, urine osmolality can help. When urine osmolality is higher than 600 milliosmoles per kilogram, that means the kidneys work properly and respond to the higher concentration of sodium by retaining more water and eliminating a low volume of concentrated urine, typically less than 500 milliliters per day. In this case, hypernatremia is most likely because of unreplaced digestive or skin losses. When urine osmolality is lower than 600 milliosmoles per kilogram, that means the kidneys can't retain water, and they eliminate dilute urine in spite of high serum sodium concentrations. So, in this case, the cause of hypernatremia is renal water loss. Depending on how dilute the urine is, exactly how low the osmolality, the cause can be either diabetes insipidus or osmotic diuresis. When urine osmolality is less than 300 milliosmoles per kilogram, the cause is most likely diabetes insipidus. To differentiate between central and nephrogenic diabetes insipidus, exogenous ADH is given. In central diabetes insipidus, the problem is that the pituitary does not secrete enough ADH, so in response to exogenous ADH, urine osmolality increases from below 300 milliosmoles per kilogram to above 750. In nephrogenic diabetes insipidus, on the other hand, the problem is that the V2 receptors in the kidneys don't respond to ADH, so urine osmolality stays below 300 milliosmoles per kilogram. When urine osmolality is between 300 and 600 milliosmoles per kilogram, the cause of renal water loss is more likely osmotic diuresis. But diabetes insipidus is still possible. To tell the two apart, we calculate the total solute excretion, which is the urine osmolality multiplied by the daily urine volume. Normally, total solute excretion ranges from 600 to 900 milliosmoles per day. A value higher than 900 milliosmoles per day is indicative of an osmotic diuresis. Some causes of osmotic diuresis include the medication mannitol, hyperglycemia due to diabetes mellitus, which means checking a blood glucose level, and an acute kidney injury, which can cause high urea levels. Finally, treating hypernatremia starts with estimating the total water deficit. Luckily, there's a formula for that. Total body water in liters times serum sodium divided by 140 minus 1, where total body water is estimated by multiplying weight in kilograms by 0.6 for men and by 0.5 for women, then administering intravenous fluids in order to correct the water deficit and thereby lower sodium levels. In individuals with acute hypernatremia, the entire water deficit should be replaced in less than 24 hours as such, intravenous 5% dextrose at a rate of 3 to 6 milliliters per kilogram per hour, monitoring serum sodium every 2 hours until it reaches 145 milliequivalents per liter. Then, the rate is lowered to 1 milliliter per kilogram per hour until sodium reaches 140 milliequivalents per liter. So, for example, let's say we're treating a 70 kilogram female with a sodium level of 150 milliequivalents per liter. The first step is calculating her total water deficit. That is her weight, 70 kilograms times 0.5, times her current sodium, which is 150 milliequivalents per liter, divided by her ideal sodium level, which is 140 milliequivalents per liter, minus 1. So that's 70 times 0.5 times 150 over 140 minus 1. So we get 35 times 1.07 minus 1, which is 35 times 0.07. That means a total water deficit of 2.45 liters. To correct that, we'll administer, say, 5 milliliters of 5% dextrose per kilogram per hour. Given that she's 70 kilograms, that's 350 milliliters per hour, and we'll monitor serum sodium every 2 hours until it reaches 145 milliequivalents per liter. Once it reaches 145, we administer 70 milliliters of 5% dextrose per hour until she gets back to a cozy serum sodium of 140 milliequivalents per liter. Bear in mind that sodium should be corrected by a maximum of 10 milliequivalents per liter per day. Any more than that risks the development of cerebral edema, where water rushes back into the cells and interstitial space of the brain, causing swelling. In individuals with chronic hypernatremia, intravenous 5% dextrose may be given at a rate of 1.35 milliliters per kilogram per hour, with a maximum correction of 10 milliequivalents per liter per day. In individuals with chronic hypernatremia who are stable, pure water may also be administered through a nasogastric tube to correct the water deficit. Finally, individuals with diabetes insipidus will also be started on lifelong treatment with desmopressin, an ADH analog. Alright, as a quick recap. Hypernatremia is defined by sodium concentration in the blood higher than 145 milliequivalents per liter. Most frequently, it's caused by unreplaced water losses, but it can also be caused by sodium gain. In a hypervolemic individual, the cause is sodium overload. In a dehydrated or euvolemic individual, the cause depends on the urine osmolality. A urine osmolality higher than 600 milliosmoles per kilogram points toward extrarenal losses, whereas urine osmolality lower than 60 milliosmoles per kilogram means renal losses, so either diabetes insipidus or osmotic diuresis. When urine osmolality is lower than 300 milliosmoles per kilogram, the individual has either central or nephrogenic diabetes insipidus. When urine osmolality is between 300 and 600 milliosmoles per kilogram, total solute excretion is calculated, with a value higher than 900 milliosmoles per kilogram per day pointing towards osmotic diuresis. Finally, treating hypernatremia relies on administering 5% dextrose or water through a nasogastric tube to correct the water deficit and lower serum sodium by a maximum of 10 milliequivalents per liter per day.
With hypernatremia, hyper means high, and natremium is Latin for sodium, often shortened just to Na+. And emia refers to the blood, so hypernatremia means a higher than normal concentration of sodium in the blood, generally above 145 milliequivalents per liter. The concentration of sodium depends on both sodium and water levels in the body. About 60% of our body weight comes from just water, and it basically sits in two places, or fluid compartments. A third of it is in the extracellular fluid, meaning outside the cells, and 2/3 of it is in the intracellular fluid, or inside cells. The extracellular fluid includes the fluid in blood vessels, lymphatic vessels, and the interstitial space, which is the space between cells that's filled with proteins and carbohydrates. Normally, the two compartments have the same osmolarity, which is the total solute concentration, and that lets water move freely between the two spaces. But the exact composition of the solutes differs quite a bit. The most common cation in the extracellular compartment is sodium, whereas in the intracellular compartment it's potassium and magnesium. The most common anion in the extracellular compartment is chloride, whereas in the intracellular compartment it's phosphate and negatively charged proteins. Of all of these, sodium is the ion that moves back and forth across cell membranes. And subtle changes in sodium concentration tilts the osmolarity balance in one direction or another, and that moves water as well. And this is why we say water follows sodium. So with hypernatremia, someone can have a high concentration of sodium in the extracellular fluid and therefore the blood by either losing more water than sodium or gaining more sodium than water. Either way, this increases the sodium concentration in the extracellular fluid, which draws water out of the cells. When hypernatremia develops over a long period of time, the cells get time to adapt and they start generating osmotically active particles, which end up preventing water from being lost via osmosis. When hypernatremia develops acutely, though, the cells get no time to adapt, and the loss of water leaves them shriveled up and can cause them to die. Now, there are several common causes of hypernatremia via water loss. All of us lose some free water every day without even realizing it. For example, through the sweat as well as through the moisture breathed out during normal breathing. Under normal conditions, though, this loss is replaced by the water we drink. But this balance can be tipped when you have a high fever or exercise a lot on a hot summer day. In those situations, you can have temporary hypernatremia, which is easily fixed by drinking lots of water. Another way that the body can lose free water is through the kidneys. When the nephrons of the kidneys filter blood and form urine, some of the water in the filtrate is reabsorbed in the distal convoluted tubule and the collecting duct. When you're dehydrated, the hypothalamus releases antidiuretic hormone, also called ADH or vasopressin, which acts on the receptors on the nephron to boost its ability to reabsorb water. So if there's brain damage affecting the part of the hypothalamus that controls the release of ADH, then ADH levels could fall and the nephron wouldn't absorb as much water, meaning more fluid gets lost and the urine becomes more dilute, and the sodium concentration in the blood gets more concentrated. This is called central diabetes insipidus, because the fault lies centrally in the hypothalamus. Another possibility is that the hypothalamus makes ADH normally, but the receptors in the kidneys stop responding to it. This time the fault is in the kidneys, so it's known as nephrogenic diabetes insipidus. Again, in this case, the urine becomes dilute and the sodium in the blood becomes more concentrated. Alternatively, there might be brain damage that only affects the thirst center in the hypothalamus, rather than the ADH secreting part of the hypothalamus. Here, the kidneys aren't losing water, but the person drinks too little water while still losing some through the sweat, again resulting in hypernatremia. In rare cases, when there's major damage to the hypothalamus, ADH may not get released and the thirst center might be destroyed, which means that the person will lose a lot of water in the urine and still won't feel thirsty, which is a dangerous combination. Instead of water loss, hypernatremia can also be caused by sodium gain. This happens most commonly when a patient in the hospital is given sodium intravenously to help increase their sodium level, and too much is given too quickly. Occasionally, this can also happen simply because somebody's diet has too much salt. In either situation, though, the kidneys usually do a good enough job of getting rid of too much sodium. So hypernatremia in this case only usually happens if there's also some sort of kidney dysfunction alongside them. Symptoms of hypernatremia are related to the underlying cause. For example, some patients might have signs of dehydration, whereas others might have signs of excess fluid in their tissues. Individuals with central or nephrogenic diabetes insipidus also have polydipsia, which means they drink a lot of water to make up for the losses. Long-standing hypernatremia typically causes fewer symptoms, because the cells have a chance to adjust, whereas acute hypernatremia can cause cell death, particularly in the central nervous system, which results in serious problems like an altered mental status, seizures, or even a coma. The first step to diagnosing hypernatremia is to figure out if a person's intravascular volume is low, or hypovolemic, or normal, or euvolemic. If a person is hypovolemic, they're usually drinking too little water or sweating a lot, like on a hot day. In this situation, the kidneys are trying to hold on to water by peeing out thick, concentrated urine with osmolality of over 600 milliosmoles per kilogram. At the same time, the kidneys are also trying to preserve sodium, so they have a urine sodium concentration of less than 20 milliequivalents per liter. If instead in a hypovolemic patient the kidneys aren't functioning right and are losing sodium, then the urine sodium concentration will be higher than 20 milliequivalents per liter. And this could be as a result of medications like osmotic and loop diuretics, or even as a result of a kidney disease. On the other hand, if a person is euvolemic, then it's usually because their kidneys are dumping water, like in diabetes insipidus. In this case, their urine osmolality is usually below 300 milliosmoles per kilogram, and they have a urine sodium concentration of less than 20 milliequivalents per liter. Treatment of hypernatremia depends on the underlying cause, but ultimately the goal is to reduce the sodium concentration. For central diabetes insipidus, desmopressin is usually given to make up for the lack of ADH in the blood. For nephrogenic diabetes insipidus, drugs like thiazide diuretics can be given to increase urine excretion of sodium. If intravenous fluids have to be given, it has to be done carefully to avoid complications like cerebral edema. Alright, as a quick recap, hypernatremia is an electrolyte disorder that describes a high concentration of sodium in the blood, which can be caused either by losing too much water or by gaining too much sodium. Either way, hypernatremia can cause water to shift out of the cells, and in severe cases it can cause brain cells to shrink and die. Diagnosing hypernatremia involves checking the volume status and measuring the urine osmolality, as well as the urine sodium concentration. Treatment generally involves slowly and carefully giving back free water to normalize the sodium concentration over time. With hyperphosphatemia, hyper means over, phosphat refers to phosphate, and emia refers to the blood. So hyperphosphatemia means having high phosphate levels in the blood, typically above 4.5 milligrams per deciliter. Now, phosphate is made up of one central phosphorus atom surrounded by 4 oxygen atoms in a tetrahedral arrangement, kind of like a mini pyramid, and has a charge of -3 and is written PO4 3-. In the body, about 85% of the phosphate is stored in the bones, where it combines with calcium to make a tough compound called hydroxyapatite, which is the stuff that makes bones hard. Of the remaining phosphate, a tiny amount is extracellular, or outside the cells, like in the blood. So this is the bit that gets measured. And the majority is intracellular, or inside cells, where it does all sorts of things. It's responsible for phosphorylation, where it binds to fats and proteins. It forms the high-energy bonds of adenosine triphosphate, or ATP, which is the most common energy currency in the cell. It's part of the DNA and RNA backbone that links individual nucleotides together. And it's also part of cellular signaling molecules like cyclic adenosine monophosphate, or CAMP. The bottom line is that phosphate's really important. Now, because most of phosphate's locked up with calcium in the bones, the levels of phosphate are heavily tied with the levels of ionized calcium in the body. If calcium levels fall, the 4 parathyroid glands buried within the thyroid gland release parathyroid hormone, which frees up both calcium and phosphate ions from the bones. It does this by stimulating osteoclasts, the cells that break down bone, to release hydrogen ions which dissolves the hard, mineralized hydroxyapatite. as soon as the positively charged calcium and negatively charged phosphate are released from the bones, they grab onto each other again, meaning that the ionized calcium level doesn't really go up much at all. These two then make their way to the nephron of the kidney, and at this point in the proximal convoluted tubule, phosphate usually gets reabsorbed back into the blood via sodium phosphate cotransporters. It turns out, though, that parathyroid hormone also shuts this down. So this means that phosphate's left in the lumen and eventually gets sent out in the urine. Now, that calcium's still in the lumen, but parathyroid hormone also affects the distal convoluted tubule and increases calcium reabsorption. So when the dust settles, as a result of parathyroid hormone, phosphate's lost in the urine while ionized calcium is kept in the blood. So ionized calcium levels rise and phosphate levels fall. With all that in mind, hyperphosphatemia can develop in a few ways. The first possibility is as a result of acute or chronic kidney disease. And to illustrate this, we'll use some numbers. So let's say normally the glomerular filtration rate, or GFR, which is the fluid filtered into the kidney per unit time, is 180 liters per day. And the phosphate concentration of that blood is 0.04 grams per liter. That means that 7.2 grams of phosphate get filtered per day. And let's say 90% of that gets reabsorbed, or 6.48 grams. That leaves 10%, or 0.72 grams, to get excreted per day. Now, with kidney disease, let's say the GFR falls to 28.8 liters per day, which means only 1.2 grams gets filtered, and only 0.12 grams gets excreted in a day. And so where there was 0.72 grams being excreted per day, now there's only 0.12 grams. And that means that the difference between these two stays in the blood every day. And this contributes to hyperphosphatemia. This number, 28.8 liters per day, or 20 milliliters per minute, is the point at which its thought excretion can't keep up with intake. In addition, the kidneys might be unable to reabsorb calcium, and so more gets excreted. Remember that in response to low calcium, the parathyroid gland releases parathyroid hormone. But since calcium just gets wasted, it keeps releasing parathyroid hormone. And this is called secondary hyperparathyroidism, because the primary problem is with the kidneys. This causes a continuous release of calcium and phosphate from the bones, kind of like an open tap. And while calcium is excreted due to impaired reabsorption, phosphate's reabsorbed due to impaired excretion. So phosphate ends up building up in the blood. To make matters worse, all this loss from the bones makes them thin and weak, which is part of a process called renal osteodystrophy, which describes the overall bone changes that happen in people with chronic kidney disease. Related to this is pseudo-hypoparathyroidism, which is where the kidneys simply don't respond to parathyroid hormone because of a genetic defect in the parathyroid hormone receptor. Since parathyroid hormone tells the kidneys to save calcium and get rid of phosphate, calcium again gets lost and phosphate builds up in the blood, following the same pattern as kidney disease, including thinning of the bones. Alright, so since, again, parathyroid hormone causes excretion of phosphate and reabsorption of calcium, then another cause of hyperphosphatemia is hypoparathyroidism, when the parathyroid glands don't produce enough parathyroid hormone in the first place. This results in the same situation of increased reabsorption of phosphate and decreased reabsorption of calcium. This can happen following a thyroid gland removal surgery where the parathyroids are accidentally taken out too, or radiation treatment for cancer of the head and neck. Also, people with the genetic disease DeGeorge syndrome are often born with parathyroid glands that are too small and can't produce enough parathyroid hormone. Alternatively, phosphate levels can rapidly increase in the blood from excessive intake and absorption through the gastrointestinal tract or bloodstream via intravenous fluids. One cause is taking too much of a phosphate-based laxative either orally or rectally as an enema. A final cause of hyperphosphatemia relates to the fact that most phosphate in the body is within the cells. Anytime a lot of cells die, the phosphate gets spilled into the bloodstream, causing hyperphosphatemia. This includes things like crush injuries, like when a piano falls on someone's legs, or tumor lysis syndrome, which is cancer treatment that causes lots of tumor cells to die all at once, or rhabdomyolysis, which is rapid destruction of skeletal muscle cells. Another situation is when living cells get affected by respiratory acidosis, which is when the carbon dioxide levels rise because a person isn't breathing or ventilating it out of the lungs quickly enough. That carbon dioxide can diffuse into a cell and react with water to form carbonic acid, which quickly breaks into a proton and bicarbonate. The bicarbonate goes back into the blood in exchange for a chloride ion, leaving behind a proton. And all this ends up lowering the cellular pH. Now, normally glycolysis in the cell uses up a lot of phosphate, but this lower pH in the cell tends to inhibit glycolysis. So as a result, the cells don't pull as much phosphate out of the blood, and this allows levels in the blood to rise. Somewhat similarly, in diabetic ketoacidosis, there are low levels of insulin, and although the exact mechanism is unclear, this reduces the amount of phosphate that cells extract from the blood, which causes it again to build up in the blood. In this case, though, it's a slower process, since there's also an osmotic diuresis, or increased urination, from the hyperglycemia, or high blood sugar. Mild hyperphosphatemia doesn't usually cause symptoms, but severe hyperphosphatemia can make neurons more excitable. This can trigger the spontaneous firing of neurons in tetany, or the involuntary contraction of muscles. This can end up causing Chvostek's sign, which is when the facial muscles twitch after the facial nerve is lightly finger-tapped 1 centimeter below the zygomatic process. It can also cause Trousseau's sign, which is where a blood pressure cuff occludes the brachial artery, and that pressure on the nerve is enough to make it fire, resulting in a muscle spasm that makes the wrist and metacarpophalangeal joints flex. It can also cause symptoms like tingling around the mouth, seizures, and bone pain. The high levels of phosphate also cause it to find and stick to calcium, which forms bone-like crystals containing calcium and phosphate in places that they shouldn't be, like just beneath the skin, in the walls of blood vessels, in the joints, or in the kidneys where they can form kidney stones. With long-term hyperphosphatemia, the whole kidney can eventually turn into bone, which is called nephrocalcinosis. In other words, flesh literally turning to bone. This widespread calcification of healthy tissues is called metastatic calcification. In this case, metastatic means that the tissue rapidly changes from one thing to another, rather than referring to cancer. Diagnosis of hyperphosphatemia is based on the phosphate levels being above 4.5 milligrams per deciliter. And treatment often involves decreasing phosphate intake. And this is accomplished by avoiding foods that contain a lot of phosphate, like dairy, meat, and soda. In other words, no more pepperoni pizza with Coke. To decrease the amount of phosphate that's absorbed from the gastrointestinal tract, people can be given medications called phosphate binders. Now, you can also try to increase excretion of phosphate. And in people with healthy kidneys, a combination of intravenous saline and a loop diuretic like furosemide can increase excretion. And this is called forced diuresis. And it essentially overwhelms the proximal convoluted tubule of the nephron with so much fluid that it's unable to reabsorb solutes, including phosphate. Alright, as a quick recap, hyperphosphatemia describes high phosphate levels in the blood, above 4.5 milligrams per deciliter. And this can result from increased absorption and intake, decreased excretion, or a shift of phosphate from the inside of cells to the bloodstream. High levels of phosphate ions in the blood also like to bind with calcium, which forms bone-like crystals, which can slowly turn into bony structures. What's happening, guys? Thanks for watching. That was a long one, so hopefully you stuck through it and learned a little bit about hyperphosphatemia. One exciting thing is that we're almost done with all the renal videos, which is really cool because there is a ton of them, and we're almost done. So once that's done, we can move on to another topic and start hashing those out. Other than that, special thanks goes to Charles B. Davis for writing the script with this one, as well as Rishi for editing the script. I did the audio as well as the illustrations. One other thing I want to let you guys know about, if you want to quiz yourself on this material, you should head over to osmosis.org. It's kind of like our website. We have quiz questions as well as flashcards and a ton of other stuff. So if you have time, go check that out. Otherwise, you can support us by donating on Patreon, subscribing to our channel, and following us on social media. All right, guys. See you later. With hypocalcemia, hypo means below, calc refers to calcium, and emia refers to the blood. So hypocalcemia means lower than normal calcium levels in the blood, generally less than 8.5 milligrams per deciliter. Now, calcium exists as an ion with a double positive charge, Ca2+, and it's the most abundant metal in the human body. So I know what you're thinking. Yeah, we're all pretty much cyborgs. Anyways, about 99% of that calcium is in our bones in the form of calcium phosphate, also called hydroxyapatite. The last 1% is split so that the majority, about 0.99%, is extracellular, which means in the blood and in the interstitial space between cells, whereas 0.01% is intracellular, or inside cells. High levels of intracellular calcium causes cells to die. In fact, that's exactly what happens during apoptosis, also known as programmed cell death. For that reason, cells end up using a ton of energy just to keep their intracellular calcium levels low. Now, calcium gets into the cell through two types of channels, or cell doors, within the cell membrane. The first type are ligand-gated channels, which are what most cells use to let calcium in, and are primarily controlled by hormones or neurotransmitters. The second type are voltage-gated channels, which are mostly found in muscle and nerve cells and are primarily controlled by changes in the electrical membrane potential. So calcium flows in through these channels, and to prevent calcium levels from getting too high, cells kick excess calcium right back out with ATP-dependent calcium pumps, as well as sodium-calcium exchangers. In addition, most of the intracellular calcium is stored within organelles like the mitochondria and the smooth endoplasmic reticulum, and is released selectively just when it's needed. Now, the majority of the extracellular calcium, the calcium in the blood and the interstitium, is split almost equally between two groups: calcium that's diffusible and calcium that's not diffusible. Diffusible calcium is separated into two subcategories: free ionized calcium, which is involved in all sorts of cellular processes like neuronal action potentials, contraction of skeletal, smooth, and cardiac muscle, hormone secretion, and blood coagulation, all of which are tightly regulated by enzymes and hormones. The other category is complex calcium, which is where the positively charged calcium is ionically linked to tiny negatively charged molecules, like oxalate, which is a small anion that's normally found in our blood in small amounts. The complex calcium forms a molecule that's electrically neutral, but unlike free ionized calcium, it's not useful for cellular processes. Both of these are called diffusible because they're small enough to diffuse across cell membranes. Finally, though, there's non-diffusible calcium, which is bound to negatively charged proteins like albumin, and the resulting protein-calcium complex is too large and charged to cross membranes, leaving this calcium also uninvolved in cellular processes. When the body's levels of extracellular calcium change, it's detected by a surface receptor in parathyroid cells called the calcium sensing receptor. This affects the amount of parathyroid hormone that gets released by the parathyroid gland. The parathyroid hormone gets the bones to release calcium and gets the kidneys to reabsorb more calcium so it's not lost in the urine, as well as synthesize calcitriol, also known as active vitamin D. Active vitamin D then goes on to cause the gastrointestinal tract to increase calcium absorption. Altogether, these effects help to keep the extracellular levels of calcium within a very narrow range, between 8.5 to 10 milligrams per deciliter. Sometimes, though, total calcium levels in the blood, which includes diffusible and non-diffusible, can vary a bit, depending on the blood's pH and protein levels. This happens because albumin has acidic amino acids, like glutamate and aspartate, and these have carboxyl groups that are in the form of COO- or COOH. Overall, the balance of COO- and COOH changes based on the pH of the blood. When there's a high pH or alkalosis, there are very few protons floating around, and so those carboxyl groups tend to be in the COO- form. More COO- groups tend to make albumin more negatively charged, and since calcium's positively charged, opposites attract, and the negatively charged albumin latches onto calcium, which means there's more bound calcium and less free ionized calcium in the blood. And so even though the total levels of calcium are the same, there's less ionized calcium, which is the one that's important for cellular processes and can lead to symptoms of hypocalcemia. Also, any condition that results in hypoalbuminemia or low albumin levels would lead to a loss of bound calcium, while at the same time free ionized calcium concentrations stay essentially the same, which is due to hormonal regulation. This is therefore called false hypocalcemia, or pseudo-hypocalcemia, since there's less overall calcium due to less bound calcium, but the free ionized calcium levels are still the same. Alright, so for there to be too little calcium in the blood, or true hypocalcemia, there could either be less calcium entering the blood, or too much calcium leaving the blood. Less calcium entering the blood is the most common cause, and can be due to hypoparathyroidism, or low levels or lower activity of the parathyroid hormone. This can be caused by surgical removal or autoimmune destruction of the parathyroid gland, as well as congenital problems involving the parathyroid gland like DeGeorge syndrome, or deficiency in magnesium, which is needed for parathyroid hormone production. Also, low levels of vitamin D can lead to hypocalcemia, and can be caused by a deficient diet, malabsorption, cirrhosis, a lack of sunlight, and chronic renal failure, just to name a few. And then there's the second cause, too much calcium leaving the blood. This might happen when too much ionized calcium gets excreted. Normally, calcium filters from the blood into the glomerulus of the kidney, but is then reabsorbed back into the blood by the nephron so that it isn't lost. In kidney failure, the nephron doesn't effectively reabsorb calcium, which allows it to get excreted in the urine. A different example would be tissue injury, like burns, rhabdomyolysis, and tumor lysis syndrome, where large numbers of cells die and release intracellular phosphate into the blood. The phosphate binds to the ionized calcium and forms calcium phosphate, making it insoluble and effectively decreasing the total amount in the blood. Other inflammatory processes can also be a cause, like acute pancreatitis, because free fatty acids end up binding to ionized calcium, which is also insoluble and precipitates out as a soap-like substance. Finally, ionized calcium levels can fall as a result of having too many blood transfusions, because additives in the blood like citrate and ethylene diamine tetraacetic acid, or EDTA, can chelate or bind to calcium, forming complex calcium, which is an inactive molecule. Low levels of ionized calcium affect a variety of cellular processes, in particular electrically active neurons. Normally, the resting state of sodium channels is stabilized by calcium ions, which prevents them from spontaneously opening and potentially causing a depolarization. With low levels of extracellular calcium, voltage-gated sodium channels are less stable and are more likely to open up, which allows the cell to depolarize more easily and makes the neuron more excitable. This can trigger tetany, or the involuntary contraction of muscles, which is a classic symptom of hypocalcemia. The spontaneous firing of neurons also can lead to Chvostek's sign, which is when facial muscles twitch after the facial nerve is lightly finger tapped 1 centimeter below the zygomatic process. It can also cause Trousseau's sign, which is where a blood pressure cuff occludes the brachial artery, and that pressure on the nerve is enough to make it fire, which results in a muscle spasm that makes the wrist and metacarpophalangeal joints flex. Other symptoms include muscle cramps, abdominal pain, perioral tingling, which is tingling around the mouth, and in extreme cases, seizures. Hypocalcemia is diagnosed based on a low level of calcium in the blood, generally below 8.5 milligrams per deciliter. Also, an electrocardiogram might have changes like a prolonged QT interval, prolonged ST segment, and arrhythmias, like torsade de pointes and atrial fibrillation. To identify the cause, lab tests are typically done, which includes tests for parathyroid hormone, vitamin D, albumin, phosphorus, and magnesium. In hypocalcemia, the main goal is to normalize calcium levels using formulation, like calcium gluconate, and if appropriate, vitamin D supplementation. Alright, as a quick recap, hypocalcemia describes a low concentration of free ionized calcium in the blood, which most commonly results from defective production of calcium-controlling hormones, like parathyroid hormone and active vitamin D. Low calcium levels tend to cause certain excitable cells to be more excitable, which results in tetany, muscle spasms, and cardiac dysfunction. What's going on, guys? Thanks for watching. Hope you liked that video. It was another long one on a renal topic, but we are really nearing the end of these topics, and it'll be really cool to be able to close out all of renal, at least for the, all intents and purposes. Huge special thanks goes to Rishi for editing the script, as well as Maria for writing the script. And I did the illustrations and the voiceover, and then Yifan did the video editing, so huge special thanks goes to him because he had to go back and forth with me for a while on these just because I am kind of a perfectionist. So thank you to Yifan for dealing with me. You guys can always help support us by donating on Patreon, as well as subscribing to our channel and following us on social media. Okay, guys. See you later.
Hypokalemia happens when there's too little potassium in the extracellular fluid, generally under 3.5 milliequivalents per liter, and it's usually due to a low potassium intake, abuse of laxatives, vomiting, metabolic alkalosis, and the use of diuretics, both loop and thiazides. Hypokalemia can be asymptomatic, or it can cause symptoms like palpitations or smooth muscle weakness leading to an ileus, which can cause nausea and vomiting. In severe cases, there can be muscle weakness, specifically in the skeletal muscles, which can lead to diaphragmatic paralysis and difficulty breathing. Whenever potassium levels are below 3.5 milliequivalents per liter, the first thing to do is an EKG. There may be EKG changes, but they don't always correlate with the severity and progression of hypokalemia. The EKG typically shows ST segment depression, a depressed T wave, and an increase in the amplitude of the U wave, best seen in leads V4 to V6. Sometimes the T and U waves merge to form a singular TU wave, which can be mistaken for a prolonged QT interval. In severe cases, the QRS duration is prolonged, the ST becomes markedly depressed, and the T waves are inverted. Common causes of hypokalemia are diarrhea, vomiting, or diuretic use. But if these aren't the cause, then urinary potassium is assessed in order to see if hypokalemia is being caused by renal losses. The best way to do that is to measure the 24-hour urine potassium. But because that takes a full day, in an urgent setting, a spot urine potassium to creatinine ratio can be obtained instead. Next, an ABG is done to assess acid-base status. In metabolic acidosis, it would show a pH below 7.35 and a bicarbonate, or HCO3 level, below 22 milliequivalents per liter. If metabolic acidosis is associated with a low urine potassium to creatinine ratio, then the cause may be gastrointestinal, like with laxative abuse. If metabolic acidosis is associated with a high urine potassium to creatinine ratio, then the cause may be diabetic ketoacidosis or type 1 or 2 renal tubular acidosis. Now, if the pH is above 7.45 and the bicarbonate is above 27 milliequivalents per liter, then it's metabolic alkalosis. If metabolic alkalosis is associated with a low urine potassium to creatinine ratio, then this might be due to vomiting. If metabolic alkalosis is associated with a high urine potassium to creatinine ratio and the individual is normotensive, then it can be caused by diuretic use, like furosemide, or two rare renal syndromes, Bartter and Gittleman syndromes. If the individual is hypertensive, then the underlying cause may be primary hyperaldosteronism or a renovascular disease like renal artery stenosis. To put it differently, if the ratio is above 14 milliequivalents per gram creatinine, then the hypokalemia is likely due to the kidney not being able to retain enough potassium. If the ratio is less than 13 milliequivalents per gram creatinine, then hypokalemia is due to something else, like gastrointestinal losses. Now, in addition, when there's hypokalemia, the serum magnesium levels should be checked. That's because when there's a magnesium deficiency, potassium secretion often increases in the distal tubule. So, when levels of magnesium are below 1.5 milliequivalents per liter, it should be treated with oral or IV magnesium sulfate. Now, when potassium is 3 to 3.4 milliequivalents per liter, then this is considered mild to moderate hypokalemia. If the cause was vomiting and it's associated with metabolic alkalosis, then treatment is oral potassium chloride. If hypokalemia was caused by laxative abuse and there's metabolic acidosis, then oral potassium bicarbonate is given instead. Treatment with potassium chloride or potassium bicarbonate is 10 to 20 milliequivalents of potassium given 2 to 4 times per day. If hypokalemia is due to renal causes, then in addition to oral potassium, a potassium-sparing diuretic, like amiloride, is given as well. If the individual doesn't tolerate oral potassium, then IV potassium chloride can be given. Finally, if an individual is dehydrated, then IV isotonic fluids are given. When potassium is below 3 milliequivalents per liter, or when the individual is symptomatic and has EKG changes, treatment is given right away. IV potassium chloride should be given at a rate of 10 to 20 milliequivalents per hour. Typically, rates greater than 20 milliequivalents per hour are highly irritating for the peripheral veins, and it can cause pain and phlebitis. But in a life-threatening situation, even 40 milliequivalents per hour can be given. Serum potassium is usually checked every 2 to 4 hours until potassium levels normalize. In addition, if an individual is dehydrated, then IV isotonic fluids are given. Okay, now let's switch gears and talk about underlying causes of hypokalemia. First, there's primary hyperaldosteronism, which is caused by aldosterone-producing adrenal adenomas. Typically, the individual is hypertensive, and there's a high aldosterone level, low serum potassium, and a low plasma renin activity. A CT scan of the abdomen is done, and adenomas are usually smaller than 4 centimeters, have a regular shape and borders, and have a CT attenuation lower than 10 Hounsfield units, which means it's about the same density as fat. Treatment is a laparoscopic adrenalectomy. Next, there's secondary hyperaldosteronism due to Bartter and Gittleman syndromes, both of which are genetic conditions that cause excess sodium chloride losses in the urine. With Bartter syndrome, sodium chloride isn't properly reabsorbed in the loop of Henle, while with Gittleman syndrome, sodium chloride isn't properly reabsorbed in the distal tubule. This leads to volume depletion, which activates the renin-angiotensin-aldosterone system, resulting in hyperrenanemia and hyperaldosteronism. Hyperaldosteronism leads to enhanced potassium and hydrogen ion secretion in the kidneys, leading to hypokalemia and metabolic alkalosis. Additionally, in Gittleman syndrome, there can be excess magnesium losses in the urine. Both Bartter and Gittleman syndromes can cause acute hypokalemia or metabolic alkalosis. Additionally, Bartter syndrome is associated with polyuria, growth delays, and cognitive disability. Gittleman syndrome can cause polyuria, muscle cramps, and fatigue. Both Bartter and Gittleman syndrome can cause hypotension as well. If these conditions are suspected, a urine chloride is measured, and in both conditions, it's above 25 milliequivalents per liter. After that, genetic testing can be done to identify both conditions. Okay, now to differentiate Bartter from Gittleman, urinary calcium is measured, and with Bartter syndrome, this is normal, or even high, because calcium reabsorption in the loop of Henle requires normal sodium chloride reabsorption. However, with Gittleman, urinary calcium is low. Treatment of both Bartter and Gittleman relies on potassium-sparing diuretics and supplementation with potassium chloride and magnesium. Finally, there's hypokalemic periodic paralysis, which is a genetic disorder which appears in late childhood or adolescence. Individuals present episodes of generalized muscle weakness that can also affect respiratory muscles and can be triggered by vigorous exercise, stress, or even a high carbohydrate meal. Episodes can last up to a few weeks, and usually the serum potassium is around 2.4 milliequivalents per liter. During an episode, once hypokalemia has been confirmed, oral potassium chloride is given. Between episodes, prophylactic treatment with a carbonic anhydrase inhibitor like dichlorphenamide can be given. Alright, as a quick recap, hypokalemia is a serum potassium below 3.5 milliequivalents per liter. It can be asymptomatic or cause symptoms like palpitations or muscle weakness. An EKG is done next. EKG abnormalities include ST segment depression, a low T wave amplitude, and an increased U wave amplitude. If metabolic acidosis is associated with a low urine potassium to creatinine ratio below 13 milliequivalents per gram, then it may be caused by laxative abuse. If metabolic acidosis is associated with a high urine potassium to creatinine ratio above 14 milliequivalents per gram, then the cause can be diabetic ketoacidosis or type 1 or 2 renal tubular acidosis. If metabolic alkalosis is associated with a low urine potassium to creatinine ratio, then this can be due to vomiting. If metabolic alkalosis is associated with high urine potassium to creatinine ratio and the individual is normotensive, then this can be caused by diuretics or by Gittleman or Bartter syndromes. If the individual is hypertensive, then primary hyperaldosteronism or renovascular disease can be the cause. Now, when potassium is between 3 and 3.4 milliequivalents per liter, there's mild to moderate hypokalemia. When there's metabolic alkalosis, oral potassium chloride is used. When there's metabolic acidosis, then potassium bicarbonate is used instead. When the cause of hypokalemia is renal, then a potassium-sparing diuretic, like amiloride, is given in addition to oral potassium. When potassium is below 3 milliequivalents per liter, or when the individual is symptomatic, then IV potassium chloride is given. Serum potassium is initially checked every 2 to 4 hours, and treatment is continued until serum potassium rises above 3.5 milliequivalents per liter. When there's also hypomagnesemia, oral or IV magnesium sulfate is given as well.
With hypokalemia, hypo means under, and cal refers to potassium, and emia refers to the blood. So hypokalemia means lower than normal potassium levels in the blood, generally under 3.5 milliequivalents per liter. Now, total body potassium can essentially be split into two components, intracellular and extracellular potassium, or potassium inside and outside cells, respectively. The extracellular component includes both the intravascular space, which is the space within the blood and lymphatic vessels, and the interstitial space, the space between cells where you typically find fibrous proteins and long chains of carbohydrates, which are called glycosaminoglycans. Now, the vast majority, around 98%, of all the body's potassium is intracellular, or inside of the cells. In fact, the concentration of potassium inside the cells is about 150 milliequivalents per liter, whereas outside the cell it's only about 4.5 milliequivalents per liter. Keep in mind that these potassium ions carry a charge, so the difference in concentration also leads to a difference in charge, which establishes an overall electrochemical gradient across the cell membrane. And this is called the internal potassium balance. This balance is maintained by the sodium-potassium pump, which pumps 2 potassium ions in for every 3 sodium ions out, as well as potassium leak channels and inward rectifier channels that are scattered throughout the membrane. This concentration gradient is extremely important for setting the resting membrane potential of excitable cell membranes, which is needed for normal contraction of smooth, cardiac, and skeletal muscles. Also, though, in addition to this internal potassium balance, there's also an external potassium balance, which refers to the potassium you get externally through the diet every day. On a daily basis, the amount of potassium that typically gets taken in usually ranges between 50 milliequivalents per liter to 150 milliequivalents per liter, which is way higher than the extracellular potassium concentration of 4.5 milliequivalents per liter. So your body has to figure out a way to excrete most of what it takes in. This external balancing act is largely taken care of by the kidneys, where excess potassium is secreted into a renal tubule and excreted in the urine. Also, though, a small amount of dietary potassium is also lost via the gastrointestinal tract and the sweat. So, in order for there to be too little potassium in the blood, or hypokalemia, there are 2 possibilities. The first is an external balance shift, most often caused by an increase in potassium excretion in the kidneys, which lowers the level of potassium in the blood. And the second is an internal balance shift, where potassium moves into cells, from the interstitium in blood. One potential cause of an internal potassium balance shift is having excess insulin. This is because after a meal, glucose increases in the blood, and at the same time insulin is released, which binds the cells and stimulates the uptake of that glucose. Insulin also increases the activity of the sodium-potassium pump, which pulls potassium into cells. People with type 1 diabetes don't make enough insulin, and so they use exogenous insulin, meaning an injection or infusion of insulin. In rare cases, insulin overdose can cause enough potassium uptake into cells as to cause hypokalemia. Another cause of an internal potassium balance shift could be an alkalosis, which is when the blood becomes too alkaline. In other words, there's a lower concentration of hydrogen ions, meaning a higher blood pH. One way the body can decrease blood pH is by moving hydrogen ions out of cells and into the blood. To accomplish this, cells use a complex series of multiple ion channels, exchangers, and pumps to exchange hydrogen ions for potassium ions across the cell membrane. So, in order to help compensate for an alkalosis, hydrogen ions leave cells and potassium ions enter the cells and leave the blood, resulting in hypokalemia. That being said, not all acid-base disturbances affect potassium levels. For example, in respiratory alkalosis, due to low carbon dioxide levels in the blood, potassium levels aren't typically affected because CO2 is lipid-soluble and freely moves out of cells without being exchanged for potassium, therefore no hypokalemia. Certain catecholamines can also shift potassium out of cells, and this is via beta-2 adrenergic and alpha-adrenergic receptors on cell membranes. When activated, beta-2 adrenergic receptors stimulate the sodium-potassium pump, which pulls potassium from the blood into cells. Meanwhile, alpha-adrenergic receptors cause a shift of potassium out of cells via calcium-dependent potassium channels. So that being said, beta-2 adrenergic agonists and alpha-adrenergic antagonists both cause a shift of potassium into cells and out of the blood. Alright, on to external potassium balance shifts resulting in hypokalemia, which has to do with potassium intake or excretion. With regards to intake, simply not taking enough potassium in can lead to hypokalemia, like in the case of anorexia, prolonged fasting, or specific types of diets. Most other cases, though, have to do with the kidneys and their ability to regulate what stays in the blood and gets excreted into the urine. The kidney does this by the processes of filtration, reabsorption, and secretion in the nephron. First off, potassium is freely filtered from the blood into the urine at the glomerulus. After that, about 67% is reabsorbed in the proximal convoluted tubule, and an additional 20% is reabsorbed in the thick ascending limb. And that leaves about 13% of the initial amount, right? And at this point, the distal tubule and collecting ducts of the nephron can either reabsorb or secrete potassium depending on what the body needs. Now, reabsorption in this area is taken care of by the alpha intercalated cells, while secretion is controlled by the principal cells. Typically, for people on a normal diet, more potassium is secreted than reabsorbed at this stage, and it could even be that all of the remaining potassium is secreted out if it's simply not needed. Now, an important hormone that helps regulate potassium reabsorption or secretion in the kidneys is aldosterone. Aldosterone increases the number of sodium channels and the number of potassium channels on the lumen side of the principal cell, as well as sodium-potassium pumps on the basolateral side of the principal cells. This allows sodium to move from the tubule into the cell, and then get pumped into the blood by the sodium-potassium pumps. As the pumps collectively move more sodium into the blood under the influence of aldosterone, more potassium gets pumped into the cell, which raises the intracellular potassium concentration. Having more intracellular potassium and also having more potassium channels promotes potassium secretion. Having said all that, in situations where somebody produces too much aldosterone, like primary hyperaldosteronism, then there's more potassium secretion by the principal cells, meaning more gets excreted. And that means less potassium is retained, causing hypokalemia. Other pathological conditions that cause increased aldosterone levels include compensated heart failure and cirrhosis. Commonly used diuretics like loop diuretics and thiazide diuretics also increase potassium excretion and can lead to hypokalemia. These diuretics inhibit sodium reabsorption upstream of the principal cells, which means more sodium is delivered downstream to the principal cells. As a result, more sodium enters the principal cells and is available for the sodium-potassium pump, which pumps that sodium out into the blood and pumps potassium into the cell, creating a relatively high potassium concentration in the principal cell. In addition, these diuretics also allow more water to remain in the lumen, creating a relatively low potassium concentration in the lumen. Taken together, a relatively high potassium concentration in the principal cell and a relatively low potassium concentration in the lumen increases the potassium gradient and causes a lot of potassium to get secreted and excreted in the urine, leading to hypokalemia. Another external balance shift causing hypokalemia is increased losses of gastrointestinal secretions, typically due to vomiting and diarrhea. Now, the upper GI tract actually only secretes a small amount of potassium, so direct losses via vomiting are usually minimal. But the loss of stomach acid leads to metabolic alkalosis, which, as we already saw, can lead to hypokalemia. Relative to the upper GI tract, the lower GI tract secretes more potassium, so more gets directly lost in the feces in cases of chronic diarrhea, like from infections, inflammatory bowel diseases, as well as laxative abuse. Finally, a very small amount of potassium is also lost in the sweat, which could be relevant for individuals who exercise a lot in a hot climate. Alright, so there are all these ways to develop hypokalemia. But what happens when somebody actually has hypokalemia? Well, remember that the concentrations of potassium inside and outside of cells is really super important for maintaining the resting cell membrane potential, and ultimately for allowing a cell to depolarize and a muscle to contract. And that includes all muscles, skeletal, smooth, and cardiac muscles. So with low potassium in the blood, the membrane potential can hyperpolarize, or become more negative. This means that the muscle cells become less reactive to stimuli. Diminished contractions of smooth muscle can lead to constipation. Diminished skeletal muscle contractions can lead to muscle weakness, cramps, and flaccid paralysis, which tends to start in the lower extremities and ascend upward. Respiratory muscles can also be affected, which leads to respiratory depression. Finally, hypokalemia can affect cardiac muscle contractions, which can lead to cardiac arrhythmias as well as cardiac arrest. Hypokalemia is diagnosed based on the presence of low levels of potassium in the blood, generally below 3.5 milliequivalents per liter. It's also important to get an electrocardiogram, which typically shows a prolonged QT interval, appearance of a U wave, and atrial or ventricular tachyarrhythmias. In patients with severe hypokalemia, the main goal of treatment is to normalize potassium levels. This is done by reducing ongoing potassium losses by treating underlying causes, like vomiting and diarrhea, and using potassium-sparing diuretics if diuretic therapy is required, as well as replenishing potassium stores with supplementation. Alright, as a quick recap, hypokalemia describes a low concentration of potassium in the blood, which can be the result of an internal potassium balance shift where potassium moves into the body's cells, as well as an external potassium balance shift having to do with either low intake or high excretion of potassium. Either way, the low potassium levels leads to issues with muscle contractions, which could be smooth, skeletal, or cardiac muscles. With hypomagnesemia, hypo means lower and magnes refers to magnesium, and emia refers to the blood. So hypermagnesemia means lower than normal magnesium levels in the blood, and symptoms typically develop at levels below 1 milliequivalent per liter. An average adult has about 25 grams of magnesium in their body. About half is stored in the bones, and most of the other half is found within cells. In fact, magnesium is a really common positively charged ion found within the cell, second only to potassium. A very tiny fraction, roughly 1% of the total magnesium in the body, is in the extracellular space, which includes both the intravascular space, the blood vessels and lymphatic vessels, and the interstitial space, the space between cells. About 20% of the magnesium in the extracellular space, which would be about 0.2% of total magnesium, is bound to negatively charged proteins like albumin, but the other 80% or 0.8% of total magnesium can be filtered into the kidneys. So inside the kidney, that magnesium gets filtered into the nephron, and about 30% gets reabsorbed at the proximal convoluted tubule, 60% gets reabsorbed in the ascending loop of Henle, and 5% gets reabsorbed at the distal convoluted tubule. And that leaves only about 5% to get excreted in the urine. Magnesium levels can fall in a few situations. One scenario is when the nephron fails to reabsorb the magnesium that's filtered out of the blood, which would mean more gets excreted in the urine instead of kept in the blood. Magnesium reabsorption is mostly a passive process, where the positively charged magnesium ion follows the electrochemical gradient and moves from the positively charged lumen into the cells lining the lumen, which usually have a negative charge. Now, loop and thiazide diuretics can disrupt this process, because they both make the lumen less positively charged, and this diminishes magnesium's electrochemical gradient and causes more of the ions to stick around in the filtrate and get peed out. Another sort of similar scenario is a genetic mutation that affects the channels that regulate ion flow, which again could change the electrochemical gradient and cause more magnesium to stick around in the lumen and get peed out. An example of this is Gittleman syndrome, where there's a mutation in the gene coding for the NaCl cotransporters in the distal tubule. Now, a different mechanism for hypomagnesemia is prolonged malnutrition, where not enough magnesium gets consumed. Alternatively, there might be enough consumed, but not enough absorbed in the gastrointestinal tract. So instead of going into the blood, it gets excreted. And this can happen because of interference from medications like proton pump inhibitors, or from a bout of diarrhea. Another cause of hypomagnesemia includes uncontrolled diabetes mellitus, where sometimes there can be increased levels of glucose in the blood. And this means that there's also increased glucose filtered into the kidney and nephron, which ends up attracting a lot of water and causes a large volume of urine to flow through the nephrons. This high urinary flow carries ions like magnesium right through the nephron, because the fast flow doesn't allow enough time for magnesium reabsorption to happen. Yet another cause is hungry bone syndrome, which is when the thyroid or parathyroid glands are surgically removed, which leads to increased bone formation. In this case, the osteoblasts, or bone-forming cells, are literally hungry for ions to make more mineralized matrix, and so it ends up taking the magnesium from the blood. Another one is alcoholism, which offers kind of a mixed picture, because often these individuals have a poor diet, which means there might be low magnesium intake. But in addition, alcohol also increases renal excretion of magnesium. Additionally, low magnesium in the blood is commonly associated with low potassium in the blood, or hypokalemia, partly because a lot of the conditions that cause hypomagnesemia, like diarrhea and diuretic therapy, are also responsible for hypokalemia. It's also thought that normally magnesium inside cells of the nephron tends to get in the way of potassium channels a little bit. So with less magnesium, potassium is more easily secreted, excreted, and wasted, which can lead to hypokalemia. Now, severe hypomagnesemia can also lead to low calcium in the blood, or hypocalcemia, since the parathyroid gland needs magnesium in order to release parathyroid hormone, which normally causes osteoclast cells to release calcium from bones into the blood. So without this magnesium, there's impaired release of parathyroid hormone, and it's also thought that magnesium is needed in order to respond to parathyroid hormone as well, and so both of these result in less calcium in the blood. Early symptoms of hypomagnesemia, though, are often neuromuscular. This happens because, under normal circumstances, at the neuromuscular junction, there are voltage-gated calcium channels on presynaptic neurons, which need to open and let calcium in to cause the neuron to release neurotransmitter and ultimately cause muscle contraction. Magnesium seems to inhibit calcium influx a little bit, which ends up stabilizing the axon. So without magnesium floating around, calcium can enter neurons more easily, and this makes the muscles and nerves more excitable. This can end up leading to neuromuscular symptoms, like uncontrolled stimulation of nerves as well as tetany, which is a condition where there are intermittent muscle spasms throughout the body. These spasms are particularly evident in the muscles of the hand and the forearm, known as trousseau sign. When the spasms happen in the muscles of facial expression, it's called Chvostek's sign. Severe hypomagnesemia can even lead to convulsions or seizures, as well as abnormal heart rhythms. Now, diagnosis of hypomagnesemia is usually done by measuring the level of free unbound magnesium in the serum, or doing a 24-hour urine collection. Treatment here depends on the cause. So, for example, if it's due to inadequate intake, then it can be supplemented orally. In more severe cases, magnesium can be given in the form of magnesium sulfate intravenously or intramuscularly. Alright, as a quick recap. Hypomagnesemia refers to decreased free magnesium ion levels in the blood. And this can be caused by excessive excretion by the kidneys, as well as inadequate intake of magnesium. These situations can lead to symptoms once below 1 milliequivalent per liter, and these symptoms can include uncontrolled firing of the neurons, which lead to muscle spasms, or even seizures and cardiac arrhythmias. What's up, guys? Thanks for watching. Got a couple updates for you. Update number 1 is that video was marks one of the last videos in the renal playlist, like all the renal videos. We're almost done with all of them, just like cardiovascular, which is really exciting because we've been working on them for a really long time. So that's going to be awesome. So look forward to seeing the last of those in the next couple weeks here. Second update is that the osmosis team is going to VidCon this year, so we're just kind of hashing that out, which is really exciting and really looking forward to that because it's going to be a blast. We went last year and it was really fun. So if you're going to go to that, we'll see you there. Other than that, I'm just going to say thanks to Debal for writing the script, Rishi for editing the script, and then I did the illustration and the audio. You guys can always help support us by donating on Patreon or subscribing to our channel. as well as subscribing to all our other social media outlets like Twitter, Facebook, Instagram, and even Reddit, where we have a subreddit called r/osmosit. So go check that out, upvote some stuff, do what Redditors do. All right, guys. See you later.
Hyponatremia means a lower than normal concentration of sodium in the blood, generally below 135 milliequivalents per liter. However, since the concentration of sodium depends on both sodium and water levels in the body, hyponatremia actually translates as too much water in the extracellular compartment. Okay, now remember that total body water is distributed either in the intracellular compartment, meaning inside the cells, or the extracellular compartment, meaning outside the cells. Now, both the intracellular and extracellular compartments have the same amount of solutes dissolved in that water, so the same osmolality. Normally between 275 and 290 milliosmoles per kilogram. Serum osmolality can be calculated using the formula twice the concentration of sodium measured in milliequivalents per liter plus the serum concentration of glucose divided by 18 measured in milligrams per deciliter plus BUN, which stands for blood urea nitrogen, divided by 2.8, also in milligrams per deciliter. So if you remember one thing from this formula, it should be that sodium is the major determinant of serum osmolality. Now, just to make matters more interesting, some of these solutes, like sodium and glucose, can't freely cross cell membranes, so they generate an osmotic pressure inside the compartment, which is a measurement of how likely it is that this compartment will draw water out of the other one. Normally, the intracellular and extracellular compartments are isotonic to each other, meaning they have the same concentration of osmotically active solutes. However, small variations in solute concentrations, like having more sodium in the extracellular compartment, can alter that equilibrium. So, water moves across cell membranes in order to restore the balance. Water moves according to the rules of osmosis, or from the hypotonic compartment, where there's more water, to the hypertonic compartment, where there's less water. And water does that until the two compartments once again become isotonic. Now, all that being said, hyponatremia, or low concentration of sodium in the extracellular fluid and therefore the blood, can be caused by either losing more sodium than water or gaining more water than sodium. And it can develop acutely, over less than 48 hours, or chronically, over more than 48 hours. Depending on severity, hyponatremia can be classified as mild, when the serum sodium is between 130 and 134 milliequivalents per liter, moderate, with the serum sodium being between 120 and 129 milliequivalents per liter, or severe, when the serum sodium is below 120 milliequivalents per liter. Now, according to serum osmolality, hyponatremia can be split in three categories. The first category is when there's low serum osmolality, below 280 milliosmoles per kilogram, and it confirms true hyponatremia. True hyponatremia can be further divided into three subcategories of its own, depending on body volume status. The first subcategory is hypervolemic hyponatremia, where there's an enormous increase in total body water with a less significant increase in total body sodium. Typically, this is seen in conditions like congestive heart failure, cirrhosis, or nephrotic syndrome, which all present with edema. The second subcategory is hypovolemic hyponatremia, where there's a small decrease in total body water with a large decrease in total body sodium. This can occur in conditions like diarrhea or vomiting, or in response to certain medications like diuretics. Another, more nuanced condition is cerebral salt wasting, which is when an intracranial injury, like meningitis, disrupts the normal sympathetic nervous system stimulation of the kidneys leading to disproportionate loss of sodium and, along with it, water. A third subcategory is euvolemic hyponatremia, or normal volume hypovolemia, which is where there's a normal body sodium with an increase in total body water. However, we call it euvolemic because there's no edema. Euvolemic hyponatremia can be split into cases with dilute urine and concentrated urine. Conditions that cause dilute urine include drinking too much water, called polydipsia, or beer, which is called podomania, as well as the tea and toast diet, which is literally what it sounds like, hyponatremia in people who drink only tea and eat only toast. The main condition that causes concentrated urine is syndrome of inappropriate antidiuretic hormone secretion, or SIADH for short. This can happen because of conditions that mess up the brain's ability to regulate the release of ADH, like strokes, hemorrhages, or trauma, after surgery, and after treatment with some medications like mood stabilizers or antiepileptics. Inappropriate ADH secretion can also happen in the context of tumors that secrete ADH, of which small cell lung carcinoma is the most likely culprit. Euvolemic hyponatremia with concentrated urine can also be seen in adrenal insufficiency and hypothyroidism. Okay, now back to serum osmolality. We've got two more scenarios, normal and high. Normal osmolality between 280 and 285 milliosmoles per kilogram point towards false hyponatremia, or pseudo-hyponatremia. This is where the body water and sodium levels are normal, but there's an excessive amount of lipids, like in hypertriglyceridemia, or proteins, like in multiple myeloma. High levels of lipids and proteins affect the laboratory instruments that measure the sodium concentration, making the instruments say the sodium concentration is too low, which is false. So check serum lipids to rule out hypertriglyceridemia, as well as serum and urinary proteins to screen for multiple myeloma. Finally, when serum osmolality is above 285 milliosmoles per kilogram, we call that hypertonic hyponatremia. This may sound paradoxical, but remember that other osmotically active solutes can make the extracellular compartment hypertonic, and this, in turn, causes water to shift from the intracellular to the extracellular compartment. Such osmotically active solutes may be the excess glucose in diabetic ketoacidosis, mannitol, which is given in the treatment of cerebral edema, as well as glycine and sorbitol, which are used for irrigation during procedures like transurethral resection of the prostate or bladder, or laparoscopic surgery. Okay, now hyponatremia can cause symptoms like nausea, vomiting, and muscle cramps. In severe hyponatremia, water moves within the brain cells and they swell up, causing cerebral edema. This can cause confusion, coma, and even death. It can also cause increased intracranial pressure, which can squash the blood vessels heading in and out of the brain, causing ischemia, as well as possible brain herniation, which can damage respiratory centers in the brain and cause respiratory failure. So, to find out the cause of hyponatremia, first we need to exclude pseudo-hyponatremia by checking serum osmolality, lipids, and proteins, and hypertonic hyponatremia by checking serum osmolality, blood glucose levels, and the history for a recent use of mannitol, sorbitol, or glycine. So, if these causes are excluded and we're left with a low osmolality, then we have to figure out the cause of true, or hypotonic, hyponatremia. The first step is evaluating the volume status. Individuals can be hypervolemic, hypovolemic, or euvolemic. Hypervolemic individuals typically have edema, often around the ankles as a result of renal failure, decompensated heart failure, cirrhosis, or nephrotic syndrome. We use urinary sodium to distinguish between renal causes, like renal failure, when urinary sodium is greater than 20 milliequivalents per liter, and extrarenal causes, like heart failure, cirrhosis, and nephrotic syndrome, where urinary sodium is lower than 10 milliequivalents per liter. With renal failure, the kidneys aren't working properly, and they lose sodium in the urine, hence the urinary sodium above 20 milliequivalents per liter. With extrarenal causes, the kidneys are perfectly capable of reabsorbing sodium, but the problem is a low effective circulating volume. This triggers the activation of the renin-angiotensin-aldosterone system, and aldosterone acts on the distal convoluted tubule of the kidney, leading to sodium and water reabsorption. This is why the urinary sodium is below 10 milliequivalents per liter. Now, just to clarify some things, bear in mind that while nephrotic syndrome reflects a kidney ailment, it does not directly cause sodium waste, but rather loss of proteins in the urine, and the result is a low effective circulating volume. Heart failure and cirrhosis also cause a low circulating volume, which is why they're all lumped together. Okay, now on the other end of the spectrum, we've got hypovolemic hyponatremia. In this case, individuals may present with signs of dehydration, like orthostatic hypotension, decreased skin turgor, dry mucous membranes, and axillary dryness. And we can differentiate between renal and extrarenal losses using the urinary sodium. Renal losses are associated with urinary sodium greater than 40 milliequivalents per liter, and this might happen because of diuretics or cerebral salt wasting. If it's due to the use of diuretics, then stopping them may be enough to reverse hyponatremia. Extrarenal losses are associated with urinary sodium lower than 25 milliequivalents per liter, as well as a low urine output, usually below 500 milliliters per day. Common causes are gastrointestinal losses like vomiting or diarrhea, or third space losses like in pancreatitis, which can be confirmed by high serum amylase and lipase. Finally, there's euvolenic hyponatremia, which can be split up based on the urine sodium and osmolality. Urine sodium is usually above 20 milliequivalents per liter, but osmolality varies depending on ADH levels. Think of urine osmolality as a sort of ADH dipstick. When ADH is not secreted, urine osmolality is below 100 milliosmoles per kilogram, meaning the kidneys don't retain water and eliminate dilute urine. When ADH is secreted, urine osmolality is above 100 milliosmoles per kilogram, meaning the kidneys retain water and eliminate concentrated urine instead. Now, for cases with dilute urine, there are three possible diagnoses: primary polydipsia, beer drinkers' potomania, and the tea and toast diet. Euvolemic hyponatremia with concentrated urine is a bit trickier. Causes include hypothyroidism, primary adrenal insufficiency, and SIADH, with the last being a diagnosis of exclusion. So, with hypothyroidism, TSH levels are high, and free T4 levels are low. In primary adrenal insufficiency, morning cortisol and aldosterone levels are low, and an ACTH stimulation test can be done to confirm the diagnosis. This means that ACTH is administered after measuring morning cortisol levels, and in healthy individuals, the adrenals should produce more cortisol following ACTH administration. In individuals with primary adrenal insufficiency, cortisol levels stay low after ACTH administration. If both the thyroid and the adrenals are working properly, SIADH is the most likely diagnosis. Treatment recommendations for hyponatremia include general measures like identifying and, if possible, reversing the cause of hyponatremia, as well as fluid restriction, usually to less than 800 milliliters per day. Bear in mind that fluid restriction in a hypovolemic individual is probably not the best idea. For example, in cerebral salt wasting, you want to give intravenous fluids instead. Additionally, hypertonic saline, or 3% sodium chloride, with or without diuretics, can be given in particular clinical scenarios. For example, in individuals with heart failure and cirrhosis, loop diuretics like furosemide with hypertonic saline can help. Depending on the duration and severity of hyponatremia, additional recommendations are mostly about whether or not to give hypertonic saline, and how much of it to give. In acute asymptomatic hyponatremia, when serum sodium is below 130 milliequivalents per liter, it's recommended to give a 50 milliliter bolus of hypertonic saline infused over 10 minutes. In acute symptomatic hyponatremia, a 100 milliliter bolus of hypertonic saline is infused over 10 minutes, and an additional 2 doses may be given over the course of 30 minutes. In chronic asymptomatic hyponatremia, general measures like fluid restriction are usually sufficient to correct the sodium-water balance. Treatment of chronic symptomatic hyponatremia, however, depends on whether or not there's associated intracranial pathology. See, even with mild chronic hyponatremia, if the individual also has associated intracranial pathology, like for example a brain tumor, the risk of brain herniation increases. So basically, when there's an increased risk of brain herniation, it's important to give a 100 milliliter bolus of hypertonic saline infused over 10 minutes. After that, 2 more 100 milliliter boluses may be given over 30 minutes. In chronic symptomatic hyponatremia, when sodium is less than 120 milliequivalents per liter, but there's no intracranial pathology, we go for a hypertonic saline drip, 3% sodium chloride at a rate of 15 to 30 milliliters per hour. Finally, after administering hypertonic saline, serum sodium is rechecked once every 1 to 2 hours. The goal is to raise the serum sodium concentration by 4 to 6 milliequivalents per liter in the first 24 hours, but no more than 8 milliequivalents per liter per day, because of an increased risk of osmotic demyelination, which is when the myelin sheath of neurons gets damaged in response to overly rapid increases in serum sodium. One final point to make before wrapping things up is the importance of differentiating between SIADH and cerebral salt wasting, because biologically they are very similar, but the fluid restriction that helps in SIADH could do a lot of harm in cerebral salt wasting. SIADH is associated with euvolemia, whereas cerebral salt wasting usually goes along with hypovolemia. So far, so good. But sometimes the clinical signs of hypovolemia are very subtle, and it's hard to tell the difference. So instead, it might be useful to determine the fractional excretion of uric acid in urine. If it's above 11%, then the hyponatremia can be corrected by giving hypertonic saline, and then remeasuring the fractional excretion of uric acid. In SIADH, the value drops below 11% following correction, whereas in cerebral salt wasting, the value remains greater than 11%. Alright, as a quick recap. Hyponatremia refers to a serum sodium concentration of less than 135 milliequivalents per liter. True hyponatremia is associated with low serum osmolality, below 280 milliosmoles per kilogram, and is further evaluated depending on volume status. Hypervolemic hyponatremia presents with edema and can occur because of heart failure, cirrhosis, or nephrotic syndrome, in which case urinary sodium will be less than 10 milliequivalents per liter, or because of kidney failure, where urine sodium will be greater than 20 milliequivalents per liter. Hypovolemic hyponatremia presents with signs of dehydration. Renal losses are associated with urinary sodium greater than 40 milliequivalents per liter, whereas extrarenal losses are associated with urinary sodium lower than 25 milliequivalents per liter and low urine output. Finally, euvolemic hyponatremia can be associated with either low urine osmolality, like in primary polydipsia or the tea and toast diet, or with high urine osmolality in SIADH, hypothyroidism, or adrenal insufficiency. Treatment of hyponatremia relies on general measures like fluid restriction and reversing the cause. Additionally, hypertonic saline or diuretics may be given depending on the duration, severity, and etiology of hyponatremia.
With hyponatremia, hypo means under or low, and latremium is Latin for sodium, often written as Na+. And emia refers to the blood, so hyponatremia means a lower than normal concentration of sodium in the blood, generally below 135 milliequivalents per liter. The concentration of sodium depends on both sodium and water levels in the body. About 60% of our body weight comes from just water, and it basically sits in two places, or fluid compartments. A third of it is in the extracellular fluid, meaning outside the cells, and 2/3 of it is in the intracellular fluid, or inside cells. The extracellular fluid includes the fluid in blood vessels, lymphatic vessels, and the interstitial space, which is the space between cells that's filled with proteins and carbohydrates. Normally, the two compartments have the same osmolarity, which is the total solute concentration, and that lets water move freely between the two spaces. But the exact composition of the solutes differs quite a bit. The most common cation in the extracellular compartment is sodium, whereas in the intracellular compartment it's potassium and magnesium. The most common anion in the extracellular compartment is chloride, whereas in the intracellular compartment it's phosphate and negatively charged proteins. Of all of these, sodium is the ion that moves back and forth across cell membranes. And subtle changes in sodium concentration tilts the osmolarity balance in one direction or another, and that moves water as well. And this is why we say water follows sodium. That being said, hyponatremia, or low concentration of sodium in the extracellular fluid, and therefore the blood, can be caused by either losing more sodium than water, or gaining more water than sodium. Broadly speaking, hyponatremia can be divided into three categories, based on water volume status. The first is hypervolemic hyponatremia, where there's a huge increase in total body water, and only a small increase in total body sodium. So in this case, you're gaining more water than you are sodium. Typically, this is seen in conditions like congestive heart failure, cirrhosis, or nephrotic syndrome, where a ton of fluid leaks out of the blood vessels and into the interstitial space, and this causes edema, especially in the ankles. Even though there's more water overall, there's a decrease in the effective circulating volume, which is the amount of blood flowing in the body. That, though, stimulates the release of antidiuretic hormone, which retains pure water, leading to an increase in water, and it also stimulates the release of aldosterone, which retains a little sodium. But remember that since water follows sodium, the body ends up retaining even more water as well. So ultimately, you can see that there's a large increase in water, but only a small increase in sodium, and this leads to hyponatremia. The second category is hypovolemic hyponatremia, where there's a small decrease in total body water and a large decrease in total body sodium. In other words, you're losing more sodium than you are water. This can happen in conditions like diarrhea or vomiting, where the cells lining the gastrointestinal tract actually pump sodium ions into the digestive juices, but then those ions don't get reabsorbed because the undigested food and the digestive juices are just tossed from the body. It can also happen in response to using certain medications, like diuretics, where sodium ions are pumped into the renal tubule and then lost in the urine. Another more nuanced condition is cerebral salt wasting, which is when an intracranial injury like meningitis disrupts the normal sympathetic nervous system stimulation of the kidneys, and this leads to disproportionate loss of sodium. A third category is euvolemic hyponatremia, also known as normal volume hypovolemia. And this is where there's a normal body sodium, but an increase in total body water, even though that's sort of contrary to the name. The reason that it's given this name is that you don't have fluid pouring into the interstitial space, and therefore there's no edema, and so no clinical signs of hypervolemia. Euvolemic hyponatremia can be split into cases with dilute urine and concentrated urine. Cases that cause dilute urine include adrenal insufficiency and drinking too much water, called polydipsia, or beer, which is called podomania. Basically here, the body has a lot of water and the kidneys are trying to get rid of it as best they can. The main condition that causes concentrated urine, on the other hand, is syndrome of inappropriate antidiuretic hormone secretion, which can be shortened to just SIADH. This is where inappropriate presence of antidiuretic hormone causes water retention, which ends up meaning the urine gets more concentrated. Finally, hypothyroidism can also cause hyponatremia with concentrated urine, but the mechanism is not clearly understood. Now, there's one final type of hyponatremia, and it's sometimes called a false hyponatremia or pseudo-hyponatremia. This is where the body water and sodium levels are normal, but there's an excess amount of lipids, like in hypertriglyceridemia, or there's an excessive amount of proteins, like in multiple myeloma. High levels of lipids and proteins affects the laboratory instruments that measure the sodium concentration, and this makes the instruments say that the sodium concentration is too low, which is false. Hyponatremia can cause symptoms like nausea, vomiting, and muscle cramps. In severe hyponatremia, which is when the sodium concentration falls below 120 milliequivalents per liter, there can be cerebral edema, which can cause confusion, coma, and even death. The cerebral edema results from water shifting from the extracellular compartment to the intracellular compartment, causing the cells in the central nervous system to swell up and get damaged or die. It can also cause increased intracranial pressure, which can squash the blood vessels heading in and out of the brain, causing ischemia, as well as possible brain herniation, which can damage the respiratory centers in the brain and cause respiratory failure. Hyponatremia is usually diagnosed by looking at physical exam findings, as well as labs from the urine and blood. For example, a low serum osmolality suggests true hyponatremia versus a pseudo-hyponatremia, which shows a normal serum osmolality. In addition, signs of edema suggest hypervolemic hyponatremia, whereas signs of dehydration suggest hypovolemic hyponatremia. Also, urine osmolality can help differentiate between the two types of euvolemic hyponatremia. If the urine osmolality is really concentrated, greater than 100 milliosmoles per kilogram, then the problem might be SIADH. On the other hand, if the urine osmolality is dilute, less than 100 milliosmoles per kilogram, then the problem might be due to taking in too much fluid. The urinary sodium concentration can also be helpful, with greater than 20 to 40 milliequivalents per liter suggesting SIADH and cerebral salt wasting, and less than 20 milliequivalents per liter suggesting hypovolemia. Treatment of hyponatremia depends on the underlying cause. In patients with SIADH, fluid restriction is generally first-line therapy. On the other hand, if patients are hypovolemic, giving more fluid can be helpful. Generally speaking, for severe hyponatremia, it's important to give hypertonic saline, but this has to be done really carefully to avoid complications like cerebral pontine myelinolysis, which is where there's a loss of myelin in the pons, which is a structure in the brain, and this is due to rapid shifts in sodium and water. Alright, as a quick recap, hyponatremia is an electrolyte disorder that describes a low concentration of sodium in the blood, which can be divided into hypervolemic, hypovolemic, and euvolemic causes. Euvolemic can be further split into those with concentrated urine and those with dilute urine. Hyponatremia can cause water to shift into cells, and in severe cases it can lead to cerebral edema and death. Increasing sodium levels can be done with hypertonic saline, but needs to be done slowly to avoid cerebral pontine myelinolysis. With hypophosphatemia, hypo means under, phosphat refers to phosphate, and emia refers to the blood. So hypophosphatemia means having low phosphate levels in the blood, typically below 2.5 milligrams per deciliter. Now, phosphate is made up of one central phosphorus atom surrounded by 4 oxygen atoms in a tetrahedral arrangement, kind of like a mini pyramid. and has a charge of -3 and is written PO4 3-. In the body, about 85% of the phosphate is stored in the bones, where it combines with calcium to make a tough compound called hydroxyapatite, which is the stuff that makes bones hard. Of the remaining phosphate, a tiny amount is extracellular, or outside the cells, like in the blood. So this is the bit that gets measured. And the majority is intracellular, or inside cells, where it does all sorts of things. It's responsible for phosphorylation, where it binds to fats and proteins. It forms the high-energy bonds of adenosine triphosphate, or ATP, which is the most common energy currency in the cell. It's part of the DNA and RNA backbone that links individual nucleotides together. And it's also part of cellular signaling molecules like cyclic adenosine monophosphate, or CAMP. The bottom line is that phosphate's really important. Now, because most of phosphate's locked up with calcium in the bones, the levels of phosphate are heavily tied with the levels of ionized calcium in the body. If calcium levels fall, the 4 parathyroid glands buried within the thyroid gland release parathyroid hormone, which frees up both calcium and phosphate ions from the bones. It does this by stimulating osteoclasts, the cells that break down bone, to release hydrogen ions, which dissolves the hard, mineralized hydroxyapatite. As soon as the positively charged calcium and negatively charged phosphate are released from the bones, they grab onto each other again, meaning that the ionized calcium level doesn't really go up much at all. These two then make their way to the nephron of the kidney, and at this point in the proximal convoluted tubule, phosphate usually gets reabsorbed back into the blood via sodium phosphate cotransporters. It turns out, though, that parathyroid hormone also shuts this down. So this means that phosphate's left in the lumen and eventually gets sent out in the urine. Now, that calcium's still in the lumen, but parathyroid hormone also affects the distal convoluted tubule and increases calcium reabsorption. So when the dust settles, as a result of parathyroid hormone, phosphate's lost in the urine while ionized calcium is kept in the blood. So ionized calcium levels rise and phosphate levels fall. With all this in mind, hypophosphatemia can develop in a few ways. The first possibility is by having excess losses of phosphate. This can result in conditions like primary hyperparathyroidism, which results in too much parathyroid hormone, which leads to excess phosphate being excreted in the urine. Another example is Fanconi syndrome, which is where the proximal convoluted tubule essentially loses its capacity to reabsorb a variety of solutes, including phosphate, which once again lets it get excreted in the urine. Another possibility is not absorbing enough through the gastrointestinal tract, because usually phosphate ions are absorbed in the GI tract, but some substances like alcohol or a medication can impair the phosphate absorption, which means it gets excreted instead. This includes antacids that contain aluminum, calcium, or magnesium, all of which are positive ions that can bind with the negatively charged phosphate and block absorption. Alternatively, a person might simply not be getting enough phosphate in the diet, although this is unusual because it's found in a lot of foods. The exception, though, is someone that's starving and severely malnourished, or someone who's actively depriving themselves of food, like in anorexia nervosa. In both of these situations, blood glucose levels are low, and as a result, cellular metabolism slows down considerably. When an individual in this state starts to suddenly eat healthy meals again, like in a hospital setting, then they all of a sudden get a bunch of glucose in their blood. And in response, insulin usually skyrockets in order to push that newfound glucose into the cells. This causes a demand for phosphate in cells because the first step in glucose metabolism is to have the enzyme hexokinase attach phosphate to glucose. Also, production of ATP molecules themselves requires a lot of phosphate. Now, this means that phosphate gets extracted from the blood, which causes phosphate levels, which have stayed relatively normal up until this point, to plummet. This is called refeeding syndrome, and it can cause levels of other electrolytes to rapidly change as well, putting these people at serious risk of developing cardiac arrhythmias and neurologic problems. Similarly, in diabetes, individuals can't make enough insulin, so the cells are effectively starving, even though they're surrounded by glucose in the blood. Sometimes these individuals can develop diabetic ketoacidosis. And to treat that complication, individuals are given insulin. And just like before, insulin causes the cells to extract glucose and phosphate from the blood, and the blood phosphate levels can quickly fall. A final cause of hypophosphatemia is respiratory alkalosis, because it causes extracellular carbon dioxide levels to decrease as it gets ventilated out of the lungs. This causes intracellular carbon dioxide to freely diffuse out of the cell, which raises the cellular pH, which stimulates glycolysis, a metabolic process that requires a lot of phosphate. Similar to the process in refeeding syndrome, when cells need phosphate, they simply pull it out of the blood, causing hypophosphatemia. Most people with mild hypophosphatemia have no symptoms, but severe hypophosphatemia can cause muscle weakness, weak bones or osteomalacia, and rhabdomyolysis, which is a type of kidney damage due to muscle breakdown, as well as an altered mental status. In addition, hypophosphatemia that happens due to primary hyperparathyroidism might show symptoms caused by the associated hypercalcemia. A common mnemonic to remember these symptoms is stones, thrones, bones, groans, and psychiatric overtones. Stones is for calcium-based kidney stones or gallstones that can form. Thrones refers to the toilet to remind you of polyuria or frequent urination that results from impaired sodium and water reabsorption. Bones is for bone pain that results after chronic hormone-driven demineralization in order to release calcium. Groans is for constipation and muscle weakness, both of which are partly due to decreased muscle contractions. And finally, psychiatric overtones refers to symptoms like depressed mood and confusion. Diagnosis of hypophosphatemia is based on the phosphate levels being below 2.5 milligrams per deciliter, and treatment involves giving intravenous or oral phosphate and close monitoring of the blood levels. In cases of malnutrition, it's important to gradually increase caloric intake and supplements over several days to avoid refeeding syndrome. Alright, as a quick recap, hypophosphatemia describes a blood phosphate level below 2.5 milligrams per deciliter, which can result from increased excretion, decreased absorption and intake, or a shift of phosphate from the bloodstream to the inside of cells. Regardless of the cause, the treatment is typically a slow increase in phosphate levels to bring them back to normal again. What's up, guys? Thanks for watching. That was hypophosphatemia, which is sort of like the sister video to hyperphosphatemia. We're almost done with all these renal videos, which is really exciting. I think we only have hypo and hypernatremia left, which is low and high sodium in the blood. So definitely be on the lookout for those ones in the coming weeks. This particular video is written by Charles B. Davis and edited by Rishi. I did the voiceover and the illustration, and Sam, which is one of our new video editors, did the video editing. So nice job, everyone. I think it turned out really well. If you guys are interested in learning a little more about this topic, you should definitely head over to osmosis.org, where we have a ton of quiz questions and flashcards and other sweet resources to take advantage of and just sort of learn some more stuff. So if you're interested, go over there and make an account. Otherwise, you can always support us by donating on Patreon and subscribing to our channel and following us on social media. All right, guys, see you later. With hydronephrosis, hydro means water, nephro means kidneys, and osis refers to a disease state. So hydronephrosis refers to a disease or condition where excessive amounts of water in the form of urine causes the kidneys to dilate. Now, normally inside the kidneys, urine forms in the nephron and then drains through the papilla, which is an inverted cone-shaped pyramid that, like a showerhead, pours urine into the calyces, which come from the Latin calyx, which means large cup, like a Roman chalice. From there it enters the renal pelvis, which funnels the urine into the ureter. If there's an obstruction to this normal flow of urine, then it can cause urinary pressures to increase and push on the walls of these structures, making them dilate. This might happen because of something within the urinary tract, for example, a kidney stone, or from external compression, for example, when a fetus pushes up against the urinary tract during pregnancy. Typically, the dilation starts closest to the site of the problem, and then slowly continues back up towards the kidneys. Now, if there's dilation of just the ureter, it's called hydroureter. But if there's dilation of the ureter, renal pelvis, and the calyces, it's called hydroureteronephrosis, or more commonly just hydronephrosis. The causes of hydronephrosis differ by age group. Hydronephrosis in the fetus is called antenatal hydronephrosis, and sometimes the cause here is unknown, and it develops and disappears on its own. So this might be a variation of normal development. But if hydronephrosis progresses through fetal development into the third trimester, then there might be an actual underlying pathology. For example, there's congenital ureteropelvic junction obstruction, which is where the ureteropelvic junction, which connects the ureter to the kidney, fails to canalize during development, which then obstructs the flow of urine. Another cause is vesicoureteral reflux, which is where urine is allowed to backflow from the bladder into the ureters and eventually the kidneys. In young children, hydronephrosis usually results from a congenital malformation, like a ureterocele, which is a sac of tissue in the distal ureter, that also obstructs the flow of urine from the ureter into the bladder, as well as posterior urethral valves, which is the malformation of the posterior urethra where flaps of tissue obstruct the outflow of urine. In contrast, adults with hydronephrosis usually develop it as a result of an acquired disease, like kidney stones, which is the most common cause, as well as prostatic hyperplasia, or enlarged prostate, which blocks the flow of urine out of the bladder. Now, severe long-standing hydronephrosis can lead to nephron destruction, and can result in an increase in serum creatinine, as well as electrolyte imbalances. When this sort of damage has happened, the kidney can develop a dilated ureter and renal pelvis, as well as compression atrophy, which is thinning of the renal medulla and cortex. Symptoms and complications of hydronephrosis are often related to the obstruction, since that's the context in which hydronephrosis is usually found. Obstruction might cause flank pain or groin pain, as well as a urinary tract infection. And the hydronephrosis itself might cause symptoms only once there's serious damage to the kidneys. A worrisome complication is post-renal azotemia, which is when an obstruction to urine flow causes the kidney to increase reabsorption of urea, resulting in increased nitrogen-containing compounds in the blood. Hydronephrosis is usually diagnosed with ultrasound, often prenatal ultrasound, meaning during pregnancy. Hydronephrosis is given a grade based on the severity, from 0 to 4. Grade 0 means that there's no dilation. Grade 1 is when there's a dilation of the renal pelvis, but the calyces remain normal. Grade 2 is when there's a dilation of the renal pelvis and the calyces. Grade 3 is when there's a moderate dilation of the renal pelvis and calyces, in addition to mild cortical thinning and flattening of the papillae. And lastly, grade 4 is when there's severe renal dilation and cortical thinning. In children, intravenous urography or pyelography is also commonly used to assess for congenital pelviureteric junction obstruction. In adults, a CT scan is commonly done because it can be helpful in identifying kidney stones, which is the most common underlying cause of the hydronephrosis. Hydronephrosis treatment focuses on relieving the obstruction and allowing the urine that might have accumulated behind the obstruction to flow out normally. Acutely, a nephrostomy tube can be used, which is a plastic tube inserted through the skin into the renal pelvis, and this allows the accumulated urine to drain out. Chronically, somebody could have a ureteric stent, which pops the ureter open, or a pyeloplasty, which is a surgical remake of the renal pelvis. Lower urinary tract obstructions, like prostatic hyperplasia, can be treated with the insertion of a urinary catheter that keeps the urethra open, or a suprapubic catheter that causes bladder decompression. Alright, as a quick recap, hydronephrosis is typically caused by either obstruction in or compression of the urinary tract, which leads to a buildup of urine and pressure and dilation of the ureter, renal pelvis, and calyces. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Kidney stones, also called nephrolithiasis, urolithiasis, or renal calculi, can form in the kidneys, but also in the ureters, bladder, or the urethra. They appear when solutes in the urine precipitate and crystallize. Depending on which solute precipitates to form the stone, there can be calcium oxalate, calcium phosphate, uric acid, cysteine, and struvite stones. Risk factors for developing kidney stones depend on their composition. Risk factors for calcium oxalate stones include high urine calcium, high urine oxalate, low urine citrate, and dietary factors include low calcium, low potassium, and low fluid intake, as well as a high oxalate and a high animal protein intake. Calcium phosphate stones usually develop in individuals with renal tubular acidosis type 1 and 2. Uric acid stones can form when urine pH is persistently below 5.5, which can happen with chronic diarrhea or conditions like gout, diabetes, and obesity. Cysteine stones occur in the setting of cystinuria, a genetic condition where too much cysteine is excreted. Finally, struvite stones, also called staghorn calculi, are made up of magnesium ammonium phosphate, and the main risk factor is a urinary tract infection with a bacterium that produces urease, like Proteus and Klebsiella. These bacteria increase urine pH, making it a favorable environment for magnesium ammonium phosphate to precipitate. Sometimes, kidney stones can be asymptomatic and discovered incidentally during an ultrasound or a CT scan. Other times, a kidney stone can cause symptoms due to urinary obstruction and renal distension. It can cause renal colic, which is when there's acute pain that's so intense that it requires IV pain medication. Passing a large stone through a narrow ureter has been compared to passing a baby's head through the vaginal canal. The difference is that you don't have to raise and nurture the stone once it passes. In renal colic, the location of pain depends on where the stone is located. A stone in the renal pelvis or the proximal ureter causes unilateral flank pain and tenderness, whereas a stone that's located lower in the ureter causes unilateral flank pain that radiates to the testicle or labia on the affected side. In addition, there can also be macroscopic hematuria, nausea, and vomiting. And if the stone is in the distal ureter, there may be dysuria and urgency as well. If the blockage is severe, like in a bilateral obstruction, when there are stones in both kidneys and they completely obstruct the flow of urine, or when a person has only a single functioning kidney, a solitary kidney, that gets obstructed, it can lead to signs of acute kidney injury, like anuria, which is when there's less than 100 milliliters of urine per day. A struvite stone can be accompanied by a urinary tract infection, which causes symptoms like fever, frequency, and urgency to urinate. Lab studies include a basic metabolic panel, where blood urea nitrogen, or BUN, and serum creatinine are done in order to check the renal function. With acute kidney injury, serum creatinine is elevated. Additionally, blood work and urinalysis may give clues as to the composition of the stone. Low serum bicarbonate and potassium levels may suggest an underlying renal tubular acidosis and a calcium phosphate stone. Serum calcium above 10 mg per deciliter suggests a calcium oxalate stone, whereas uric acid levels above 6 mg per deciliter suggest a uric acid stone. A urinalysis may show microscopic hematuria, or especially with struvite stones, there may be signs of a urinary tract infection, like bacteriuria and positive leukocyte esterase. On microscopy, if there are calcium oxalate crystals in the urinary sediment, this may point towards a calcium oxalate stone. Alternatively, with uric acid stones, uric acid crystals may be present. When urine pH is above 7 and there are phosphate crystals in the urine, this suggests a calcium phosphate stone or a struvite stone. Finally, hexagonal cysteine crystals are diagnostic for cysteine stones. The best way to see a kidney stone is by doing a non-contrast abdominal CT scan, but in pregnancy, an ultrasound is done instead. Now, on a CT scan, the location and density of a stone can suggest its composition. Calcium oxalate and calcium phosphate stones are radiopaque. A struvite stone is also radiopaque, but not quite as dense as calcium stones, and is usually large and located in the renal pelvis. Uric acid stones are lower density than both calcium and struvite stones. Finally, a cystine stone is lucent, and it's barely seen on the CT scan. When an ultrasound is done, stones that are located in the renal pelvis and proximal ureter can be seen. The stones are easily identified on the ultrasound because they cast an acoustic shadow. Additionally, indirect signs of obstruction may be seen on ultrasound, like hydronephrosis, which is when the kidney fills up with urine and swells. Sometimes, a kidney ureter bladder radiography, or KUB radiography, can be done, and radiopaque stones like calcium oxalate and calcium phosphate stones and struvite stones that are larger than 5 mm can be seen. But stones smaller than 5 mm or uric acid stones and cystine stones are often missed. Now, treatment mostly depends on the location, specifically whether the stone is in the renal pelvis or the ureter, size, and composition of the stones. For individuals with acute renal colic, pain control is managed with an NSAID, like indomethacin, or an opioid, like morphine. During renal colic, IV hydration is avoided unless the individual is dehydrated, because it can worsen the pain. In some cases, urgent decompression of the collecting system may also be necessary following analgesia. For example, when there's bilateral obstruction caused by stones in both kidneys and acute kidney injury, or when there's obstruction of a solitary kidney, or if the individual presents with signs of sepsis, like with a struvite stone that's associated with a UTI, or when there's hydronephrosis and a secondary bacterial kidney infection. Decompression can be done with percutaneous nephrostomy, which is when a catheter is inserted through the back or flank into the kidney in order to drain the urine. Another option is ureteral stenting, which is when a cystourethropy is done. This is when a flexible tube is inserted through the urethra into the bladder. Once inside the bladder, the affected ureter is identified and a guide wire is passed through the affected ureter and into the kidney. A stent is then placed over the guide wire and pushed into the ureter, allowing the flow of urine. Now, if an individual's symptoms are controlled and there are ureteral stones that are less than 10 mm, then initial management is observation and medical expulsive therapy, or MET. MET includes increased fluid intake, at least 2 liters per day, along with an NSAID and an antiemetic like metoclopramide. In addition, an alpha blocker like tamsulosin or a calcium channel blocker like nifedipine may be used to help pass the stone. This is done for about 6 weeks. During that time, if the individual has uncontrolled pain, fever, nausea, or vomiting, or if the individual simply wants the stone removed, then a more aggressive approach is taken based on stone location. For proximal ureteral calculi, meaning stones located further up in the ureter, one option is extracorporeal shockwave lithotripsy, or ESWL. ESWL is a machine that uses high-energy sound waves that produce shock waves to break kidney stones into smaller fragments, which can then be passed in the urine. If ESWL fails, then flexible ureteroscopy, or URS, can be done instead. URS is also preferred during pregnancy. URS is done with an endoscope that's passed through the urethra, bladder, and finally into the ureter where it's used to remove the stone. For mid and distal ureteral calculi, and for all ureteral calculi larger than 10 mm regardless of their location, URS is done. URS is also the treatment of choice when lab work and imaging studies suggest a cystine or uric acid stone. If URS fails, then percutaneous nephrolithotomy or PCNL is done. PCNL is a minimally invasive procedure where a small incision is made in the flank, and then a flexible nephroscope is inserted and the stone is removed through the working canal of the nephroscope. Other options include laparoscopic or open surgery. Now, most stones that are under 5 mm pass spontaneously, and individuals are advised to drink at least 2 liters of fluids per day until the stone passes. Once it passes, they should retrieve it and send it to the hospital laboratory to determine its composition. Finally, there are renal stones. For asymptomatic renal stones, active surveillance is done once a year using urinalysis, creatinine, and an abdominal ultrasound. For symptomatic renal stones smaller than 20 mm, ESWL or URS can be done. For symptomatic stones that are over 20 mm, PCNL is done. For stones that are located in the lower pole calyces and are under 10 mm, ESWL or URS can be done. For symptomatic stones that are located in the lower pole calyces and are over 10 mm, PCNL is done. With struvite stones, urinary tract infections need to be treated with antibiotics. Now, after retrieving a stone, its composition is analyzed in order to determine what kind of stone it was. If the stone composition remains unknown, then after 1 to 3 months from the acute episode, 2 24-hour urine collections should be obtained to determine urine volume, pH, and urinary excretion of calcium, uric acid, citrate, oxalate, sodium, potassium, and creatinine. This helps identify risk factors for stone formation and prevent further stone episodes. General measures include higher fluid intake in order to produce at least 2 liters of urine per day, less than 1 tablespoon of salt per day, less animal protein in the diet, less oxalate-containing foods like French fries, dark chocolate, or black tea, and finally, more fruits and vegetables in order to raise the level of citrate in the urine. If there's high urine calcium, then a thiazide diuretic like chlorthalidone is given to lower urine calcium. If there's a high urine calcium, then the serum calcium is checked. If the serum calcium is high as well, then there may be an underlying hyperparathyroidism. If there's high urine uric acid and general measures don't lower the levels, then allopurinol is given. Finally, to prevent cystine stones, urinary alkalinization can be done with oral potassium citrate. A follow-up with a 24-hour urine collection is done after 6 months of dietary and medical therapy. Alright, as a quick recap. The best test for identifying a kidney stone is a non-contrast CT scan, where calcium oxalate and calcium phosphate stones are radiopaque, struvites have a lower density than calcium stones, and uric acid and cystine stones have an even lower density. The ultrasound can identify renal stones, or proximal ureter stones, and hydronephrosis. Acute renal colic is treated with NSAIDs or opioids. If there are obstructive stones and there's also fever, or if there's bilateral obstruction, like when both kidneys have stones with high levels of creatinine, or if there's an obstruction on a solitary kidney, specifically when there's a single functional kidney, then percutaneous nephrostomy or ureteral stenting is urgently done. Most stones that are smaller than 5 millimeters pass spontaneously. Ureteral stones that are smaller than 10 millimeters with controlled symptoms are initially managed with MET, increased fluid intake, NSAID, an antiemetic, and an alpha blocker for 6 weeks. If during this period the individual has uncontrolled pain and fever, then options include ESWL and URS for proximal ureteral stones. URS is done for stones that are located in the mid and distal ureter and also for stones larger than 10 millimeters. If URS fails, then PCNL, laparoscopic or open surgery is done. Asymptomatic renal stones need active surveillance once a year using urinalysis, creatinine levels, and abdominal ultrasound. Symptomatic renal stones under 20 millimeters are treated with ESWL or URS. When they are above 20 millimeters, PCNL is done. For lower pole calyx stones under 10 millimeters, ESWL or URS is done. And for lower pole calyx stones over 10 millimeters, PCNL is done. Stone composition needs to be determined in order to correct specific risk factors and to prevent recurrence.
In the emergency department, 2 people with similar symptoms arrive. One of them is 35-year-old Conrad, who has terrible left flank pain, along with nausea and vomiting, and the other one is 40-year-old Sam, who has left flank pain, but also has dysuria. An electrolyte panel and urinalysis was done in both individuals. Results showed that Conrad had normal levels of calcium in the blood, but urinalysis showed hypercalciuria and hematuria. Sam's urinalysis showed positive leukocyte esterase, as well as positive nitrites and hematuria. Abdominal CT showed radiopaque masses in their ureters. Now, the suspicion is that both individuals have kidney stones, but there are actually several types of kidney stones, and we need to know what we're dealing with in order to give the right treatment. Okay, let's first talk about how kidney stones form. Urine is a combination of water, which acts as a solvent, and all sorts of particles or solutes. In general, when certain solutes become too concentrated in the solvent, they become supersaturated. Urinary supersaturation of certain solutes results in precipitation out of the solution and formation of crystals. Those crystals then act as a nidus, or place where more solutes can deposit, and over time, it builds up a crystalline structure. This can happen if there's an increase in the solute or a decrease in the solvent, as would be the case with dehydration. This means that dehydration leads to a low urine volume, which can further put a person at risk for kidney stones. Okay, let's now talk about the different types of stones. There are four main types of stones. Calcium stones are present in about 80% of the cases, while struvite stones are present in about 15%, and uric acid stones are present in about 5% of the cases. Finally, a super rare type of stone is a cysteine stone. Let's start with calcium stones. With calcium stones, in most cases, the inorganic precipitate is calcium oxalate, formed by a positively charged calcium ion binding to a negatively charged oxalate ion, which results in a black or dark brown colored stone that's shaped like an envelope or a dumbbell. Calcium oxalate stones appear radiopaque on X-ray, as well as on a CT scan. Now, there are some risk factors for developing calcium stones, such as idiopathic hypercalciuria or hypercalcemia. Another very important risk factor is hypocitriuria, which means that less citrate is eliminated in the urine. This is because, normally, citrate prevents stone formation by inhibiting crystal growth and aggregation. Another risk factor includes fat malabsorption, which can happen with Crohn's disease or in individuals that have had a gastric bypass operation. Since fat won't be absorbed in the intestine, it will bind to calcium, and this leaves a lot of oxalate free to be absorbed in the intestine, which raises oxalate levels in the blood and can further promote calcium oxalate stone formation. Another risk factor is the ingestion of ethylene glycol or antifreeze, because ethylene glycol forms oxalate once ingested. Finally, there's vitamin C abuse, because one product of vitamin C metabolism is oxalate. Now, treatment of calcium oxalate stones involves giving thiazide diuretics. Thiazides inhibit the sodium chloride transporter in the distal convoluted tubule, meaning that more sodium and chloride get in the urine. Okay, the distal convoluted tubule also has a calcium channel, which allows calcium from the lumen to diffuse into the cell. Once in the cell, calcium is transported out into the interstitium through a sodium-calcium exchanger that pumps sodium in and calcium out. Now, since thiazides decrease sodium reabsorption, there's less sodium in the cell, so the sodium-calcium exchanger works overtime to pump more sodium in and more calcium out. The decrease in intracellular calcium, in turn, leads to more calcium reabsorption from the urine. Another treatment is giving potassium citrate, which binds to the calcium in urine, thus preventing reabsorption. Finally, another treatment involves a low sodium diet. That's because when a person has a high sodium diet, more water is retained. This means that the extracellular volume expands. Since there's so much water and sodium, the renin-angiotensin-aldosterone system has nothing to respond to, so its activity is dialed down. This means that not so much sodium will be reabsorbed in the proximal convoluted tubule. Now, calcium and sodium reabsorption are tied together in the proximal convoluted tubule, so when there's less sodium reabsorption, there's also less calcium reabsorption, and there will be hypercalciuria. Sometimes, instead of oxalate, the calcium bind to negatively charged phosphate groups to form calcium phosphate stones. These are dirty white in color and shaped like a wedge prism, which appears radiopaque on an X-ray. A risk factor is highly alkaline urine, which could be caused by a renal tubular acidosis where there's a decreased secretion of hydrogen, or increased secretion of bicarbonate into the urine. Treatment includes a low sodium diet, as well as thiazide diuretics. Another type are struvite stones, sometimes called infection stones, which are a composite mix of magnesium, ammonium, and phosphate. Since they're infection stones, this means that the individual can present with signs of a urinary tract infection, like dysuria. For your tests, remember that these form when there's an overabundance of urease-positive bugs, like Proteus mirabilis, Staphylococcus saprophyticus, and Klebsiella species. They use the enzyme urease to split urea into ammonia and carbon dioxide. The ammonia makes the urine more alkaline and favors precipitation of magnesium, ammonium, and phosphate into jagged crystals called staghorn because they often branch into several of the renal calyces and look like the horns of a staghorn deer. On an X-ray or on a CT scan, such stones are radiopaque, but are less dense than calcium stones. You can see how the stone is occupying the renal calculi, Treatment relies on killing off the bacteria with antibiotics and surgical treatment in order to remove the stone. Next, there are uric acid stones. At a physiologic urine pH, which is about 5.5 to 7, meaning it's acidic, uric acid loses a proton and becomes a urate ion, which then binds sodium, forming monosodium urate, which crystallizes and ultimately forms uric acid stones. Such stones are red-brown in color and rhomboid or rosettes in shape, and appear radiolucent on X-ray, and are minimally visible on CT scan. Risk factors for developing uric acid stones include acidic urine pH as well as dehydration. One important risk factor is hyperuricemia, which can happen in conditions like gout. Other risk factors include conditions with a high cell turnover, such as leukemia. That's because the tissue breakdown releases a lot of uric acid. Treatment includes alkalinization of urine, as well as medications like allopurinol, which helps decrease uric acid levels. Finally, a tiny minority of stones are cysteine stones, composed of the amino acid cysteine, which sometimes leaks into the urine to crystallize and form a yellow or light pink colored stone that's hexagonal. Cysteine stones crystallize even more if the urine pH is acidic. For your tests, you can remember this using the following memory trick. 16 stones have 6 sides. On X-ray, it's faintly radiolucent, and on a CT scan, it's moderately radiopaque. The main risk factor for cysteine stones is cystinuria, an autosomal recessive hereditary condition that manifests in childhood. The protein affected is the amino acid transporter in the proximal convoluted tubule, which decrease reabsorption of ornithine, lysine, arginine, and most importantly, cysteine. The sodium cyanide nitroprusside test can detect cysteine in the urine and is used to diagnose this disorder. Treatment involves a low-sodium diet and alkalinization of urine. If this doesn't work, chelating agents are administered. For your tests, it's important to remember that all types of kidney stones generally present with the same symptoms, such as unilateral flank tenderness and pain, meaning between the ribs and the hip. Now, the pain is colicky and can radiate to the groin. This type of pain is called renal colic, which is when there is acute pain that's so intense that it requires IV pain medication. The pain is caused by the dilation, stretching, and spasm caused by obstruction of the ureter, and is typically worse at the uretero-pelvic junction and down the ureter. It subsides once the stone gets to the bladder. There can also be hematuria that can either be gross or can be detected using urinalysis. Okay. Now, sometimes kidney stones can completely obstruct the ureter. This way, the urine builds up behind the obstruction and the kidneys and ureters swell up. The distension or dilation in the renal pelvis and calyces is called hydronephrosis. But remember, other disorders like benign prostatic hypertrophy, congenital obstructions of the ureter, cervical cancer, vesicoureteral reflux, and retroperitoneal fibrosis can all lead to hydronephrosis. Now, all that distension compresses the kidney, which can further lead to atrophy of the renal cortex and medulla. When the obstruction is bilateral, or if the person only has one kidney, there's no urine flow, and this means that the kidneys aren't functioning at all, and creatinine levels go up. Okay, let's review. There are 4 main types of kidney stones. The most common is a calcium stone, which is usually a calcium oxalate stone, but can also be a calcium phosphate stone. Risk factors for calcium oxalate stones include idiopathic calciuria, hypercalcemia, hypocitriuria, fat malabsorption, ingestion of ethylene glycol or antifreeze, and vitamin C abuse. While risk factors for calcium phosphate stones include highly alkaline urine. Treatment of calcium stones includes thiazides, low sodium diet, and citrate. Another type is a struvite stone, which is also called an infection stone because it forms in individuals that have a urinary tract infection with a urease-positive bug, like Proteus mirabilis. Treatment relies on eradicating the infection and surgically removing the stone. Another type of stone is a uric acid stone, which usually appears in individuals with hyperuricemia, and treatment relies on alkalinization of urine and allopurinol. Cysteine stones are super rare, and the main risk factor is a hereditary condition that causes cystinuria. Treatment involves a low-sodium diet, alkalinization of urine, and if this doesn't work, then chelating agents are administered. Symptoms of a kidney stone include colicky flank pain that can radiate in the groin and hematuria. An X-ray and CT scan can be done to identify the location of the stone and sometimes even the type. When the kidney stones obstruct the ureter, this can lead to swelling in the renal pelvis and calyces called hydronephrosis. Hydronephrosis has other causes, like benign prostatic hypertrophy, congenital obstructions of the ureter, cervical cancer, injury to the ureter, vesicoureteral reflux, and retroperitoneal fibrosis. Now, back to our cases. Conrad came in with colicky flank pain, nausea, vomiting caused by the pain, probably. Urinalysis showed that Conrad has hypercalciuria and hematuria with normal calcium levels in the blood. The CT scan showed a radiopaque stone in the ureter, and based on the test results, this is most likely a calcium stone. Sam came in with flank pain and dysuria, and urinalysis showed positive hematuria and nitrites, as well as positive leukocyte esterase. The positive leukocyte esterase and nitrites suggest a urinary tract infection, and the CT scan showed a struvite stone in the kidneys.
With nephrolithiasis, nephro refers to the kidneys, and lithiasis means stone. So nephrolithiasis means kidney stones, sometimes also referred to as renal calculi, or urolithiasis. Kidney stones form when solutes in the urine precipitate out and crystallize. And although these most commonly form in the kidneys themselves, they can also form in the ureters, the bladder, or the urethra. Now, urine's a combination of water, which acts as a solvent, and all sorts of particles, or solutes. In general, when certain solutes become too concentrated in the solvent, they become supersaturated. Urinary supersaturation of certain solutes results in precipitation out of the solution and the formation of crystals. Those crystals then act as a nidus, or a place where more solutes can deposit, and over time it builds up a crystalline structure. This can happen if there's an increase in the solute or a decrease in the solvent, as would be the case with dehydration. In addition, there are substances like magnesium and citrate that inhibit crystal growth and aggregation, preventing kidney stones from forming in the first place. In the majority of cases, the inorganic precipitate is calcium oxalate, formed by a positively charged calcium ion binding to a negatively charged oxalate ion, which results in a black or dark brown colored stone that's radio-opaque on an X-ray, meaning that it shows up as a white spot. Sometimes, instead of oxalate, the calcium binds a negatively charged phosphate group to form calcium phosphate stones, which are dirty white in color and also radio-opaque on an X-ray. Calcium oxalate crystals are more likely to form in acidic urine, whereas calcium phosphate crystals are more likely to form in alkaline urine. The exact reason why these stones form is usually unknown, but there are some known risk factors like hypercalcemia and hypercalciuria, having too much calcium in the blood and urine, respectively. Hypercalcemia can result from increased calcium absorption in the gastrointestinal tract, as well as hormonal causes like primary hyperparathyroidism. Hypercalciuria can result from impaired renal tubular reabsorption of calcium, which leaves a lot of calcium behind in the tubule. For the calcium oxalate stones, hyperoxaluria is a risk factor as well, and it can be due to a genetic defect that increases oxalate excretion, a defect in liver metabolism, or a diet heavy in oxalate-rich foods like rhubarb, spinach, chocolate, nuts, and beer. There are also uric acid stones, which are red-brown in color and radiolucent under an X-ray, meaning that they're transparent to X-rays and don't usually show up very well. At a physiologic pH, uric acid loses a proton and becomes a urate ion, which then binds sodium, forming monosodium urate, which crystallizes and ultimately forms uric acid stones. Since uric acid's a breakdown product of purines, a very common reason for high levels of uric acid is consuming lots of purines. Purine-rich food includes shellfish, anchovies, red meat, or organ meat. High levels of uric acid can also cause gouty arthritis, most commonly in the first metatarsal joint, which is the base of the big toe. A fourth type are struvite stones, sometimes called infection stones, which are a composite mix of magnesium, ammonium, and phosphate. These form when bacteria like Proteus mirabilis, Proteus vulgaris, or Morganella morganii use the enzyme urease to split urea into carbon dioxide and ammonia. The ammonia makes the urine more alkaline and favors precipitation of magnesium, ammonium, and phosphate into jagged crystals called staghorns, because they often branch into several of the renal calyces and look like the horns of a staghorn deer. Like the calcium phosphate stones, struvite stones are dirty white and radio-opaque under an X-ray. Risk factors include urinary tract infections, as well as vesicoureteral reflux and obstructive uropathies, both of which are also risk factors for urinary tract infections. A tiny minority of stones are cysteine stones, composed of the amino acid cysteine, which sometimes leaks into the urine to crystallize and form a yellow or light pink colored stone that's also radio-opaque under X-ray. Finally, there are some rare stones made of xanthine, which, just like uric acid, is a byproduct of purine breakdown. These stones, also like uric acid stones, are red-brown in color and radiolucent under an X-ray. Kidney stones can cause dull or localized flank pain in the mid to lower back on both sides, as well as renal colic, which is a sharp pain and is a bit of a misnomer because the pain's usually constant rather than intermittent. The pain is caused by the dilation, stretching, and spasm caused by obstruction of the ureter, and is typically worse at the uretopelvic junction and down the ureter, and subsides when the stone gets to the bladder. Stones that are less than 5 millimeters across are usually passed within hours. Diagnosis involves a history and physical exam, as well as imaging studies like X-ray, CT scans, or ultrasound. And finally, a urinalysis, because it might show microscopic or gross hematuria, which means blood in the urine. Treatment or management includes hydrating an individual to reverse the process of precipitation. Also, medications might be given to help reduce pain, reduce stone formation, like potassium citrate, and to help stones pass through, like alpha-adrenergic blockers and calcium channel blockers. Also, shockwave lithotripsy might be used, which is a non-invasive treatment that uses high-intensity acoustic pulses that travel through the body to break up the kidney stones. Finally, surgery and stent placement might be needed for larger stones. Alright, as a quick recap. Nephrolithiasis is the formation of kidney stones, which form when solutes precipitate out into crystals in the urine. The most common type of stones are calcium oxalate stones, though other types include uric acid stones and struvite stones. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Renal cortical necrosis, sometimes called diffuse cortical necrosis, can be explained by the name. Renal refers to the kidneys, cortical refers to the outer layer, and necrosis refers to tissue death. So renal cortical necrosis describes the outer layer of the kidney dying, usually because of ischemia, or lack of blood flow. Normally, around 20% of the blood leaving the heart goes into the renal arteries and through cortical radial arteries to reach the renal cortex, which is where the glomeruli of the nephrons are located. And that's a lot of blood, especially given that the kidneys are relatively smallish organs when you put them next to the brain and the liver. Literally millions of glomeruli work in the kidneys to filter that large volume of blood, and they do so at a rate called the glomerular filtration rate. It's also worth noticing that those cortical radial arteries are end arteries, meaning that they rarely anastomose with adjacent branches, and are therefore more susceptible to infarction, since a single blocked artery is all it takes to cause ischemia because the tissue can't be saved by neighboring arteries. Some causes of reduced blood flow or a complete blockage are thrombi, which are blood clots that fill the blood vessels, and vasospasm, which is the narrowing of a blood vessel. Interestingly, renal cortical necrosis has been associated with pregnancy complications, like placental abruption, which is when the placental lining is separated from the uterus, as well as prolonged intrauterine fetal death, which is when the fetus dies and then remains inside the uterus, and infected abortion, which is when there's an infection of the remnants of the placenta or fetus. All of these are obviously terrible complications, and they relate back to renal cortical necrosis because they can progress to septic shock or disseminated intravascular coagulation, both conditions that can lead to widespread formation of blood clots. So, once there's an obstruction of blood flow, tissue ischemia sets in, and this triggers inflammation in the renal cortex. That inflammation causes fluid to leak into the interstitium of the kidney, which is the space between the cells, and then trigger vasoconstriction of the afferent arterioles, which bring blood to the glomeruli of the nephrons. That vasoconstriction reduces the glomerular filtration rate, which is the amount of blood that gets filtered over time. Also, some parts of the nephron that happen to be in the cortex, like the proximal tubule and thick ascending loop of Henle, need more energy and therefore a bigger supply of blood to carry out their job of reabsorption. Since these cells are very energy demanding, having a reduced blood supply means that they're the first to start dying and detaching when there's renal ischemia. The dead epithelial cells can clog up the lumen of the nephron and cause an increase in pressure within that nephron. Since blood likes to move from a high pressure to a low pressure space whenever possible, a higher pressure inside the nephron reduces the glomerular filtration rate even more. Up to this point, if the obstruction goes away and normal blood flow is recovered, the damage to the kidney cells is generally reversible, and this is also known as acute tubular necrosis. If the blood flow isn't recovered, though, and the ischemia persists, then the ischemic damage eventually leads to an irreversible necrotic injury to the renal cortex. Broadly speaking, renal cortical necrosis is a type of prerenal acute kidney injury, which is a category that includes any cause of kidney injury that anatomically comes before the kidneys, like in this case, a decreased blood flow. The decrease in blood flow leads to one of the main symptoms, which is a sharp decrease in urine output. Renal cortical necrosis makes the kidney swell up and stretches out the renal capsule, and that can cause flank pain at the costovertebral angle. The diagnosis of renal cortical necrosis is often done by getting laboratory studies in the blood and urine. The blood typically has an excess of nitrogen waste products, like BUN and creatinine, as well as other serious electrolyte and metabolic imbalances, like hyperkalemia, increased potassium levels in the blood, and metabolic acidosis. The urine typically shows hematuria, blood in the urine, proteinuria, protein in the urine, and tubular cell casts, which are dead tubular cells in the mold of the tubule. Since there's no blood flow to the renal cortex, imaging studies like a contrast-enhanced CT scan usually shows a non-enhancing renal cortex. Sometimes a very thin rim of contrast enhancement can happen, and this is known as the cortical rim sign. In a biopsy, the kidney cortex might show patchy necrosis and atrophy, whereas the renal medulla looks pretty normal. Unfortunately, by the time the renal cortical necrosis is treated, the damage is usually irreversible, so the main goal is to increase blood perfusion to the renal cortex. Once kidney function is severely affected, hemodialysis might be needed. Alright, as a quick recap, renal cortical necrosis is an irreversible type of prerenal acute kidney injury caused by a sudden drop in blood perfusion to the renal cortex, and it's been associated with pregnancy complications. The reduced blood supply, due in part to a lack of anastomoses among radial end arteries, combined with a relatively high demand for blood in certain parts of the nephron, like the proximal tubule and the thick ascending loop of Henle, causes ischemia to set in.
On the nephrology ward, 2 people came in with the same symptoms: peripheral and periorbital edema, along with cola-colored urine, arterial hypertension, and decreased urine output. The first person is 10-year-old Timmy, who had a throat infection 2 weeks ago. The second one is 45-year-old Dorothy, who also presents with hemoptysis. Lab tests show that both of them have increased creatinine and BUN. On urinalysis, there's hematuria and red blood cell casts in the urine. A 24-hour protein collection was done and showed that both Timmy and Dorothy had proteinuria, but in both cases it was less than 3.5 grams per day. Now both Timmy and Dorothy have nephritic syndrome. Nephritic syndrome is typically caused by inflammation that damages the glomerular basement membrane, leading to hematuria and red blood cell casts in the urine. Eventually, this damage can lead to renal failure, where the individual can present with oliguria, arterial hypertension due to sodium retention, and peripheral and periorbital edema. Lab tests show high levels of BUN and creatinine, and on urinalysis there's hematuria, proteinuria, and RBC casts in the urine. A 24-hour protein collection is necessary to quantify how many proteins are lost through urine. Now, nephritic syndrome can be differentiated from nephrotic syndrome because the proteinuria is generally under 3.5 grams per day, or within the subnephrotic range. In severe cases, though, proteinuria can reach over 3.5 grams per day. In order to determine the cause, a careful history and a kidney biopsy can help diagnose the particular disease. Let's start talking about the different disorders that could cause nephritic syndrome. To make things simpler, we can categorize these into 3 groups. Those caused by type 3 hypersensitivity, like post-streptococcal glomerulonephritis, IgA nephropathy, and diffuse proliferative glomerulonephritis. Those with multiple potential causes, like membranoproliferative glomerulonephritis and rapidly progressive glomerulonephritis. And finally, Alport syndrome, which is caused by a defect in collagen synthesis. For the diseases that are only caused by a type 3 hypersensitivity reaction, let's start with acute post-streptococcal glomerulonephritis, or PSGN, which is most frequently seen in children, a very high-yield fact. Post-streptococcal glomerulonephritis can happen 2 to 4 weeks after a group A streptococcal infection of the pharynx or the skin, like impetigo. Some group A streptococci strains carry the M protein virulence factor, which initiates a type 3 hypersensitivity reaction, where antibodies, often IgG and IgM, form immune complexes with the bacterial antigen. These immune complexes travel to the glomerulus through the blood and deposit in the glomerular basement membrane, or GBM. Most of the time, they're subepithelial, meaning between the podocytes and the basement membrane. The immune complexes initiate an inflammatory reaction in the glomerulus, which involves activation and deposition of C3 complement, inflammatory cytokines, oxidants, and proteases that damage the podocytes. For your test, remember that lab tests show low levels of C3 in the blood, and strep titers and serologies are positive. Although a kidney biopsy isn't always necessary, when it's done, it can provide some specific clues. On light microscopy, the glomeruli are enlarged and hypercellular. On immunofluorescence, there are IgG, IgM, and C3 deposits along the glomerular basement membrane and the mesangium, which creates a specific starry sky appearance. On electron microscopy, there are subepithelial deposits which appear as humps. PSGN usually resolves on its own in children, but in adults it can sometimes lead to renal failure. So another high-yield fact is that age affects prognosis. Next on the list is IgA nephropathy, formerly called Berger's disease. This happens when abnormal IgA form in the body and the immune system recognizes them as foreign. In response, the body generates IgG antibodies that target these IgAs, forming immune complexes which travel through the bloodstream and then get trapped in the kidney. The immune complexes specifically deposit in the mesangium, which is the tissue in the Bowman's capsule that offers structural support to the glomerular capillaries. The IgA-IgG immune complexes activate the alternative complement pathway, leading to the release of pro-inflammatory cytokines and migration of macrophages into the kidney, all of which contributes to glomerular injury. What's absolutely important to remember for your tests is that IgA antibodies are mainly secreted by the mucosal tissues of the respiratory and GI tract. So a high-yield fact is that IgA nephropathy usually accompanies a respiratory or a GI infection. On light microscopy, there's mesangial proliferation. On immunofluorescence, there are IgA immune complexes in the mesangium, and on electron microscopy, the immune complexes are again seen in the mesangium. Okay, now your test might try to confuse you by presenting a similar disorder called IgA vasculitis, also known as Henoch-Schönlein purpura. Remember, the difference is IgA nephropathy only affects the kidneys, while IgA vasculitis can cause nephritic or nephrotic syndrome, but it also presents with colicky abdominal pain, bloody stool, arthritis, and palpable skin lesions. Let's move on to diffuse proliferative glomerulonephritis, which is often caused by systemic lupus erythematosus. Lupus is an autoimmune condition that affects multiple organs, including the kidneys. This is another example of type 3 hypersensitivity reaction, where immune complexes are formed and deposit in various parts of the body. Once they reach the kidney, they initiate an inflammatory reaction that leads to nephritic syndrome. Lupus nephritis is classified depending on the exact site of these immune complexes and subsequent inflammatory reaction. With diffuse proliferative glomerulonephritis, diffuse means that more than 50% of the glomeruli in both kidneys are affected. The most common site of deposition is in the subendothelial space, meaning between the endothelial wall and the glomerular basement membrane. On light microscopy, the immune complexes create an overall thickening of the capillary wall, which gives a wire loop appearance. On immunofluorescence, there are granular immune complexes. On electron microscopy, you can see subendothelial immune complexes. Okay, we've covered the conditions that are mainly caused by type 3 hypersensitivity reaction. Next, we'll talk more complex conditions that could have multiple causes. First, there's membranoproliferative glomerulonephritis, or MPGN. There are actually 3 types of MPGN, but they all cause proliferation of mesangial and endothelial cells in the glomerulus. We'll only go through the first 2, since the third type isn't well understood. Type 1 MPGN is the most common form, and it can be idiopathic or secondary to hepatitis B or hepatitis C infection. Type 1 MPGN usually starts one of 2 ways. The first way is through type 3 hypersensitivity reaction, where there are circulating immune complexes made from antibodies bound to antigens released from hepatitis B or hepatitis C infections. And this is another very high-yield fact. Over time, many of these immune complexes that circulate in the body reach the glomerulus and activate the complement system through the classical pathway, also causing complement deposition. These immune complexes end up in the subendothelium, meaning between the endothelial wall and the glomerular basement membrane. The second way is not caused by a hypersensitivity reaction, but it involves the inappropriate activation of the alternative pathway of the complement system. With this pathway, C3 is converted to C3A and C3B by an enzyme called C3 convertase. Inappropriate activation of this enzyme could be caused by a genetic mutation or a special IgG autoantibody called nephritic factor or C3NEF. This IgG binds to the C3 convertase, stabilizing it and allows it to continue working. This long-life C3 convertase keeps on converting C3 to C3A and C3B. This process consumes a lot of C3, so serum C3 levels are low. Since in this situation there's inappropriate activation of complement, there are no immune complex deposits with the complement deposits. Either way, in type 1 MPGN, the immune complexes and/or complement deposits end up in the subendothelium. These immune deposits recruit inflammatory cells to the area, causing inflammation and damaging the glomerulus. This in turn leads to the thickening of the basement membrane, which also triggers the mesangial cells to proliferate and reach through the thick basement membrane with their cytoplasmic arms. This process is called mesangial interposition, which sometimes causes the basement membrane to split around the mesangial cell, forming a duplication of the basement membrane or tram track appearance on light microscopy. Also, because of the immune complexes or complement deposits, the glomeruli also appear granular on immunofluorescence. Okay, next we have type 2 MPGN, which is also caused by nephritic factors but does not involve immune complexes. It's now classified as its own separate disease called dense deposit disease. Once again, this nephritic factor stabilizes the C3 convertase and allows it to keep on converting C3 to C3A and C3B. In this case, complement deposits in the basement membrane, as opposed to the subendothelium, as in type 1, which leads to inflammation in the basement membrane and low circulating levels of C3. MPGN shows the same tram track pattern on light microscopy. Let's move on to rapidly progressive glomerulonephritis, or RPGN. This is a very special type of glomerulonephritis that can be initiated by type 2 or 3 hypersensitivity reactions, or sometimes there are no immune complexes at all. Here, the inflammation in the glomerulus is so severe that it breaks the glomerular basement membrane, and as a result, the kidney function decreases rapidly in a matter of days to weeks. RPGN can be idiopathic, but when the cause is known, it can be split into 3 types. Type 1 is associated with Goodpasture disease, and it's a type 2 hypersensitivity reaction caused by anti-glomerular basement membrane, or GBM, antibodies that target the alpha-3 chain of collagen type 4 in the GBM and the alveolar basement membrane. Once these autoantibodies, usually IgG, bind to the alpha-3 chain, they activate the complement system, which damages the basement membrane as well as the nearby endothelium and the underlying organ itself. A similar process is also happening in the basement membrane of the lungs and causes widespread damage to the alveoli, leading to hemoptysis. Type 2 RPGN is another type 3 hypersensitivity reaction. Now sometimes, with both post-streptococcal glomerulonephritis and diffuse proliferative glomerulonephritis, the inflammation in the glomerulus is so severe that it causes the GBM to break, leading to RPGN. Finally, there's type 3 RPGN, which is caused by pauci-immune vasculitis. Pauci-immune means there's little or no anti-GBM antibodies or immune complex deposits. The 2 ANCA-associated vasculitis include granulomatosis with polyangiitis, or GPA, formerly known as Wegener's granulomatosis, and microscopic polyangiitis. Now, GPA classically affects the blood vessels supplying 3 organ systems: the upper respiratory tract, the lower respiratory tract, and the kidneys. Upper respiratory tract symptoms include chronic sinusitis, otitis media, mastoiditis, or even perforation of the nasal septum. Lower respiratory tract symptoms include hemoptysis. On your exam, don't confuse GPA with Goodpasture disease, which also presents with lower respiratory tract symptoms and glomerulonephritis. But there's no upper respiratory tract symptoms. For GPA, C-ANCA antibodies are present, and the histology would show non-caseating granulomas. Microscopic polyangiitis presents similarly to GPA, but upper respiratory tract symptoms are absent. Remember that a unique feature is that microscopic polyangiitis is precipitated by medications, especially antibiotics like penicillin. Also remember that unlike GPA, P-ANCA antibodies are present, and histology does not show granulomas. Now, whatever the underlying cause is, the common feature for RPGN is rapid and severe injury that causes the glomerular basement membrane to break. This allows material circulating in the blood, like red blood cells, inflammatory mediators, plasma proteins, and fibrin, to pass through into the Bowman space. Following this flood of material, more monocytes and macrophages enter the Bowman space, as well as parietal epithelial cells. The presence of all these foreign materials leads to the expansion of the normally thin epithelial layer of cells into a thick, characteristic crescent moon shape. Now, with all three types of RPGN, light microscopy shows a crescent moon shape in Bowman space, which is mostly made up of fibrin. Immunofluorescence patterns are different though. With Goodpasture disease, the immunofluorescence pattern will be linear, since antibodies bind to collagen of the glomerular basement membrane. Treatment of Goodpasture disease involves plasmapheresis in order to get rid of these bad antibodies. With type 2, the immune complexes randomly deposit in the subendothelial space, creating a granular pattern. Finally, with posse-immune vasculitis, you absolutely have to remember that immunofluorescence won't show any immunoglobulins or complement deposition. In this case, serum ANCAs are done to check for posse-immune glomerulonephritis. Finally, let's talk about Alport syndrome. This is actually a genetic disease where there's a mutation in the gene that codes for type 4 collagen. Without this type of collagen, the glomerular basement membrane becomes thin and splits. Alport syndrome also causes hearing loss during late childhood or adolescence, but the precise mechanism is unclear. Some patients with Alport syndrome also have retinopathy and lens dislocation. On electron microscopy, the glomerular basement membrane appears irregularly thin in some areas. There are also areas where the glomerular basement membrane is thicker and creates a basket weave appearance. Okay, let's review. With nephritic syndrome, there's inflammatory damage to the kidney that causes hematuria, peripheral and/or periorbital edema, arterial hypertension due to salt retention, and oliguria. Lab tests show high levels of creatinine and BUN, which means there's also kidney failure. Urinalysis shows hematuria with red blood cell casts in the urine, along with proteinuria that's below 3.5 grams per day. Nephritic syndrome can be caused by type 3 hypersensitivity reaction, and this is the case for post-streptococcal glomerulonephritis, IgA nephropathy, and diffuse proliferative glomerulonephritis. Other disorders can cause nephritic syndrome through multiple mechanisms, like with MPGN and RPGN. Finally, there's the genetic disease called Alport syndrome, which affects collagen synthesis. So remember, a careful history and a kidney biopsy are needed to determine the exact cause. Coming back to our individuals, Timmy is a young boy who has had a throat infection 2 weeks prior to the renal manifestations, which is consistent with post-streptococcal glomerulonephritis. This usually resolves on its own, and his prognosis is excellent. Then there's 45-year-old Dorothy that presents with hemoptysis and oliguria, which suggests Goodpasture disease. Further investigations showed that anti-GBM antibodies were positive, And the kidney biopsy showed the characteristic crescent shape seen with RPGN. Regarding treatment, immunosuppressive therapy is the treatment of choice.
Collagens are a family of proteins that are collectively the most abundant protein in the body and can be found throughout various connective tissues. Each member of the family is named with a Roman numeral, and if mutated or absent, it can lead to problems in the tissues where that particular collagen is found. Alport syndrome happens as a result of mutations in type 4 collagen, which is particularly important in the glomerulus of the kidney, the eye, and the cochlea, and that's why the symptoms of Alport syndrome are specific to those tissues. Type 4 collagen is a sheet-like structure found in all basement membranes and serves to support cells and form barriers. The three basement membrane layers are the lamina lucida, lamina densa, where type 4 collagen is, and lamina reticularis. Now, within the kidneys, there are glomeruli, which filter the blood and that, together with a tubule, form a nephron. These glomeruli happen to have basement membranes, called the glomerular basement membrane, or GBM. And that GBM, along with the fenestrated, meaning has pores, capillary endothelium, and the podocyte slit diaphragm, forms a selective filter, meaning that water and certain other plasma components can escape the capillary, forming the filtrate that will eventually become the urine. But red blood cells and most proteins stay in the glomerular capillary. In Alport syndrome, kidney functions normal through early childhood, but over time, the missing or non-functional type 4 collagen causes the GBM to become thin and overly porous. And this allows red blood cells to pass right through the capillary to the urinary filtrate, leading to microscopic hematuria, which is where red blood cells are seen in the urine under a microscope. And this might eventually lead to gross hematuria, where the red blood cells can be seen with the naked eye. Over time, excessive amounts of protein start to get through the filter, resulting in proteinuria, or protein in the urine. And finally, this excessive protein loss and other factors cause the GBM to undergo sclerosis. As there are less and less healthy glomeruli, somebody with Alport syndrome might develop renal insufficiency or even renal failure, which can lead to renovascular hypertension as well. Together, the hematuria, renal insufficiency, and hypertension contribute to the categorization of Alport syndrome as a glomerulonephritis. Another cause of glomerulonephritis, called Goodpasture syndrome, is caused by autoantibodies against the basement membrane in the glomeruli and the alveoli. So although abnormality in the basement membrane is from a different cause, the result is similar in these two syndromes. Another part of the body affected in Alport syndrome is the ear, which can lead to hearing loss, and usually this isn't present at birth, but starts in childhood or adolescence. And the precise mechanism behind this is unclear. One proposed mechanism involves the cochlea, or inner ear structure, which contains the organ of Corti, which has really small but highly specialized sets of hair cells that are attached to a basement membrane. Abnormal type 4 collagen might prevent those hair cells from generating normal nerve signals in response to sound vibrations. Because it's an inner ear problem, this is a type of sensory neural hearing loss, as opposed to middle ear and outer ear problems, which would lead to a conductive hearing loss. Some patients with Alport syndrome also have eye findings, which are also not typically present at birth. These include anterior lenticonus, where the middle part of the lens starts to push into the anterior chamber because the anterior lens capsule lacks the integrity to maintain the shape of the lens. Myopia or nearsightedness and lens opacities can result as well. Other eye changes in Alport syndrome include having white or yellow flecks around the macula, which is the central part of the retina, as well as having problems with the cornea, like recurrent erosions. Type 4 collagen is a heterotrimer, meaning that it's made up of 3 different polypeptide subunits, which are each composed of an alpha chain and that fit together in a triple helix. Each alpha chain has a very long repetitive amino acid sequence, with glycine followed by 2 variable amino acids, repeated over and over. Just remember that this is a repeat of amino acids, not a DNA triplet repeat. Now, glycine is the smallest amino acid, which allows it to fit tightly into the triple helix of collagen. If a mutation causes a larger amino acid to get put in place of glycine, then that regular helix can't be packed as tightly and might get degraded. Now there are 6 similar alpha chains to choose from when building a collagen 4 trimer, which are encoded by 6 genes with the names that start with COL4 for collagen 4, and then an A since they code for the alpha chains, and a number 1 to 6 to designate which alpha chain. One version of type 4 collagen combines the alpha 3, alpha 4, and alpha 5 chains. Another combines 2 alpha 1s and an alpha 2. And a third version has 2 alpha 5s and an alpha 6. The alpha 1, alpha 2 collagen 4 is present in basement membranes at birth, but during infancy it gets replaced by the alpha 3, alpha 4, alpha 5 collagen 4, particularly in the glomerulus, the inner ear, and the eyes. When there's a mutation in the COL4A3, A4, or A5 genes, then the alpha 3, alpha 4, alpha 5 heterotrimer is affected, and this causes Alport syndrome. COL4A5 is on the X chromosome, so mutations in it can cause X-linked Alport syndrome, which presents early on and is the most common form of Alport syndrome. COL4A3 and A4 are on autosomes, meaning non-sex chromosomes, and mutations in these cause either autosomal recessive Alport syndrome, which is also early onset, or autosomal dominant Alport syndrome, which causes late onset disease. Also, mild mutations in COL4A3 and A4 can cause thin basement membrane nephropathy, where microscopic hematuria is the only symptom. For diagnosis, Alport syndrome is typically suspected when there are clinical signs like gross hematuria, or if there are vision or hearing problems, or microscopic hematuria with no apparent cause. A family history of Alport syndrome is also a good clue, but it also might be absent in cases of recessive Alport syndrome or with new spontaneous mutations. To confirm the diagnosis, a kidney or a skin biopsy is often analyzed by immunohistochemistry, meaning a labeled antibody is applied to a biopsy sample on a slide. Since misfolded collagen tends to get degraded, absent staining for collagen alpha chain suggests Alport syndrome. Skin is easier to biopsy, and although it contains the alpha 5, alpha 6 form of type 4 collagen, it doesn't have any alpha 3 or alpha 4 chains, so it can only be used to detect alpha 5 chain mutations. Alternatively, the biopsy can be looked at under an electron microscope, which early in the disease would show GBM thinning, while later in the disease would show a GBM with both thin and thick abnormal segments, and a lamina densa that appears split, with strands that look like a woven basket. Finally, some people might have gene testing for the COL4A genes. The treatment for Alport syndrome usually focuses on the symptoms. Proteinuria is treated with angiotensin-converting enzyme inhibitors and/or angiotensin receptor blockers because there's evidence that this prevents progression to kidney failure. Anterior lenticonus can be treated with a replacement lens, and kidney failure might require dialysis or even a kidney transplant. Okay, as a quick recap, Alport syndrome is due to a mutation in gene COL4A, 3, 4, and 5, which encode for type 4 collagen alpha subunits 3, 4, and 5. And this causes kidney problems like hematuria and eventually glomerulonephritis, inner ear problems like sensorineural hearing loss, and eye problems like anterior lenticonus. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media. IgA is a class of immunoglobulin, or antibody, and nephropathy means kidney disease. IgA nephropathy, sometimes known as Bergère disease, is the most common form of nephropathy worldwide, and it happens when an abnormal IgA forms and deposits in the kidneys, causing kidney damage. IgA is the main antibody found in breast milk, tears, saliva, and the mucosal secretions of the respiratory tract, gastrointestinal tract, and genitourinary tract. Unlike other antibodies, IgA can be secreted out in pairs or a dimeric form called secretory IgA, which is literally two IgA antibodies attached together. By being bound together, it helps both antibodies avoid degradation by proteolytic enzymes in harsh environments like the gut. Now, IgA comes in two subclasses, IgA1 and IgA2. IgA1 is found mainly in the serum, while IgA2 is more often found in mucus secretions, typically in its dimeric form. Now, the hinge region of the IgA1 heavy chain, the part that gives the antibody a bit of flexibility to bind to multiple antigens without being torn apart, is made up of a string of amino acids. Among these are serine and threonine residues, which are O-linked glycosylated, meaning they have a sugar molecule, specifically galactose, attached to their oxygen. Now, these glycosylated IgA1 antibodies are identified by the body and degraded when too much of it accumulates. In IgA nephropathy, though, there's abnormal glycosylation of these serine and threonine residues, causing them to be galactose deficient. These galactose deficient IgA1s are not identified by the body, and therefore not degraded, allowing them to simply accumulate in the body. In addition, it's thought that these galactose deficient IgA1 antibodies are different enough from normal IgA1 antibodies that the body no longer recognizes them as self. In response, the body generates IgG antibodies that target the abnormally glycosylated residues, and these are known as anti-glycan IgG antibodies. When these anti-glycan IgG antibodies bind to abnormal IgA1, immune complexes are formed. These immune complexes can travel through the bloodstream where they get trapped at sites of filtration, like the kidney. IgA nephropathy is therefore a type 3 hypersensitivity disorder, meaning that pathology and inflammation will happen at the site the immune complexes deposit, not where they're formed. The immune complexes specifically deposit in the mesangium, which is the tissue in the Bowman's capsule that offers structural support to the glomerular capillaries. In fact, the mesangium is continuous with the smooth muscles of the afferent and efferent arterioles, and fills in the space between the loops of blood vessels, hence the name. When the abnormal IgA1, IgG immune complexes deposit in the mesangium, the alternative complement pathway is activated, leading to the release of pro-inflammatory cytokines and migration of macrophages into the kidney, all of which contributes to glomerular injury. Usually the glomerulus and mesangium help filter the blood to remove wastes while keeping larger proteins and cells, including red blood cells, from getting into the urine. So when there's glomerular injury, red blood cells sneak into the urine, causing hematuria, which contributes to this being a type of nephritic syndrome. Typically, IgA nephropathy presents in childhood as either microscopic or gross hematuria, meaning seen under a microscope or with the naked eye. And it typically develops during an infection involving the mucosal lining, like infections of the gastrointestinal or respiratory tract. In these sorts of infections, IgA1 antibody production gets ramped up, leading to IgG anti-glycan formation and immune complex deposition in the glomerular mesangium, causing inflammation. With each mucosal infection, the glomeruli undergo inflammation and injury. So over time, on the scale of decades, individuals may slowly progress to renal failure. The exact reason why the abnormal IgA1 forms in the first place is unclear, but genetic factors likely play an important role. On light microscopy, there'll often be mesangial proliferation, or expansion of the mesangium, and upon getting a closer look with electron microscopy, there'll be immune complexes deposited within the mesangium. Those immune complexes can also be visualized on immunofluorescence, although one important finding that can help differentiate from other immune complex-mediated nephropathies is that these complexes involve IgA. These findings, though, can also be found in another IgA-mediated disease, called Henoch-Schönlein purpura, or HSP. Except that in IgA nephropathy, only the kidneys involved, whereas in HSP, the kidneys can be affected, as well as the skin, connective tissue, scrotum, joints, and GI tract. Once the kidneys have been scarred, they can't be repaired. So treatment's mainly focused on preventing further damage and avoiding end-stage kidney disease. controlling the blood pressure can help by eating well and reducing salt and cholesterol intake, as well as by taking specific antihypertensive medication. Preventing the formation of immune complexes can help as well. Taking corticosteroids like prednisone can prevent an individual's immune system from making both the defective IgA1 as well as the anti-glycan IgG, which bind together to form the immune complexes. Alright, as a quick recap, IgA nephropathy is the most common cause of nephropathy worldwide, and it's a type of nephritic syndrome in which abnormal IgA1 immunoglobulin is targeted by anti-glycan autoantibodies, forming immune complexes that are then deposited in the glomerular mesangium, which then start up a type 3 hypersensitivity reaction, which causes glomerular injury and hematuria. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. The term lupus refers to systemic lupus erythematosus. Nephritis refers to the nephron, the Greek word for kidney, and itis means inflammation. So lupus nephritis refers to inflammation of the kidney that results from having systemic lupus erythematosus. Lupus is an autoimmune disease in which the immune system attacks various parts of the body, including the skin, the joints, lungs, heart, central nervous system, and of course, the kidneys. In fact, about half of all individuals with lupus develop some form of lupus nephritis. In lupus, what happens is that some cells have their DNA so badly damaged that the cell undergoes programmed cell death, or apoptosis, and it dies. This produces all these little apoptotic bodies, and exposes the insides of the cell, including parts of the nucleus, like DNA, histones, and other proteins, to the rest of the body. Now, with lupus, the immune system is more likely to think that the cellular parts are foreign, or antigens, and since they're from the nucleus, they're referred to as nuclear antigens, and immune cells try to attack them. Not only that though, individuals with lupus have less effective clearance, essentially meaning they aren't as good at getting rid of these apoptotic bodies, and so they end up having more nuclear antigens floating around. So as a result of all this, B cells start producing antibodies against these pieces of nucleus, which are called anti-nuclear antibodies. These anti-nuclear antibodies bind to nuclear antigens, forming antigen-antibody complexes, which drift away in the blood and deposit in various places, including the kidneys. These immune complexes can then initiate an inflammatory reaction, which is known as a type 3 hypersensitivity reaction. Lupus nephritis is classified into various types, depending on the exact site of these immune complexes and subsequent inflammatory reaction. The most common site of deposition is just underneath the capillary wall, also known as the endothelium. But deposits can also be within the Bowman space of the nephron, the basement membrane, or near the mesangial cells. The extent of inflammation within the kidney can be focal, which involves nephrons in just one area, or diffuse, involving almost all the nephrons in both kidneys. In the majority of cases, lupus nephritis presents as a nephrotic syndrome, which means that the damage to the nephron allows plasma proteins to get into the urine, which causes proteinuria, typically greater than 3.5 grams per day. An important protein in the blood is albumin, and so when it starts leaving the blood, people get hypoalbuminemia, low albumin in the blood. With less protein in the blood, the oncotic pressure falls, which lowers the overall osmotic pressure, which drives water out of the blood vessels and into the tissues, called edema. Finally, it's thought that as a result of either losing albumin or losing some protein or proteins that inhibit the synthesis of lipids, or fats, you get increased levels of lipids in the blood, called hyperlipidemia. Just like the proteins, these lipids can also get into the urine, causing lipiduria. And those are the hallmarks of nephrotic syndrome: proteinuria, hypoalbuminemia, edema, hyperlipidemia, and lipiduria. In some cases, though, lupus nephritis can present as a nephritic syndrome, which means that the damage to the nephron ends up allowing red blood cells to filter into the urine, which causes hematuria, or blood in the urine. The location of lesions and the extent of kidney injury often predicts whether the general presentation will be nephrotic versus nephritic syndrome, but is far from exact. And this brings us to the diagnosis of lupus nephritis, which typically requires a kidney biopsy. Deposition of immune complexes in the Bowman space results in a characteristic crescent-shaped swelling of the area, and deposition in the basement membrane can cause thickening of the structure, giving rise to a wire loop pattern. It's also possible to look for the presence of immune markers like complement proteins and immunoglobulins in the glomerulus by staining them with fluorescent markers. Lupus nephritis is treated the same way that lupus is treated, by suppressing the immune system. This is often done with corticosteroids, as well as with specific medications like mycophenolate and cyclophosphamide. Alright, as a quick recap, lupus nephritis is inflammation of the kidneys caused by lupus, and it can present as either nephrotic or nephritic syndrome. It happens due to the deposition of immune complexes in the nephron, which is a type 3 hypersensitivity reaction, and the resulting inflammation causes damage that can be detected on a kidney biopsy. Hey guys, thanks for watching. Hope you like that one. Those awesome illustrations come to you from Vincent, our other illustrator. The script was written by Debal and edited by Andrea and Rishi, and the voiceover was myself. Getting a big team, and it's really awesome. That's all I got for you, except to remind you to subscribe to our new subreddit, r/osmosit. Go check it out. It's super new, so it really needs some love. Other than that, you can always follow us on social media and donate to us on Patreon. All right, see you guys. Crescentic glomerulonephritis, which is sometimes called rapidly progressive glomerulonephritis, is a type of nephritic syndrome, meaning it involves inflammation of the kidney's glomeruli. This inflammation ultimately causes a proliferation of cells in the Bowman space, which forms a crescent shape, and this change leads to renal failure relatively quickly, within weeks to months. The development of crescents in Bowman space can happen in several ways. In some cases, it's idiopathic, meaning there's no identifiable cause. When the cause is identifiable, though, it can be split into several types. Type 1 is caused by anti-glomerular basement membrane, or GBM, antibodies that target the GBM. Type 1 is associated with Goodpasture syndrome, which also involves pulmonary hemorrhages. Type 2 is immune complex mediated, meaning caused by immune complexes, composed of antigens and antibodies. This might be the case with post-streptococcal glomerulonephritis, systemic lupus erythematosus, IgA nephropathy, and Heddock-Schoenlein purpura. And finally, type 3 is known as posse-immune, meaning little or no anti-GBM antibodies or immune complex deposits. In these cases, often anti-neutrophilic cytoplasmic antibodies, or ANCAs, are found in the blood, which are autoantibodies against the body's own neutrophils. Furthermore, you can break it down into the type of ANCA. C ANCA, or cytoplasmic ANCAs, are associated with Wagner granulomatosis. P ANCAs, or paranuclear ANCAs, on the other hand, are associated with microscopic polyangiitis and Churg-Strauss syndrome, the latter of which can be distinguished by having granulomatous inflammation, which is when immune cells attempt to wall off a substance perceived as foreign, asthma, and eosinophilia. Whatever the underlying cause is, the common feature is severe glomerular injury and the development of a crescent shape. Typically, as a result of cell-mediated immunity, as well as macrophage involvement, the glomerular basement membrane breaks. And this allows stuff circulating in the blood, like red blood cells, which can then go on to get into the urine, called hematuria, more inflammatory mediators, plasma proteins like complement C3b protein, and fibrin to pass through into the Bowman space. Following this flood of stuff, more monocytes and macrophages enter the Bowman space, as well as parietal epithelial cells, which proliferate. The presence of these monocytes and macrophages, plasma proteins, fibrin, and parietal epithelial cells lead to the expansion of the normally thin epithelial layer of cells into a thick, characteristic crescent moon shape. Over time, this crescent might also undergo sclerosis, or scarring, where it's replaced by connective tissue. Ultimately, the glomeruli are severely damaged, and the kidneys lose their ability to filter blood effectively, which means the glomerular filtration rate, or GFR, goes down. And if left untreated, crescentic glomerulonephritis can quickly lead to acute renal failure. On light microscopy, you'll see the characteristic moon or crescent-shaped glomeruli in all three types. The three types, though, can sometimes be differentiated on immunofluorescence. For type 1, the immunofluorescence pattern will be linear, since antibodies bind to the collagen of the glomerular basement membrane. For type 2, the immunofluorescence pattern will be granular, as a result of immune complex deposition in the subendothelium. Type 3, though, is actually negative on immunofluorescence, since remember it's posse-immune, and there usually aren't antibodies or immune complex deposits in the glomeruli, but rather type 3 is associated with ANCAs in the blood. Crescentic glomerulonephritis most often affects adults in their 50s and their 60s, and typically has a poor prognosis if not treated early. Anticoagulants might be used to reduce fibrin buildup in the formation of the crescent, and plasmapheresis is usually used in combination with immunosuppressants. If the renal failures become irreversible, they might need dialysis or a kidney transplant. Alright, as a quick recap, crescentic glomerulonephritis is a type of nephritic syndrome that's characterized by epithelial cell proliferation into a thick crescent or moon shape, which leads to hematuria, decreased glomerular filtration, and can rapidly progress to renal failure. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
On the nephrology ward, 2 people came in with the same symptoms, peripheral and periorbital edema. One of them is a 10-year-old Caucasian boy named Brian, who had recently been stung by a bee, and the other is a 55-year-old Hispanic individual named Gregory. Lab tests show that both of them have hypoalbuminemia, hyperlipidemia, and their urinalysis showed frothy urine with fatty casts. A 24-hour protein collection was done, which showed massive proteinuria with more than 3.5 grams of protein lost through urine per day. Both Brian and Gregory have nephrotic syndrome, but Brian has minimal change disease, while Gregory has focal segmental glomerulosclerosis. Nephrotic syndrome happens when the glomeruli are damaged and they become more permeable, so they start letting plasma proteins pass from the blood to the nephron and then into the urine. This leads to proteinuria, which is when more than 3.5 grams of protein is excreted through the urine per day. One of the proteins lost through urine is albumin, and this leads to hypoalbuminemia. This causes peripheral and periorbital edema since there's less oncotic pressure in the blood vessels, and then the fluid leaks out. On your tests, a nephrotic patient could also present with a hypercoagulable state, and you will need to understand the pathology. The reason for this is that the person is also losing antithrombin 3 proteins, which is the body's anticoagulant. This means that individuals with nephrotic syndrome are prone to thrombotic and thromboembolic complications. Immunoglobulins are another type of proteins lost through urine, which means that there's a higher risk for infection. Now, apart from proteins, lipids are also lost through urine, which gives the urine a frothy or foamy appearance. On microscopy, there could be fatty casts, which are hyaline from dead epithelial cells that contained a lot of fat globules. If these casts contain a lot of cholesterol, then under polarized light they will take on a classic Maltese cross appearance. It's also important to remember that one of the secondary changes in individuals with nephrotic syndrome is that the liver will increase lipoprotein synthesis, which results in hyperlipidemia. Now, nephrotic syndrome can be primary, due to direct sclerosis of podocytes on the glomerulus. There are 3 common causes of primary nephrotic syndrome: minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. Let's begin with minimal change disease, where a commonly tested fact is that this is the most common cause of nephrotic syndrome in children. The cause is most often idiopathic, and it can be triggered by a recent infection, recent vaccination, or by an immune stimulus, like a bee sting. It's also important to remember this disease is caused by T cells in the blood, releasing cytokines glomerular permeability factor that specifically damages the foot processes of the podocytes, making them flatten out, a process called effacement. Damaged foot processes lose their negatively charged coat, eventually allowing negatively charged molecules, like albumin, to slip into the nephron. Even though albumin goes through, other larger proteins like immunoglobulins do not. So for your exam, it's important to remember that in minimal change disease, there's selective proteinuria, in contrast to other causes of nephrotic syndrome, which are characterized by non-selective proteinuria. On light microscopy, the glomeruli look completely normal. In some cases, there can be lipids in the proximal tubular cells. Immunofluorescence is negative. The only changes are seen on electron microscopy, where there's effacement of podocyte foot processes. The last high-yield fact is that idiopathic minimal change disease is the only nephrotic disease that can be consistently treated with corticosteroids. Next is focal segmental glomerulosclerosis, which is the most common cause of nephrotic syndrome in individuals of African or Hispanic descent. Focal segmental glomerulosclerosis is more common in adults and can be idiopathic, but the most common clues test makers give are a history of heroin abuse, HIV infection, interferon treatment, or congenital malformations. The cause of focal segmental glomerulosclerosis is not exactly known yet, but what you need to know is that just like minimal change disease, there's effacement of podocyte foot processes. Additionally, with focal segmental glomerulosclerosis, there's also hyalinosis that's caused by deposition of lipids and proteins in the glomerulus. Over time, hyalinosis further develops into sclerosis or scar tissue. On light microscopy, there's sclerosis and hyalinosis among the glomeruli. For your tests, it's important to understand that in focal segmental glomerulosclerosis, segmental means that only a segment or part of the glomeruli is affected, and focal means that only some of the glomeruli are affected. Immunofluorescence is often negative, but can sometimes be positive for deposits of C3, C1, or IgM. Unlike primary minimal change disease, primary focal segmental glomerular sclerosis has an inconstant response to corticosteroids, and some individuals may progress to chronic kidney disease. Next on the list is membranous nephropathy, and it's important to remember it can be primary or secondary to systemic lupus erythematosus drugs like NSAIDs, gold, or penicillamine, infections, particularly Hep B, Hep C, or syphilis, and solid tumors, colorectal carcinoma being one example that comes up sometimes on tests. It's also important to remember that with membranous nephropathy, the damage is caused by immune complexes. These immune complexes are called subepithelial deposits because they build up right between the podocytes and the glomerular basement membrane. These subepithelial deposits are thought to activate the complement system, which directly damages both the podocytes as well as mesangial cells. One major antigen that's been identified is the phospholipase A2 receptor, or PLA2R. So a high-yield fact is that in the serum of individuals with membranous nephropathy, you can find IgG antibodies against PLA2R. On light microscopy, there's diffuse capillary and glomerular basement membrane thickening caused by immune complexes deposition. Now, there are a couple clues that could help you confirm the diagnosis. When the sample is stained with silver methenamine, irregular expansions from the glomerular basement membrane can be seen. Immunofluorescence will show that the immune complexes are granular and mostly made up of IgG and C3. On electron microscopy, there's flattening of the podocyte foot processes and subepithelial deposits of immune complexes. Now, there are thin expansions of the glomerular basement membrane that separate or surround the immune complexes, creating spike and dome patterns. Membranous nephropathy has a poor response to corticosteroids, and individuals may progress to chronic kidney disease. Nephrotic syndrome can also be secondary to a systemic disease, such as amyloidosis or diabetes mellitus. First, there's diabetic glomerular nephropathy. Try saying that 3 times fast. It's the most common cause of end-stage renal disease in the US. When there's a lot of glucose in the blood, it can stick to proteins in the blood. This is called non-enzymatic glycation. And because glucose can get through the endothelium, this process of glycation can also involve the basement membrane of the efferent arteriole, making it thicken and creating an obstruction that increases the pressure in the glomeruli. It's important to remember that the problem occurs when the efferent arteriole thickens, meaning it's harder for blood to leave, and eventually the afferent arteriole dilates, further increasing the pressure. High pressure in the glomerulus leads to an increase in the glomerular filtration rate, and this is called hyperfiltration. In response to this high-pressure state, the mesangial cells secrete more and more structural matrix expanding the size of the glomerulus. This matrix deposition and mesangial expansion happen uniformly, or it can result in little nodules within the mesangium called Kimmel-Steele-Wilson nodules, which are tiny little balls of protein. So, for your exam, remember the following clues. On light microscopy, there's mesangial expansion, glomerular basement membrane thickening, and Kimmel-Steele-Wilson nodules. Also remember that early detection for diabetic glomerular nephropathy can be done by screening for microalbuminuria. Last but not least, there's systemic amyloidosis. Amyloids are actually just proteins with an abnormal shape, which makes them stick together and settle in tissues. Amyloidosis is the name for the disease that develops as a result of the tissue damage from these protein depositions. The kidneys often get affected by amyloidosis. The important clue they often give is that on light microscopy, Congo red staining makes amyloid take on a characteristic pink color. When it's seen under polarized light, the amyloid proteins appear apple green in color and are localized in the mesangium. Okay, to review. Regardless of cause, nephrotic syndrome presents the same. There's periorbital and peripheral edema, frothy urine, massive proteinuria, typically above 3.5 grams per day, hypoalbuminemia, and hyperlipidemia. All individuals with nephrotic syndrome are in a hypercoagulable state and also have a higher risk for infections. Nephrotic syndrome can be primary when there's direct damage of the podocytes, like with minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy, or can be secondary to a systemic disease, like with diabetic glomerular nephropathy and amyloidosis. In order to determine the exact cause of nephrotic syndrome, a careful history is taken and a kidney biopsy is done. Coming back to our individuals, Brian is a young boy and he has minimal change disease that was triggered by an immune stimulus, the bee sting. Brian will be treated with corticosteroids and his prognosis is excellent. On the other hand, Gregory has focal segmental glomerulosclerosis that is probably associated with the fact that he is of Hispanic descent. Regarding treatment, corticosteroids will likely be less effective. And that's the nephrotic syndrome pathology in a nutshell.
In amyloidosis, amyloid refers to starch-like, and it goes back to an observation made by the German scientist Rudolf Virchow, who saw mysterious deposits in the tissue that stained blue with iodine, just like plant starch. As it turns out, amyloids are actually just proteins that take on an abnormal shape, which makes them stick together and settle in tissues. And amyloidosis is the name given for the disease that develops as a result of the tissue damage from these protein deposits. Normally, our cells produce thousands of proteins each and every moment, and these proteins need to fold into a particular shape in order to do their jobs properly. If a protein folds incorrectly, it's normally spotted right away and destroyed by proteases, which are enzymes that chop up larger proteins into tiny little bits. In amyloidosis, there are a few different ways that protein folding can go wrong. One way is when normal proteins are produced in enormous amounts, and just a small fraction of them folds incorrectly. A second option is that abnormal proteins with incorrect amino acid sequences are produced in normal amounts, and they fold incorrectly. Either way, the misfolded proteins, called amyloids, start to build up. Sometimes there's simply too many of them for the proteases to handle, and other times the way that they're folded makes them tough to break down. It's a bit like a pistachio that doesn't have an opening for your fingers to work with. Nightmare. When the amyloid proteins get excreted out of the cell, they tend to clump together, forming a rigid, insoluble structure called a beta sheet, like a folded sheet of paper, kind of. These beta sheets then deposit in the extracellular space of tissues and cause damage. So amyloidosis is a process where there are extra protein deposits, and there are many different proteins and diseases that follow that same underlying process. In general, amyloidosis can be systemic, meaning that those protein deposits occur in multiple organ systems, or it can be localized, meaning that they occur in one organ. Until recently, systemic amyloidosis was further broken down into primary amyloidosis, which is where amyloidosis was thought to be the main problem, and secondary amyloidosis, which is where there was another known disease process that resulted in the protein deposits. However, this isn't totally accurate, since an underlying disease process has been identified even in the primary form. Okay, so AL amyloidosis, previously known as primary amyloidosis, is where the A refers to amyloidosis, and L refers to the immunoglobulin light chain as the protein that gets misfolded and deposited. In plasma cell disorders, like multiple myeloma, plasma cells in the bone marrow produce more light chains than heavy chains, and those excess light chains leak out into the blood. Since there are so many light chains, some misfold into AL proteins and build up in various tissues. In AA amyloidosis, previously known as secondary amyloidosis, the misfolded protein comes from serum amyloid A. Now, under normal circumstances, serum amyloid A is a properly folded protein that's an acute phase reactant, meaning that it's secreted into the bloodstream by the liver whenever there's inflammation. But when inflammation goes on for too long, like in rheumatoid arthritis, inflammatory bowel disease, various cancers, or hereditary immune disorders like familial Mediterranean fever, there's a lot of serum amyloid A in the blood. And a small proportion of the serum amyloid A spontaneously folds incorrectly into AA amyloids, which end up accumulating within tissues, creating amyloidosis. In systemic amyloidosis, amyloids deposit in various organs. In the kidneys, amyloid deposits can damage the podocytes, which are the cells that line the glomerulus. When the podocytes are damaged, proteins like albumin spill into the urine, which results in proteinuria, protein in the urine, typically greater than 3.5 grams per day, and hypoalbuminemia, which is low albumin in the blood. Over time, with less protein in the blood, the oncotic pressure falls, and that drives water out of the blood vessels and into the tissues, called edema. Albumin and other proteins normally inhibit the synthesis of lipids, or fat, so losing them leads to hyperlipidemia, which is increased levels of lipid in the blood. Those are the hallmarks of nephrotic syndrome: proteinuria, hypoalbuminemia, edema, and hyperlipidemia. Now, in the heart, amyloid deposits can make the heart walls stiff and non-compliant, and that can lead to something called restrictive cardiomyopathy, which is when the ventricle is unable to stretch out and fill up with blood. Over time, that can lead to congestive heart failure. Amyloid deposits can also interfere with the electrical conduction system of the heart, causing arrhythmias, or an irregular heartbeat. In the intestines, amyloid deposits can damage the tips of the intestinal villi, which are the tiny finger-like projections that increase the surface area available for absorbing nutrients. When the villi are damaged, nutrients don't get absorbed and simply end up in the stool. Amyloid deposits can also build up in the liver, spleen, or tongue, making them enlarge. Finally, amyloid deposits can injure peripheral nerve fibres, like the ones carrying sensory or motor signals, or autonomic nerves that control things like digestion and blood pressure. In localized amyloidosis, amyloid deposits in a single organ, and a well-known example is Alzheimer's disease. Alzheimer's disease is a neurodegenerative disease, caused when proteins called A-beta peptides collect in one organ, the brain. These A-beta peptides clump together and form plaques that sit outside of the neurons and interfere with neuron-to-neuron signaling. Amyloid plaques also deposit in the walls of the blood vessels in the brain, called amyloid angiopathy, which weakens the walls of the blood vessels and increases the risk of hemorrhage or rupture. These plaques can trigger an inflammatory response that can cause damage to the neurons, over time leading to problems with brain function, like memory. Another example of localized amyloidosis is familial amyloid cardiomyopathy, also known as ATTR amyloidosis. This is a genetic disorder where the mutant transthyretin protein, or TTR, is misfolded and deposits in the heart tissue, causing restrictive cardiomyopathy. In contrast, there's also senile cardiac amyloidosis, which is when the normal TTR protein gradually begins to deposit in the heart. This only becomes a problem, though, when it's gone on for a long time, so mostly just affects the elderly. Amyloids can also deposit in the pancreas. For example, in diabetes mellitus type 2, the beta cells of the pancreas, found in the islets of Langerhans, pump out more insulin than normal. But along with increased insulin production, beta cells also secrete an increased amount of a protein called islet amyloid A peptide, or amylin. Over time, amylin aggregates between beta cells in the islets of the pancreas, causing inflammation, which leads to damage and beta cell death. The symptoms of amyloidosis can vary widely, depending on what damage is caused. With kidney damage, there's swelling in the face, ankles, and legs. Heart damage can lead to palpitations and shortness of breath, and intestinal damage can cause malabsorption and weight loss. Some individuals develop a large tongue, which can interfere with speech and swallowing, and cause noisy breathing at night. Nerve damage can lead to numbness or pain in the fingers and toes, as well as alternating bouts of diarrhea and constipation, or orthostatic hypotension, meaning that blood pressure falls, causing the person to feel lightheaded whenever they're standing up. The central nervous system is often spared, except in Alzheimer's disease, where the main symptoms are memory loss and difficulty learning new skills. The diagnosis of amyloidosis typically requires a biopsy of the involved organ, or by doing a fat pad biopsy, which is when the fat is taken from the abdomen. The sample is then dyed with a special Congo red staining, which makes amyloid take on a characteristic pink colour. When it's seen under polarised light, the amyloid proteins appear apple green in colour. When it comes to treatment, unfortunately, there's no effective way to remove the amyloid deposits. So if there's extensive damage to an organ, then organ transplantation can be tried. Okay, so let's have a quick recap then. Amyloidosis is caused by misfolded amyloid fibril deposits, which can be systemic in multiple organ systems, like the kidney, the heart, and intestines, or localized to the brain in Alzheimer's disease, or the pancreas in diabetes mellitus type 2. In tissue biopsy, Congo red stain makes the amyloid proteins go pink, and under polarized light they appear apple green.
Hey everyone, Sarah here. Cheers for watching that video on amyloidosis. I hope it made the subjects a bit simpler. It was quite a long video, but you've made it this far, so well done. So the script was written by Antonia Saniotti, and it was edited by Rishi Desai and Ifan Chow. And then I did the illustration and the voiceover, and the whole video was edited and put together by Sam Gillespie. So thanks, Osmosis. I hope you liked it. Either way, we'd love to hear your comments, so chuck them in the comments section. And if you haven't seen that we've got loads of other videos, then make sure you subscribe to our YouTube channel. But what you might not know is that we actually have loads more videos that aren't on YouTube on our website, which is osmosis.org. And as well as loads of videos, we've also got flashcards, questions, timetabling program that helps you sort out your whole life when it comes to studies. And that's not just for medicine, although it's fantastic for medicine, but also for other healthcare subjects. So make sure you get to osmosis.org and do that. And I look forward to making the next video for you. Bye!
Focal segmental glomerulosclerosis, or sometimes focal glomerular sclerosis, or just sometimes FSGS, is a type of kidney disease that affects the kidney's glomeruli, which is where small molecules are first filtered out of the blood and into the urine. From the name, you have glomerulosclerosis, which indicates sclerosis, or scar tissue, forming in the glomeruli. Segmental means that only a segment, or part of that glomeruli, is affected. And focal means that among all those glomeruli in the kidney, only some are affected. Those glomeruli that are affected, though, allow proteins to filter through into the urine, and ultimately people with FSGS develop nephrotic syndrome. But what exactly is nephrotic syndrome? Well, usually the glomerulus only lets small molecules, like sodium and water, move from the blood into the kidney nephron, where it eventually makes its way into the urine. But with nephrotic syndromes, the glomeruli are damaged and they become more permeable. So they start letting plasma proteins come across from the blood to the nephron and then into the urine, which causes proteinuria, typically greater than 3.5 grams per day. An important protein in the blood is albumin, and so when it starts leaving the blood, people get hypoalbuminemia, low albumin in the blood. With less protein in the blood, the oncotic pressure falls, which lowers the overall osmotic pressure, which drives water out of the blood vessels and into the tissues, called edema. Finally, it's thought that as a result of either losing albumin or losing some protein or proteins that inhibit the synthesis of lipids, or fat, you get increased levels of lipids in the blood, called hyperlipidemia. Just like the proteins, these lipids can also get into the urine, causing lipiduria. And those are the hallmarks of nephrotic syndrome: proteinuria, hypoalbuminemia, edema, hyperlipidemia, and lipiduria. So FSGS is a type of nephrotic syndrome. That's helpful. But why does the glomerulus develop segmental sclerosis in the first place? Well, primary FSGS is when it's idiopathic, or there's no clear underlying cause. What is known, though, is that the podocytes, which are the cells that have these long tentacle-like projections called foot processes, that wrap around the capillaries in the glomeruli, are damaged. These damaged podocytes allow some plasma proteins and lipids to sneak by, which then go on to get into the urine. Not only that, though, over time some of these proteins and lipids get trapped and build up in the glomerulus, resulting in hyalinosis, where the tissue has a hyaline or glassy appearance on histology. And it's thought that over time these areas move on to develop sclerosis, or scar tissue. Some research suggests that these changes in FSGS are a continuation from another nephrotic syndrome called minimal change disease, which is also characterized by podocyte injury. Other research suggests that minimal change disease and FSGS have different mechanisms of podocyte injury. Fundamentally, FSGS is a histopathologic description, basically what it looks like under a microscope, which could be the end result of a number of different pathophysiologic mechanisms. As opposed to primary FSGS, secondary FSGS is when there's a clear underlying cause, and there are several important conditions that can be associated. Sickle cell disease, where blood cells are sickle-shaped due to a structurally abnormal hemoglobin protein that can cause tissue ischemia, has been linked to FSGS. HIV, a retrovirus that infects various human cell types, can also lead to FSGS and is called HIV-associated nephropathy. Heroin abuse has also been linked to FSGS, which is called heroin nephropathy. Also, other conditions like kidney hyperperfusion or increased perfusion of blood, as well as increased pressure in the glomerular capillaries, have been linked to FSGS as well. Alright, so on histology, there'll be segmental sclerosis and hyalinosis of the glomeruli, and under electron microscope, there's effacement of the foot processes of the podocytes, and on immunofluorescence, there might be nonspecific focal deposits of IgM and complement proteins, and these get trapped in areas of hyalinosis, but these aren't always seen. FSGS is the most common cause of nephrotic syndrome in African Americans and Hispanics, and can affect both children and adults. FSGS is usually treated with steroids, although it has an inconsistent response, and for that reason, especially in adults, FSGS can involve more and more segments of the kidney's glomeruli, to the point where it causes chronic renal failure. Alright, so as a quick recap, focal segmental glomerulosclerosis is a nephrotic syndrome characterized by sclerosis and hyalinosis in some, but not all, glomeruli, and usually only affects part of the glomeruli that it does affect. Membranoproliferative glomerulonephritis, or MPGN, is a kidney disease triggered by immune deposits which end up in the walls of the glomerulus, which are the tufts of capillaries where blood is filtered. These deposits lead to inflammation and result in structural changes to the glomerulus that causes a decrease in kidney function, which commonly presents as a nephrotic syndrome. But what exactly is nephrotic syndrome? Well, usually the glomerulus only lets small molecules, like sodium and water, move from the blood into the kidney nephron, where it eventually makes its way into the urine. But with nephrotic syndromes, the glomeruli are damaged and they become more permeable. So they start letting plasma proteins come across from the blood to the nephron and then into the urine, which causes proteinuria, typically greater than 3.5 grams per day. An important protein in the blood is albumin, and so when it starts leaving the blood, people get hypoalbuminemia, low albumin in the blood. With less protein in the blood, the oncotic pressure falls, which lowers the overall osmotic pressure, which drives water out of the blood vessels and into the tissues, called edema. Finally, it's thought that as a result of either losing albumin or losing some protein or proteins that inhibit the synthesis of lipids, or fat, you get increased levels of lipids in the blood, called hyperlipidemia. Just like the proteins, these lipids can also get into the urine, causing lipiduria. And those are the hallmarks of nephrotic syndrome: proteinuria, hypoalbuminemia, edema, hyperlipidemia, and lipiduria. Okay, so membranoproliferative glomerulonephritis is a type of nephrotic syndrome. Got it. But how exactly do these glomeruli start letting plasma proteins like albumin through? Well, with MPGN, there are actually 3 types. So let's go through them one by one. Type 1 MPGN is the most common form, and it usually starts one of 2 ways. The first way involves circulating immune complexes, made up of antigens and antibodies, that might form, for example, because of antigen release from a chronic infection, like hepatitis B or hepatitis C, which then gets bound by the antibody in the blood. Over time, a lot of these immune complexes might find their way to the glomerulus, and then cause an activation of the classical complement pathway, leading to complement protein deposition right alongside the immune complex deposits. The second way involves the inappropriate activation of the alternate complement pathway. Specifically with this pathway, C3 is converted to C3a and C3b by the enzyme C3 convertase. Inappropriate activation could mean a mutation in or autoantibody against proteins that regulate this process. On the flip side, since C3 convertase usually only exists for a short time, there could also be inappropriate activation if there's an IgG antibody that actually binds to C3 convertase, which makes the C3 convertase more stable, causing it to exist for longer periods of time, which means it keeps on converting C3 to C3a and C3b. This special IgG autoantibody is called nephritic factor, or C3NEF, and is responsible for some of the cases of type 1 MPGN. Since in this situation there's inappropriate activation of complement, there are no immune complex deposits with the complement deposits. Either way, the actual mutation or autoantibody triggering all this trouble isn't always known. But what is known is that the immune complexes and/or complement deposits end up in the subendothelium, meaning between the endothelial layer and the basement membrane of the glomerular capillaries. These immune deposits recruit inflammatory cells to that area, which release oxidants and proteases that end up damaging the capillary wall. In addition to all this, that inflammation triggers the thickening of the basement membrane, which also triggers the mesangial cells of the glomerulus to start to proliferate or divide and reach through the thick basement membrane with their cytoplasmic arms. This process is called mesangial interposition, which sometimes causes the basement membrane to split around the mesangial cell, forming a duplication of the basement membrane or tram track appearance on light microscopy. Also, because of the immune complexes, the glomeruli also appear granular on immunofluorescence. Okay, so type 2 MPGN generally involves only complement deposits and does not involve immune complexes, and actually is now classified as its own separate disease, called dense deposit disease. The leading mechanism causing type 2 MPGN is the same IgG autoantibody called nephritic factor that we talked about in type 1. Except now this mechanism is responsible for nearly all of the cases. Once again, this nephritic factor stabilizes the C3 convertase and allows it to keep on converting C3 to C3a and C3b. In this case, though, complement deposits in the basement membrane, as opposed to the subendothelium as in type 1, which leads to 1. Inflammation in the basement membrane, and 2. Low circulating levels of C3. Most cases of dense deposit disease don't show the same tram track pattern, and it's not quite clear how these complement abnormalities induce changes in the glomeruli. Alright, so finally we've got type 3 MPGN, but this guy's shrouded in even more mystery. This type seems also to be an immune complex and complement disease like type 1, but in addition to finding deposits in the subendothelial space, there also seems to be deposits found in the subepithelial space, though again, many of the mechanisms leading to glomerular changes aren't well understood. Regardless of the differences between these three types of MPGN, they can all present as nephrotic syndrome, usually characterized by proteins in the urine. But in addition to this, they can also present as nephritic syndrome, since they all involve some sort of inflammation, with characteristic findings of hematuria, or blood in the urine, oliguria, abnormally low production of urine, azotemia, or increased nitrogen-containing compounds in the blood, and hypertension. For treatment, sometimes steroids might be given to suppress the immune system, although responses have been inconsistent, and all three types of MPGN can progress to chronic renal failure. Alright, so super quick recap. Type 1 MPGN is caused by either immune complex or complement deposits in the subendothelium. Type 2 MPGN, or dense deposit disease, is when complement deposits are found in the basement membrane. And type 3 MPGN is where immune complexes or complement deposits are found in the subepithelium as well as possibly the subendothelium. All three typically lead to nephrotic symptoms, but occasionally nephritic symptoms as well. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Membranous glomerulonephritis, also known as membranous nephropathy, is where the glomerular basement membrane, or GBM, which lines the glomeruli in the kidney, becomes inflamed and damaged, which results in increased permeability and proteins being able to filter through into the urine, causing nephrotic syndrome. But what exactly is nephrotic syndrome? Well, usually the glomerulus only lets small molecules, like sodium and water, move from the blood into the kidney nephron, where it eventually makes its way into the urine. But with nephrotic syndromes, the glomeruli are damaged and they become more permeable. So they start letting plasma proteins come across from the blood to the nephron and then into the urine, which causes proteinuria, typically greater than 3.5 grams per day. An important protein in the blood is albumin, and so when it starts leaving the blood, people get hypoalbuminemia, low albumin in the blood. With less protein in the blood, the oncotic pressure falls, which lowers the overall osmotic pressure, which drives water out of the blood vessels and into the tissues, called edema. Finally, it's thought that as a result of either losing albumin or losing some protein or proteins that inhibit the synthesis of lipids or fat, you get increased levels of lipids in the blood, called hyperlipidemia. Just like the proteins, these lipids can also get into the urine, causing lipiduria. And those are the hallmarks of nephrotic syndrome: proteinuria, hypoalbuminemia, edema, hyperlipidemia, and lipiduria. Alright, so with membranous glomerulonephritis, the basement membrane becomes damaged, which causes nephrotic syndrome. How does that happen though? Well, ultimately this damage is caused by immune complexes. Complexes composed of an antigen with an antibody bound to it. One way these complexes can form is as a result of autoantibodies directly targeting the glomerular basement membrane. Two major antigen targets that have been identified are the M-type phospholipase A2 receptor and neutral endopeptidase, which are both expressed on the podocyte surface, the cells that line the basement membrane. And we know this because in a large proportion of cases, people with membranous glomerulonephritis have antibodies against these autoantigens in their bloodstream. Immune complexes, though, might also form outside the kidney, and then get carried through the bloodstream to the glomerulus and deposit in the basement membrane. One potential circulating antigen that's been identified is cationic bovine serum albumin, which is present in cow's milk and beef protein, and can escape the intestinal barrier, cause immune complex formation, and deposit in the GBM. Whether they bind directly to the GBM or come from somewhere else, these immune complexes are called subepithelial deposits because they're sandwiched right between the epithelial cells, or podocytes, and the GBM. These subepithelial deposits are thought to activate the complement system, which is a cascade of enzyme activation that ultimately produces the membrane attack complex, which directly damages both the podocytes as well as mesangial cells, which are the cells that work to remove trapped residue and debris. The immune reaction also recruits inflammatory cells that release proteases and oxidants, which damage the basement membrane and cause it to become leaky, allowing proteins to filter through into the urine, which causes the signs and symptoms of nephrotic syndrome. Over time, as a reaction to the immune deposits, GBM matrix is deposited in between the immune complexes, which makes the GBM appear thickened on histology. But if you take a closer look on electron microscopy, you'll see that this pattern of GBM matrix on the subepithelial deposits creates a characteristic spike and dome pattern. And you'll also see effacement or flattening of the foot processes of the podocytes. Finally, on immunofluorescence, you'll see deposits of immune complexes, which appears granular or sort of sprinkled throughout the GBM. Membranous glomerulonephritis most commonly affects Caucasian adults, and it can be primary or idiopathic, meaning it's not quite clear why these complexes form, and this accounts for the vast majority of cases. The rest of the cases, though, are secondary, and seem to arise from autoantibodies that are generated in response to another process, like an infection or malignancies, autoimmune conditions, or medications. If it is secondary to some other disease, then usually treatment starts by treating the underlying disease. If it's primary or idiopathic, then steroids are sometimes used, but they've been shown to have mixed results. If it goes untreated or treatment's not successful, then membranous glomerulonephritis can progress to chronic renal failure. Alright, as a quick recap, membranous glomerulonephritis is where immune complexes deposit in the GBM, which causes a thickening of that GBM and a spike and dome appearance that leads to nephrotic syndrome. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Minimal change disease, sometimes called nil disease, affects the millions of the kidney's glomeruli, which are the specific parts of the kidney where small molecules are first filtered out of the blood and into the urine. Specifically, it's a type of nephrotic syndrome. In fact, the most common nephrotic syndrome seen in children. But what exactly is nephrotic syndrome? Well, usually the glomerulus only lets small molecules, like sodium and water, move from the blood into the kidney nephron, where it eventually makes its way into the urine. But with nephrotic syndromes, the glomeruli are damaged and they become more permeable. So they start letting plasma proteins come across from the blood to the nephron and then into the urine, which causes proteinuria, typically greater than 3.5 grams per day. An important protein in the blood is albumin, and so when it starts leaving the blood, people get hypoalbuminemia, low albumin in the blood. With less protein in the blood, the oncotic pressure falls, which lowers the overall osmotic pressure, which drives water out of the blood vessels and into the tissues, called edema. Finally, it's thought that as a result of either losing albumin or losing some protein or proteins that inhibit the synthesis of lipids, or fat, you get increased levels of lipids in the blood, called hyperlipidemia. Just like the proteins, these lipids can also get into the urine, causing lipiduria. And those are the hallmarks of nephrotic syndrome: proteinuria, hypoalbuminemia, edema, hyperlipidemia, and lipiduria. Okay, so minimal change disease is a type of nephrotic syndrome. Got it. But how exactly do these glomeruli start letting plasma proteins like albumin through? Well, usually in the glomerulus, you've got your endothelial cells lining the capillaries, then the basement membrane, and then the podocytes, which are the cells that have these long tentacle-like projections called foot processes. And this is also why they're called podocytes, since podo refers to the foot. Those foot processes have a negatively charged coat that helps repel negatively charged molecules, like albumin, thereby acting as a charge barrier. With minimal change disease, although not completely known, it's thought that the T cells in the blood release cytokines that specifically damages the foot processes of the podocytes, making them flatten out, a process called effacement. This means that there's less of a charge barrier, right? And albumin is allowed to slip through from the blood into the nephron. Even though albumin goes through, other larger proteins like immunoglobulin aren't allowed through. And so with minimal change disease, there's selective proteinuria. The exact identity and mechanism of these ominous T cell cytokines, though, still remains a mystery. As far as causes of minimal change disease goes, in most cases it's idiopathic, meaning the cause is unknown. Although one interesting clue is that it's associated with Hodgkin's lymphoma, possibly because of the general increase in cytokine production in that disease. For diagnosis, minimal change disease can be kind of tricky. With only light microscopy and H&E stain, you can't see the foot process effacement. And so it seems like there's no change to the glomerulus, hence the names minimal change and nil disease. With electron microscopy, though, you can see effacement of foot processes. Also, immunofluorescence with minimal change disease is usually negative, since the damage is due to cytokines, not immune complex deposition. Treatment of minimal change disease is typically corticosteroid therapy, of which about 90% of children respond very well. Adults also respond well to corticosteroid therapy, but the response is generally slower. In both cases, though, there's a potential for relapse. Alright, so as a short recap, minimal change disease is a nephrotic syndrome thought to be caused by cytokine damage to the foot processes of the podocytes in the glomeruli of the kidney. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
Acute pyelonephritis is an upper urinary tract infection that typically occurs when bacteria, most commonly E. coli, make their way from the lower urinary tract, such as the urethra and bladder, up the ureters and kidneys. Now, based on the patient's clinical features, Acute pyelonephritis can be classified as complicated or uncomplicated. Complicated pyelonephritis occurs when the patient has functional or structural abnormalities like neurogenic bladder or like urinary obstruction due to nephrolithiasis. Complicated pyelonephritis also occurs when the patient has specific host risk factors, such as immunosuppression, advanced age, or male sex. On the other hand, a patient has uncomplicated pyelonephritis when there are no urinary tract abnormalities and no host-specific risk factors. Now, if you suspect acute pyelonephritis, you should first perform an ABCDE assessment to determine if they are stable or unstable. Unstable individuals might present with signs of sepsis or shock, like tachycardia and hypotension, so don't forget to stabilize their airway, breathing, and circulation. Additionally, obtain IV access, administer supplemental oxygen, and put your patient on continuous vital sign monitoring. Okay, let's return to the ABCDE assessment. If the patient is stable or once you stabilize them, obtain a focused history and physical examination. Your patient will likely report fever, chills, malaise, flank pain, nausea and vomiting, and sometimes dysuria. On the other hand, physical exam may reveal elevated body temperature, hypotension, tachycardia, costovertebral angle and flank tenderness, and abdominal tenderness to palpation. At this point, you should suspect pyelonephritis. So your next step is to order labs, including CBC and CMP, as well as urinalysis and urine cultures. So, upon reviewing the labs, the CBC will reveal a leukocytosis with a left shift, and the CMP might show an elevated BUN and creatinine, indicating renal insufficiency. The urinalysis will generally reveal pyuria and bacteriuria, and possibly hematuria, nitrates, leukocyte esterase, and WBC casts. Okay, now we can make a confident diagnosis of acute pyelonephritis. So your next step is to determine whether or not your patient requires hospitalization. Outpatient management is reserved for individuals that can tolerate oral intake, adhere to a treatment plan, and have no coexisting conditions. Some important conditions to keep in mind include diabetes, renal insufficiency, a history of nephrolithiasis, or anatomical abnormalities of the urinary tract. In a patient that meets these criteria, you should proceed with medical therapy, which consists of oral hydration and empiric antibiotics. Now, due to increasing fluoroquinolone resistance, you should give a parenteral antibiotic like a cephalosporin prior to starting an oral fluoroquinolone. An example would be intramuscular ceftriaxone followed by oral ciprofloxacin. Next, review the culture results that were previously ordered. These results will hopefully identify the pathogen within a few days and allow you to tailor antibiotics based on culture results. Now, once you start tailored antibiotics, expect a response to treatment within 72 hours. If they are improving, then the response is adequate and you can be confident that they have pyelonephritis. On the other hand, if your patient is not improving, then they have failed outpatient therapy and you should suspect complicated pyelonephritis. In this case, you'll want to admit them to the hospital to proceed with inpatient management. Okay, let's switch gears and discuss inpatient management of pyelonephritis. This type of management is reserved for individuals who cannot tolerate oral intake, have failed outpatient treatment, might not adhere to the treatment plan, or have coexisting conditions that require inpatient treatment. In these individuals, there is a greater risk for complications, such as obstruction and abscess formation. While you are waiting for your culture results, begin medical therapy with IV hydration and empiric IV antibiotics, such as ceftriaxone or piperacillin tazobactam, and assess the patient's response to treatment. If the patient improves and response is adequate, They can be discharged to complete treatment as an outpatient, which would require making arrangements for IV antibiotic administration or transitioning to oral antibiotics. However, if there's no clinical improvement after 72 hours on IV antibiotics, you should order imaging to identify the potential cause, which you could then treat in order to resolve the pyelonephritis. CT is primarily used to look for things such as nephrolithiasis, an anatomical abnormality, or some obstructing outflow of urine such as malignancy or abscess. For example, imaging may reveal an obstructing renal stone resulting in pyelonephritis, where pyelonephritis can be seen on CT as decreased cortical enhancement and surrounding paranephric stranding compared to normal kidney. These individuals have complicated pyelonephritis. In these individuals, tailor antibiotics based on culture results and consult the appropriate surgery team. Ultrasound can also be used to look for potential causes and can be the first choice in patients with contraindications to CT, like pregnancy, or if CT is not available. On the other hand, normal renal ultrasound and CT findings are highly suggestive of uncomplicated pyelonephritis, so tailor antibiotics based on culture results and assess the patient's response. If they are improving, the response is adequate, so the patient might be able to complete the treatment as an outpatient, either continuing IV antibiotic administration or transitioning to oral antibiotics. However, if the patient is not improving or they are worsening, suspect undiagnosed complicated pyelonephritis, in which case you want to repeat urine cultures as well as imaging. Sometimes you might need to consult your surgical team. Now, here's a clinical pearl to keep in mind. Not all cases of complicated pyelonephritis are found on imaging. Pyelonephritis associated with sepsis or septic shock is considered complicated and should be treated more aggressively with broad-spectrum antibiotics. Also, while infections of the urinary tract are prevalent in biologically female individuals, their presence in a biologically male individual is always considered complicated and should prompt urologic evaluation. Alright, as a quick recap, if you suspect acute pyelonephritis, first do an ABCDE assessment. If unstable, stabilize the airway, breathing, and circulation. Additionally, obtain IV access, administer supplemental oxygen if needed, and put your patient on continuous vital sign monitoring. On the other hand, in stable individuals, order labs, primarily CBC, CMP, as well as urinalysis and urine cultures. Next, determine if your patient requires hospitalization. Outpatient management is reserved for individuals that can tolerate oral intake, adhere to the treatment plan, and have no coexisting conditions. In this case, suspect uncomplicated pyelonephritis and proceed with oral hydration and empiric antibiotics. Once you get urine culture results, tailor antibiotics and assess the patient's response. If they are improving, complete the current antibiotics. But if your patient is not improving, you should suspect complicated pyelonephritis. In this case, admit them to the hospital for inpatient management and immediately start empiric therapy with IV hydration and IV antibiotics. This type of management is reserved for individuals who have failed outpatient treatment, cannot tolerate oral intake, might not adhere to the treatment plan, or have some coexisting conditions. Next, if there's no clinical improvement after 72 hours, order ultrasound or CT to look for evidence of complications, such as obstruction from malignancy or nephrolithiasis, anatomical abnormality, or abscess. If you find evidence of complicated pyelonephritis, tailor antibiotics based on culture results and make sure to consult the surgery team. On the flip side, normal ultrasound and CT findings are suggestive of uncomplicated pyelonephritis, so again, tailor antibiotics based on culture results. Lastly, assess the patient's response. If they are improving, the patient could complete the treatment as an outpatient, either arranging for IV antibiotic administration or transitioning to oral antibiotics. However, if they are not improving, suspect undiagnosed complicated pyelonephritis and repeat urine cultures as well as imaging. Additionally, consider consulting your surgical team.
With acute pyelonephritis, pyelo means pelvis, and neph refers to the kidney. So in this case, it's the renal pelvis, which is the funnel-like structure of the kidney that drains urine into the ureter. And itis means inflammation. So acute pyelonephritis describes an inflamed kidney that develops relatively quickly, usually as a result of a bacterial infection. Now, a urinary tract infection, or UTI, is any infection of the urinary tract, which includes the upper portion of the tract, the kidneys and the ureters, and the lower portion of the tract, the bladder and the urethra. So acute pyelonephritis is a type of upper urinary tract infection. Acute pyelonephritis is most often caused by ascending infection, meaning bacteria start by colonizing the urethra and bladder, which would be a lower urinary tract infection, and make their way up the ureter to the kidney. Therefore, upper UTI shares a lot of the same risk factors as lower UTI. Things like female sex, sexual intercourse, indwelling catheters, diabetes mellitus, and urinary tract obstruction. One major factor that increases the risk of an upper UTI from a lower UTI spreading upward is vesicoureteral reflux, or VUR, which is where urine's allowed to move backward up the urinary tract, which can happen if the vesicoureteral orifice fails. The vesicoureteral orifice is the one-way valve that allows urine to flow from each ureter into the bladder, but not in the reverse direction. VUR can be the result of a primary congenital defect, or it can be caused by bladder outlet obstruction, which increases pressure in the bladder and distorts the valve. As kind of a double whammy, obstruction also leads to urinary stasis, where urine stands still, which makes it easier for bacteria to adhere and colonize the urinary tract. So, for ascending infections that cause acute pyelonephritis, the most common organisms are E. coli, Proteus species, and Enterobacter species, all of which are commonly found in the bowel flora. Now, it's also possible that the kidneys get infected via hematogenous infection, or spread through the bloodstream, although this is a lot less common. Usually, pyelonephritis from hematogenous spread is a consequence of septicemia or bacteremia, which is bacteria in the blood, as well as infective endocarditis, an infection of the inner layer of the heart. In these situations, the most common organisms are Staphylococcus species and, again, E. coli. Acute pyelonephritis is most often unilateral, meaning it affects just one kidney. And when bacteria mount an attack, they usually start by adhering to the renal epithelium of the tubules, which triggers an inflammatory response. Chemokines attract neutrophils to the renal interstitium, but typically the glomeruli and vessels of the kidney are spared. As neutrophils infiltrate and die off, they make their way through the urinary tract and are peed out. So people with acute pyelonephritis often have white blood cells in their urine. Sometimes the cells and the surrounding inflammatory protein debris is even casted into the shape of the tubule, which is then also peed out and is called a white blood cell cast. Patients also can present with increased white blood cells in their blood, called leukocytosis. And as a result of the inflammatory immune response, patients can also develop fevers, chills, nausea and vomiting, as well as flank pain at the costovertebral angle. These systemic symptoms are what often distinguish acute pyelonephritis from a lower urinary tract infection. Treatment's typically antibiotics and making sure that the individual stays well hydrated. Like most bacterial infections, there's also a possibility of a renal abscess that can form as a complication. Also, if there are recurrent infections, which can be the case in people with an anatomic problem that allows bacteria to easily cause infections, then it can lead to chronic pyelonephritis, as well as papillary necrosis, or death of the renal papillae tissue, which has a much worse prognosis because that can affect the kidney's overall ability to function. Alright, as a quick recap, acute pyelonephritis is typically a bacterial infection of the upper urinary tract, which usually develops from a lower urinary tract infection, especially in individuals with vesicoureteral reflux. The infection causes systemic symptoms like fevers and flank pain at the costovertebral angle and is treated with antibiotics. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. With chronic pyelonephritis, pyelo means pelvis, and neph refers to the kidney. So in this case, it's the renal pelvis, which is the funnel-like structure of the kidney that drains urine into the ureter. And itis means inflammation. This inflammation is usually caused by bacterial infection of the kidney, which is called acute pyelonephritis. When somebody has recurrent episodes of acute pyelonephritis, the kidney becomes visibly scarred, at which point it's referred to as chronic pyelonephritis. Now, a urinary tract infection, or UTI, is any infection of the urinary tract, which includes the upper portion of the tract, the kidneys and the ureters, and the lower portion of the tract, the bladder and the urethra. So acute and chronic pyelonephritis are types of upper urinary tract infections. Now, an episode of acute pyelonephritis often clears up without much complication. Certain people, though, are predisposed to having recurring bouts of acute pyelonephritis, which eventually leads to chronic pyelonephritis and permanent scarring of the renal tissue. The most common risk factor for recurrent acute pyelonephritis and therefore chronic pyelonephritis is vesicoureteral reflux, or VUR, which is where urine's allowed to move backward up the urinary tract, which can happen if the vesicoureteral orifice fails. The vesicoureteral orifice is the one-way valve that allows urine to flow from each ureter into the bladder, but not in the reverse direction. VUR can be the result of a primary congenital defect, or it can be caused by bladder outlet obstruction, which increases pressure in the bladder and distorts the valve. That being said, chronic obstruction is its own independent risk factor for chronic pyelonephritis. Obstructions in the urinary tract causes urinary stasis, meaning it tends to cause urine to stand still, which makes it easier for bacteria to adhere to and colonize the tissue, making lower UTIs more likely and therefore upper UTIs more likely. Bilateral obstruction increases pressure in the bladder, and therefore affects both kidneys. Causes of this include congenital malformations, like posterior urethral valve, which obstructs the flow of urine through the urethra, as well as benign prostatic hyperplasia in men, which is an enlarged prostate, and cervical carcinoma in women, both of which might compress the urethra shut. Obstructions could be unilateral as well, which would be a little higher up and affect only one kidney, as in the case of urinary calculi or kidney stones. Although one episode of inflammation might not lead to any permanent damage, recurrent episodes of inflammation eventually leads the renal interstitium to undergo fibrosis and scarring, and those renal tubules atrophy, and these changes are generally found in the upper and lower poles of the kidney. Also, on imaging studies, like for example computed tomographic urogram, or CTU, the renal calyces become blunted or flattened. On histology, some tubules might be dilated and full of glassy-appearing proteinaceous material called colloid that forms as a result of chronic inflammation. This material ends up being shaped like the tubules and therefore forms colloid casts. And since this material happens to look a little like thyroid tissue, this process is sometimes referred to as thyroidization of the kidney. Those colloid casts can then get peed out and show up in the urine. A rare type of chronic pyelonephritis is called xanthogranulomatous pyelonephritis, or just XGP, which happens when an infected kidney stone causes chronic obstruction. The combination of infection and increased pressure creates granulomatous tissue, which is full of foamy or fat-laden macrophages and can easily be confused for a kidney tumor on imaging. Treatment for chronic pyelonephritis involves correcting the underlying cause of recurrent infection, which could be surgery to correct congenital structural causes or to remove obstructions like kidney stones. In some cases, though, dialysis or nephrectomy, which is removal of some or all of the kidney, might be needed. Alright, as a quick recap, chronic pyelonephritis is where the kidney develops permanent scarring as a result of recurring bouts of acute pyelonephritis, which is bacterial infection and inflammation of the kidney. The two major predisposing factors to developing chronic pyelonephritis are vesicoureteral reflux and chronic obstruction. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Nephronophthisis, which means nephron wasting, and medullary cystic kidney disease, which refers to fluid-filled sacs in the medulla, are two kidney diseases that share some similar features. They're both genetic, they both affect the nephrons, and they both can lead to kidney cysts and renal failure over time. To help understand these diseases, let's first take a zoomed-in look at a nephron and talk about how it works. Alright, so the outer layer of the kidney is called the cortex, and this is where the glomeruli live, which is where blood is initially filtered into the nephron, as well as the proximal convoluted tubule, where some of the filtered substances are reabsorbed back into the body. The filtered substances, or filtrate, that don't get reabsorbed then moves down the medulla via the descending and ascending parts of the loop of Henle. The filtrate then goes back to the cortex just briefly in the distal convoluted tubule, and then returns back to the medulla in the collecting duct. Zooming back out a bit, the collecting ducts in each region of the kidney, called a renal pyramid, converge on the renal papilla, which dumps fully formed urine into a minor calyx. From there, the urine goes into the major calyx, and soon after it goes into the ureter and the bladder. And finally, zooming back in, surrounding each nephron's tubule is the tubular interstitium, a hypertonic environment optimized to help reabsorb water and other substances from the tubules. Alright, so in nephronophthisis, which presents in childhood, the tubules atrophy and the interstitium gets infiltrated by macrophages and becomes fibrotic. Inflammation of the tubules and the interstitium qualifies nephronophthisis as a tubulointerstitial nephritis. But don't confuse this with nephritic syndrome, which is where red blood cells and protein escape in the urine as a result of damage to the glomerulus. In nephronophthisis, the affected tubules lose their ability to concentrate the urine by reabsorbing water and other substances back to the body. So urine ends up being more dilute than usual, which leads to polyuria, excessive urination, and therefore polydipsia, or excessive drinking. Sodium wasting also happens, which is where excess sodium gets excreted in the urine. But proteinuria, or proteins in the urine, as well as hematuria, or blood in the urine, typically aren't seen in nephronophthisis. Later on in the disease, the glomeruli can become sclerosed, or scarred, and cysts might pop up in the medulla, particularly in the corticomedullary junction, which is where the cortex meets the medulla. Over time, this leads to renal insufficiency, or poor renal function, which can cause uremia, or too much urea in the blood, and anemia from a failure of the kidneys to make erythropoietin. Eventually, this leads to renal failure, usually in the teenage years. Nephronophthisis is broken into subtypes by the age of onset, like for example infantile versus juvenile, or by the gene that's mutated, of which there are over a dozen possible mutated genes, all of which are inherited in an autosomal recessive fashion, though the most common is NPHP1, which codes for nephrocystin 1 protein. Most nephronophthisis genes encode for and therefore affect proteins in primary cilia or a related organelle, the centriole. A primary cilium is present on almost every human cell, and it's a tiny appendage that projects outside the cell and conveys sensory input to the inside of the cell. The centriole, on the other hand, is the main component of the centrosome, and helps organize the mitotic spindle and microtubules during cell division. When there are defects in these structures, the epithelial cells lining the kidney are seriously affected, and this leads to the tubule atrophy seen in nephronophthisis. Primary cilia and other parts of the body rely on these proteins too, which explains why other organ systems can be affected by nephronophthisis. For example, it can cause liver fibrosis or situs inversus, where the major visceral organs are reversed from their normal positions. On the flip side, medullary cystic kidney disease, or MCKD, has similar kidney changes as nephronophthisis, like tubulo-interstitial fibrosis and inflammation, tubular atrophy, cysts in the medulla and corticomedullary junction, and eventually glomerular sclerosis. MCKD is also clinically similar, with progression to polyuria and polydipsia from poor urine concentration, as well as salt wasting and eventually renal insufficiency and renal failure. Some differences are that MCKD starts in adulthood and doesn't have symptoms in other organs except for hyperuricemia because of a failure to excrete uric acid, which causes gout. Also, there are two types of medullary cystic kidney disease, one called MCKD1, which is caused by mutations in the MUC1 gene, and the other called MCKD2, which is caused by mutations in the UMOD gene. And both of these conditions are autosomal dominant. For diagnosis, nephronophthisis and medullary cystic kidney disease might be suspected when an individual has polyuria or polydipsia as an early symptom, or if there's a family history of the disease, or if there's a finding on imaging like kidney cysts. To confirm the diagnosis, a renal biopsy or genetic testing can be done, and based on the severity of the disease, treatment primarily involves dialysis and kidney transplant. Having said all that, it's important to remember that renal cysts can be caused by a lot of other diseases, and they can also just be simple renal cysts, which are common, age-related findings that tend to be in the cortex and don't usually cause any problems. Okay, as a quick recap, nephronophthisis and medullary cystic kidney disease are genetic disorders that affect the renal tubules and interstitium and can lead to cysts and renal failure. Nephronophthisis presents in childhood, is autosomal recessive, and can involve other organs, whereas medullary cystic kidney disease presents later on, is autosomal dominant, and affects only the kidney. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Medullary sponge kidney, also known as Cacchi-Ricci disease, is a congenital disease where the medullary part of the kidney, which is deeper inside the kidney, gets loaded with fluid-filled cysts, which gives the kidney the appearance of a sponge. Now the kidney can be divided into the cortex, which is the outer layer, and the medulla, which is the layer below that. Kidneys have millions of tiny nephrons, which filter the blood, each of which is like a little tube that receives blood on one end in the cortex. From there, the nephron dips into the medulla, and then goes back out into the cortex, and finally dips back into the medulla a second time to connect to the collecting ducts, which gather up all the urine. Not every nephron has this exact structure, but a lot of them do. From there, the urine drains through the papilla, which is an inverted cone-shaped pyramid that, like a showerhead, pours urine into the calyces, which comes from the Latin calyx, which means large cup, kind of like a fancy Roman chalice. From there, it enters the renal pelvis, which funnels the urine into the ureter, then to the bladder, and then finally leaves the body out the urethra. Now, medullary sponge kidney has to do with the development of the kidney. So, during fetal development, first off, you've got this structure called the mesonephric duct, which is involved in development of urinary and reproductive organs. And during the 5th week of gestation, a little guy called the ureteric bud starts pushing its way into another structure called the metanephric blastema. And together, these two little embryologic structures go on to develop into a kidney. At about the 7th week, nephrogenesis, or formation of the kidneys, starts under the influence of that ureteric bud. By about 20 weeks, the ureteric bud has formed the ureters, the renal calyces, collecting ducts, and collecting tubules, while the metanephric blastema develops into the nephron itself, which includes the epithelial cells and the podocytes of the Bowman's capsule. In the 3rd trimester and throughout infancy, the kidneys continue to grow and mature. Although not completely known, it's thought that medullary sponge kidney is a result of some sort of abnormal induction of the metanephric blastema by the ureteric bud. This failure might be the fault of the mesonephric duct not forming right, or the ureteric bud not forming right, or both. Whatever the case, in medullary sponge kidney, the hallmark features are dilated collecting ducts, meaning enlarged, as well as small cysts that form around the collecting ducts. Even though medullary sponge kidney is present at birth, sometimes complications don't pop up until adulthood, and even then they might come and go. The most common one is nephrolithiasis, or developing kidney stones, which are made of calcium phosphate or calcium oxalate. These form in the collecting ducts and surrounding tissue, and these result mostly from a failure of the kidney cells to properly reabsorb or secrete solutes, which ultimately results in stone formation. For example, there might be high levels of calcium, phosphate, and oxalate in the urine, all of which are not very soluble. In addition, there might be low levels of substances like citrate in the urine, which would normally increase their solubility. Making matters even worse, medullary sponge kidney can lead to metabolic acidosis, which can cause calcium to leach out of the bones, which raises the amount of calcium that gets filtered through the kidneys. Together, the kidney stones and cysts obstruct urine flow, creating pockets of stagnant urine. Those stagnant pools of urine allow more time for solutes to precipitate and crystallize into stones, which creates this vicious cycle of stone formation. Ultimately, a kidney that's full of cysts and stones with areas of stagnant urine also invites bacteria to flourish, resulting in urinary tract infections. So, the symptoms of medullary sponge kidney are related to these complications. Kidney stones tend to cause bouts of extreme pain and blood in the urine from tissue damage, and urinary tract infections can cause fevers as well as pain. Medullary sponge kidney is usually diagnosed by medical imaging. For example, an intravenous pyelogram is a type of X-ray that uses contrast to show the enlargement and hyperdensity of the collecting ducts and cysts. These tend to show a classic feathered appearance of the ducts at the interface of the papilla and calyx. Treatment of medullary sponge kidney might target preventing stones from forming, which includes keeping an individual well hydrated, taking citrate supplements to make calcium more soluble, and taking bicarbonate supplements to prevent calcium from getting leached out of the bones. If small stones develop, they can be broken down with focused shock waves, or surgically removed before they get bigger. Finally, complications like urinary tract infections can be managed with antibiotics. Alright, as a quick recap. Medullary sponge kidney is a congenital disorder where the medulla is full of large collecting ducts as well as cysts. To make matters worse, the nephrons can become dysfunctional, which allows high levels of calcium, phosphate, and oxalate in the urine, which can precipitate out and form kidney stones. Together, these cysts and stones can predispose an individual to getting infections. How's it going, guys? Hope you liked that video. It was written by Amanda and edited by Rishi and then illustrated by myself. Don't have much else for you besides to remind you to check out our subreddit called r/osmosit. It's pretty new and needs some subscribers. So go there and check out some of the videos and post some comments, classic subreddit things. Otherwise, you can always subscribe to our YouTube channel, donate to us on Patreon, as well as follow us on social media. All right, guys. See you later. Multicystic dysplastic kidney, or MCDK, is a congenital disease where one or both kidneys don't form quite right, specifically causing them to not drain urine properly, which results in urine building up in the kidneys and forming multiple fluid-filled sacs called cysts. Alright, so during fetal development, first off you've got this structure called the mesonephric duct, which is involved in development of urinary and reproductive organs. And during the 5th week of gestation, a little guy called the ureteric bud starts pushing its way into another structure called the metanephric blastema. And together these two little embryologic structures go on to develop into a kidney. At about the 7th week, nephrogenesis, or formation of the kidneys, starts under the influence of the ureteric bud. By about 20 weeks, the ureteric bud has formed the ureters, the renal calyces, collecting ducts, and collecting tubules, while the metanephric blastema develops into the nephron itself, which includes the epithelial cells and the podocytes of the Bowman's capsule. In the 3rd trimester and throughout infancy, the kidneys continue to grow and mature. Although not completely known, it's thought that MCDK is a result of some sort of abnormal induction of the metanephric blastema by the ureteric bud. This failure might be the fault of the mesonephric duct not forming right, or the ureteric bud not forming right, or both. Regardless of the cause of the failure, the ureteric bud's supposed to go on to form the ureters, as well as the rest of the tubules that branch out to collect urine. So as blood starts coming in to be filtered, and urine starts getting produced, a failure to properly develop into these urine-collecting tubules means that the urine has nowhere to go, and so it builds up in the kidneys and forms these fluid-filled cysts that are composed of abnormal connective tissue, especially cartilage, that actually replaces normal kidney tissue and decreases the kidney's ability to function. Most cases are actually unilateral, meaning they affect only one kidney, although sometimes it might be bilateral, where both are affected. MCDK is usually a sporadic condition that happens during development and does not follow a clear inheritance pattern, which is an important distinction from polycystic kidney disease, a similar cystic kidney disease that's familial, meaning inherited, and in this case it's typically passed through autosomal dominant inheritance. Having said that, there are some genetic syndromes, like papillorenal syndrome, that have been associated with MCDK, as well as some genes that might play a role, like EYA1, SIX1, and the PAX2 gene. Certain prescription drugs taken for maternal hypertension, like ACE inhibitors, as well as illicit drugs like cocaine, have also been implicated as potentially causing MCDK in the developing fetus. If only one kidney's been affected and the other's functioning normally, the remaining kidney might be able to preserve overall kidney function. If it's bilateral and mild, the newborn might need dialysis and/or a kidney transplant. But newborns with severe bilateral MCDK usually don't survive. Alright, so as a quick recap, multicystic dysplastic kidney is a type of non-inherited congenital kidney disease where the ureteric bud fails to develop properly, resulting in a buildup of urine and formation of cysts. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. On the nephrology ward, 2 people came in. The first one is 55-year-old Matilda, who came in with oliguria, fever, and a rash on her arm. Matilda also has a history of taking NSAIDs for her knee pain. The second one is 34-year-old George, who came in with oliguria, hypotension, tachycardia, and cold extremities. George says that he's also been having diarrhea for a few days now. BUN and creatinine levels were high for both of them. Both Matilda and George have renal failure. Now, renal failure is when the kidneys are not functioning properly. Before talking specifics, let's remember some basic renal physiology. Now, the kidney's job is to regulate what's in the blood, so they might remove waste, or make sure electrolyte levels are steady, or regulate the amount of water, and even make hormones, like erythropoietin, which stimulate red blood cell production. Alright, so blood gets into the kidney through the renal artery, into clumps of arterioles called glomeruli where filtration happens. After filtration, the stuff that gets filtered out, which is called the filtrate, moves into the renal tubules, where reabsorption and secretion of fluid and electrolytes happen. Along with fluid and electrolytes, though, waste-containing compounds are also filtered, like urea and creatinine, although some urea is actually reabsorbed back into the blood, whereas only a tiny bit of creatinine is reabsorbed. In fact, in the blood, the normal ratio of blood urea nitrogen, or BUN, to creatinine is between 5 and 20 to 1, meaning the blood carries 5 to 20 molecules of urea for every 1 molecule of creatinine. And this is a pretty good way to assess kidney function. So when we want to check renal function, we look at BUN and creatinine levels. And if there's something wrong, then levels of both BUN and creatinine will be high. Now back to renal failure. There are 2 types of renal failure, acute and chronic. Acute renal failure is also called acute kidney injury. This is when the kidney is not functioning at 100%, and that decrease in function develops relatively quickly, typically over a few days. In this case, the individual typically presents with oliguria, even anuria, and levels of BUN and creatinine will be high. Then there's chronic kidney failure, which is now called chronic kidney disease. This is when the kidney function gradually decreases over a minimum of 3 months. This is usually caused by hypertension, diabetes mellitus, or congenital renal conditions. Both acute and chronic renal failure have some pretty dire consequences. A lot of things that the kidneys normally excrete are now stuck in the body. First, hydrogen ion secretion is impaired, and this can lead to metabolic acidosis. Secondly, potassium excretion is also impaired, and this can lead to hyperkalemia. Now, in certain cases, like heart failure, pulmonary edema, or hypertension, the kidney will retain more water and sodium. So the individual can present with peripheral or periorbital edema. Next, there's uremia, which is caused by the accumulation of uremic toxins, including urea itself. Symptoms include nausea and anorexia. Another sign of uremia is bleeding and easy bruising, and that's due to platelet dysfunction. There's also uremic pericarditis, which is the inflammation of the pericardium. Next, there's uremic neuropathy, affecting the central and peripheral nervous system. Clinically, there's progressive encephalopathy, and that causes asterixis, which is a tremor in the hand when the wrist is extended, just like a bird flapping its wings. Finally, renal failure can also increase lipid synthesis in the liver, causing hyperlipidemia, especially hypertriglyceridemia. Now, chronic kidney disease can lead to even more problems over a long period of time. If a child is affected, it can lead to growth retardation and developmental delay, especially in individuals that had to undergo dialysis. Another important fact for your exams is that there's also erythropoietin deficiency, and this leads to anemia. Finally, there's renal osteodystrophy, and this happens for a number of reasons, and it's important to memorize all of them. First, the kidneys cannot excrete phosphate, leading to hyperphosphatemia. Next, the kidneys are needed to convert 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D, or calcitriol, which is the active form of vitamin D, which helps with intestinal calcium reabsorption. As a result, there'll be hypocalcemia. Now, since there's too much phosphate and too little calcium, this can affect the bones, and they can become thinner and more prone to break. Hyperphosphatemia and hypocalcemia also triggers the parathyroid glands to release more parathyroid hormone, which is a hormone that causes increased bone breakdown to release more calcium. Finally, the extra phosphate in the blood can also bind to calcium, and they can deposit in various tissues, like the vascular tissue. Okay, now that we've gone over the general pathology, let's look at some specific causes of acute kidney injury. There are 3 types of acute kidney injury, or AKI: pre-renal AKI, intrarenal AKI, and post-renal AKI. With pre-renal AKI, the cause is decreased blood flow into the kidneys. Now, since less blood's going to the kidneys, this means that less blood is being filtered. So there's a decrease in the glomerular filtration rate, or GFR, which is how much blood, usually in milliliters, the kidney filters through the glomeruli per minute. If less blood is being filtered, that means that less urea and creatinine are filtered out, and more stays in the blood. so levels of BUN and creatinine will be high. Also, with less blood being filtered, the kidneys activate the renin-angiotensin system, which causes aldosterone released by the adrenal glands. This hormone tells the kidneys to reabsorb sodium. When sodium gets reabsorbed, water gets reabsorbed as well. Water and sodium reabsorption is also tied to urea reabsorption. So in this situation, urea gets reabsorbed, and so even more urea gets into the blood, resulting in a BUN to creatinine ratio of greater than 20:1. Now, looking at the urine, more sodium is being retained. So the urine sodium is usually less than 20 milliequivalents per liter. The ratio of sodium excreted to total sodium filtered, or FeNA, is usually less than 1%. And finally, that urine is more concentrated, because less water is excreted. So typically the urine's greater than 500 milliosmoles per kilogram. Prerenal AKI can happen in hypovolemic states, like an acute hemorrhage, gastrointestinal losses like diarrhea and vomiting, and renal losses like with diuretics. All this can lead to hypovolemic shock. In a hypovolemic state, the individual presents with tachycardia, hypotension, reduced skin turgor, and cool extremities. Now, prerenal AKI can also happen with hypervolemic states, where there's a low effective circulating volume. One example is severe systolic heart failure leading to not enough blood getting pumped to the kidneys. When this happens, it's called cardiorenal syndrome. Finally, systemic vasodilation, like with sepsis, can lead to prerenal AKI. Next, there's intrinsic or intrarenal AKI, which is due to damage to the tubules, the glomerulus, or the kidney interstitium, which is the space between tubules. In general, with intrarenal AKI, there's kidney damage, causing them to lose the ability to filter blood and secrete or reabsorb materials like normal. If urea is not reabsorbed, less urea stays in the blood relative to creatinine, and the BUN to creatinine ratio falls to less than 20:1. Also, renal tubule cells cannot reabsorb sodium, meaning the urine sodium goes above 40 milliequivalents per liter, and the FeNA goes above 2%. And finally, since water is not being reabsorbed as much, urine osmolality falls below 350 milliosmoles per kilogram. Alright, now the most common cause of intrarenal AKI is acute tubular necrosis, or ATN, which causes damage to the tubules. Often ATN is due to ischemia from a prerenal acute kidney injury. On your tests, make sure you don't confuse this with prerenal AKI, where there's decreased filtration of blood, but the kidneys are not damaged. In ATN, there's severe ischemia leading to the death of tubular cells. The proximal tubular cells and the thick ascending limb cells are highly susceptible to injury, and that's because these cells receive their blood from vasa recta, which are tiny capillaries located in the medulla of the kidney. In this particular zone, the blood flow is relatively slow to allow for the countercurrent multiplication mechanism to work properly. The other way tubules can be damaged is via nephrotoxins, like contrast dyes, aminoglycosides antibiotics, cisplatin, heavy metals like lead, myoglobin from damaged muscles, like in rhabdomyolysis, ethylene glycol or radiocontrast dye, and hemoglobinuria, that's usually associated with hemolytic anemia. The proximal tubule cells are particularly susceptible to nephrotoxin injury. Now, ATN usually has 3 stages. The first one is the inciting event, or the trigger that causes damage to the tubules. Next, there's a maintenance phase, also called the oliguric phase, which usually lasts from 1 to 3 weeks. This is when the kidneys are not working, and here there's a risk for developing electrolyte disturbances, like hyperkalemia because potassium is not effectively secreted, metabolic acidosis because acid secretion is impaired, and uremia, which is when there are too many waste products retained. Finally, there's the recovery phase, which is when the kidneys start working, because the tubular cells begin a process of re-epithelialization, meaning new functional cells are born. As a result, creatinine and BUN levels fall, and there's polyuria. Also for your tests, remember that in this phase, there's a risk for developing hypokalemia, because too much potassium is excreted this time. There can be wasting of other electrolytes or minerals as well. Remember for your exams that on microscopy, there are muddy brown granular epithelial cell casts, along with renal tubular epithelial cells. Alright, moving on to another cause of intrarenal AKI, which is acute interstitial nephritis. This is an inflammation of the renal interstitium over the course of days to weeks. It's thought to be a type 1 or type 4 hypersensitivity reaction, and is typically a response to a medication like NSAIDs, in which case it's called analgesic nephropathy, penicillin, rifampin, proton pump inhibitors, and diuretics. After the cessation of the offending medication, symptoms of acute interstitial nephritis typically resolve completely. In rare cases, the inflammation in the interstitium can be caused by systemic infections, like infections with mycoplasma or autoimmune conditions, like Sjogren's syndrome, sarcoidosis, or systemic lupus erythematosus. It can be asymptomatic, but for your exams, remember that can also present symptoms like fever, rash, hematuria, pyuria, and costovertebral angle tenderness. With acute interstitial nephritis, the blood count shows eosinophilia and the urine microscopy shows white cells, white cell casts, and red blood cells. Another type of intrarenal AKI is acute glomerulonephritis, which is when the glomeruli are damaged by inflammation. Acute glomerulonephritis can be caused by rapidly progressive glomerulonephritis, which is when the inflammation in the glomerulus is so severe that it breaks the glomerular basement membrane, and as a result, the kidney function decreases rapidly in a matter of days to weeks. Another cause of acute glomerulonephritis is hemolytic uremic syndrome, which is caused by bacteria like E. coli O157H7. For your exam, remember that it's characterized by hemolytic anemia, thrombocytopenia, and acute kidney injury. Another clue is that the person might have had bloody diarrhea for a few days prior to the oliguria. Next up, there's diffuse cortical necrosis, which is when there's generalized cortical infarction of both kidneys. This happens because of a combination of vasospasm and disseminated intravascular coagulation, or DIC, where tiny thrombi block some of the arteries in the kidney, and so the kidneys don't get any blood in that area. This can be associated with obstetric complications like abruptio placentae, where there's massive blood loss that can lead to both vasospasm and DIC. It can also be associated with septic shock, which also causes DIC. Alright, next there's renal papillary necrosis, where the renal papillae are damaged and tiny parts of them can be eliminated in the urine, so there's sloughing of the renal papillae. This is usually a consequence of ischemia, because the arteries supplying the renal papillae are tiny, so they're prone to obstruction. Now, renal papillary necrosis can be associated with sickle cell disease, because the abnormal red blood cells can build up and obstruct the arteries that supply blood to the renal papillae. It can also be due to acute pyelonephritis, because the inflammation can obstruct those arteries. Another cause is the use of NSAIDs, because they block the synthesis of prostaglandins that keep afferent arterioles dilated. In other words, lack of these prostaglandins causes vasoconstriction of the afferent arteriole, and therefore decreased glomerular filtration rate. So when there's reduced blood flow through the renal artery, which is particularly common in the elderly and individuals with underlying heart, liver, or kidney disease, vasoconstriction of the afferent arteriole can lead to renal papillary necrosis. Finally, diabetes mellitus can lead to papillary necrosis due to the vascular damage it induces. Let's move on to post-renal AKI, which is caused by an obstruction in the outflow of urine from the kidneys, which causes a buildup of urine that backs up into the kidney. Now, BUN to creatinine ratio, FeNA, and urine sodium largely depend on if the tubules are working or not. So for your tests, simply remember that these three parameters can vary. Just as with the others, less water and fluid being reabsorbed causes the urine to be less concentrated, and urine osmolality falls below 350 milliosmoles per kilogram. Post-renal AKI is most frequently due to benign prostatic hyperplasia or prostatic cancer in a male, both of which lead to compression of the urethra. This can lead to frequent urination, but a slow urinary stream and a low volume of urine excretion. Finally, there are kidney stones that can get stuck in either ureter or in the urethra. Now, if only one ureter is obstructed, it's called unilateral obstruction, and the other kidney is working fine, then renal function is usually preserved. But if both ureters are obstructed, it's called bilateral obstruction. Alright, as a quick recap. Consequences of renal failure include metabolic acidosis, hyperkalemia, sodium and water retention, hyperlipidemia, and uremia for both acute and chronic kidney failure. Chronic renal failure leads to growth retardation and developmental delay, along with erythropoietin deficiency and renal osteodystrophy for chronic kidney disease. Alright, now acute kidney injury can be pre-renal, when there's decreased blood flow to the kidneys. Labs here show high levels of BUN and creatinine. BUN to creatinine ratio of greater than 20:1, urine sodium is less than 20 milliequivalents per liter, FeNA less than 1%, and urine osmolality greater than 500 milliosmoles per kilogram. Intrarenal AKI is due to damage to the tubules, the glomerulus, or the kidney interstitium. Labs show high levels of BUN and creatinine. BUN to creatinine ratio less than 20:1, urine sodium above 40 milliequivalents per liter, FeNA goes above 2%, and urine osmolality falls below 350 milliosmoles per kilogram. Causes of intrarenal AKI include ATN, acute interstitial nephritis, and acute glomerulonephritis. With postrenal AKI, there's an obstruction in the outflow of urine. Labs show urine osmolality below 350 milliosmoles per kilogram, but the other values might vary depending on if there's damage to the kidneys themselves. Okay, so back to our cases. Matilda came in with oliguria, a fever, and a rash on her arms, and the labs show that she had high levels of BUN and creatinine. Oh, and she's also taking NSAIDs. Further lab work showed that she also had eosinophilia, BUN to creatinine ratio less than 20:1, urine sodium above 40 milliequivalents per liter, FeNA above 2%, and urine osmolality below 350 milliosmoles per kilogram. She also had pyuria and white cell casts. So we can say that Matilda has a case of intrarenal AKI caused by interstitial nephritis, which in turn is caused by NSAIDs. So this is analgesic nephropathy. In this case, NSAIDs are stopped and the problem eventually resolved. Next, there's George that came in with oliguria, hypotension, tachycardia, and cold extremities, and has also been having diarrhea for a few days. BUN and creatinine were high, and further lab work showed BUN to creatinine ratio greater than 20:1, urine sodium less than 20 milliequivalents per liter, FeNA less than 1%, and urine osmolality greater than 500 milliosmoles per kilogram. So it's a case of pre-renal AKI caused by diarrhea. We should rehydrate him.
Chronic kidney disease, or CKD, describes a decrease in kidney function with an estimated glomerular filtration rate, or eGFR, below 60 milliliters per minute per 1.73 square meters. That happens over a minimum of 3 months, regardless of the cause. Now, if there's already kidney damage, like with glomerular disease, tubulointerstitial disease, vascular disease, or congenital renal disease, but the eGFR is above 60 milliliters per minute per 1.73 square meters, then this is still CKD, because all these conditions progressively affect the renal function, and, over time, without treatment, eGFR decreases. Now, the causes of CKD can be split into 3 categories: pre-renal, intrarenal, and post-renal causes. Pre-renal CKD causes are due to a decrease in renal perfusion, like in heart failure and cirrhosis. Intrarenal CKD causes can be further classified into renal vascular disease, glomerular disease, and tubulointerstitial disease. Renal vascular disease includes hypertension and renal artery stenosis. Glomerular diseases include nephritic and nephrotic diseases. And tubulointerstitial disease includes polycystic kidney disease. Other causes of intrarenal CKD are nephrotoxic substances like lead and certain medications like cisplatin. Finally, there's post-renal CKD, which is most commonly caused by prostate disease. Also, repeated episodes of pyelonephritis can lead to CKD. Diagnosing CKD usually requires having past measurements of the eGFR, albuminuria or proteinuria, and past urine dipstick and sediment examinations. If that isn't possible, the individual needs to have multiple assessments over a period of 3 months to confirm that the problem is chronic. That means getting serum creatinine to calculate the eGFR, along with urinalysis, both by dipstick and microscopy, to identify any abnormalities in the urine, such as hematuria, and checking the urine albumin levels. Additionally, an abdominal ultrasound is done because CKD can cause scarring, which makes the kidneys small and echogenic. However, it depends on the cause, since some causes of CKD, like diabetic nephropathy, leave the kidneys normal-sized. Now, based on the eGFR, CKD is classified into 5 stages, called G stages, measured in units of milliliters per minute per 1.73 square meters. G1 is when the eGFR is above 90, but there's an underlying kidney disease. G2 is when the eGFR is between 60 and 89, and this is considered mildly decreased kidney function. G3A is when the eGFR is between 45 and 59, and this is mildly to moderately decreased kidney function. G3B is when the eGFR is between 30 and 44, and this is moderately to severely decreased kidney function. G4 is when the eGFR is between 15 and 29, and this is considered severely decreased kidney function. Finally, there's G5, where the eGFR is below 15, and this is end-stage renal disease, or ESRD. For individuals with stage G5 CKD, if they're also on dialysis, a D is added to the G stage, so it's called G5D. Now, albuminuria, or the albumin excretion rate, has also been added to the CKD staging, and they're called the A stages. A1 is when the albumin excretion rate is less than 30 milligrams per day, and this is normal to mildly increased albuminuria. A2 is when the albumin excretion rate is between 30 and 300 milligrams per day, and this is moderately increased albuminuria. Finally, there's A3, where the albumin excretion rate is over 300 milligrams per day, and this is severely increased albuminuria. We use both these staging systems because the higher the stage, the higher risk of mortality and progression of CKD is. Individuals with CKD can develop signs and symptoms due to their decreased renal function, such as edema and oliguria, meaning a urine output less than 400 milliliters per day, fatigue, weakness, and anorexia. Individuals with CKD may also have hypertension from sodium retention, increased activity of the renin-angiotensin-aldosterone system, and secondary hyperparathyroidism. Additionally, the individual may have symptoms from the underlying disease, such as gross hematuria, with IgA nephropathy or shortness of breath from heart failure. CKD can also cause complications like anemia, which might be due to the kidneys making insufficient erythropoietin. In individuals that undergo hemodialysis, anemia can be caused by regular blood loss during hemodialysis sessions. Individuals with CKD are also prone to iron deficiency anemia for several reasons. Some have diet low in iron, blood loss during hemodialysis, or impaired absorption of iron. Another complication of CKD is mineral and bone disorder, sometimes called CKD-MBD for short. CKD-MBD includes metabolic changes that result in hyperphosphatemia and hypocalcemia, skeletal abnormalities like bone fractures, and extraskeletal calcifications like coronary artery calcifications. CKD-MBD develops for a number of reasons. First, the kidneys can't excrete phosphate, leading to hyperphosphatemia and improper conversion of 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D, or calcitriol, which is the active form of vitamin D. Low levels of calcitriol leads to hypocalcemia. Hyperphosphatemia and hypocalcemia lead to increased levels of parathyroid hormone, which is a type of secondary hyperparathyroidism, and the parathyroids become bigger. Sometimes, PTH can be the first one to increase, due to increased PTH gene expression, so phosphate and calcium levels can remain normal for a long period of time. Now, after a long period of time with secondary hyperparathyroidism, the large hypertrophied parathyroids start secreting even more PTH, regardless of triggers like hyperphosphatemia, hypocalcemia, or vitamin D deficiency. This is called tertiary hyperparathyroidism. In this case, really high levels of PTH can lead to hypercalcemia. Another complication is hyperkalemia, which can cause symptoms like palpitations, paresthesias, and muscle weakness. Finally, CKD can lead to metabolic acidosis, which can lead to dyspnea, or if it's chronic, may be asymptomatic. Now, in individuals with ESRD, there may be uremia, which is caused by the accumulation of uremic toxins, including urea itself. Symptoms include nausea, vomiting, weight loss, fatigue, and pruritus. Another sign of uremia is bleeding and easy bruising, and that's due to platelet dysfunction. There's also uremic pericarditis, which can cause chest pain, and on auscultation, there's a pericardial friction rub. Next, there's uremic neuropathy, affecting the central and peripheral nervous system. Clinically, there's progressive encephalopathy that causes confusion, asterixis, and myoclonus. It can also cause distal symmetrical polyneuropathy and paresthesias. Finally, in severe cases, it can cause seizures and coma. There can also be sexual dysfunction that presents with decreased libido and erectile dysfunction in males and amenorrhea in females. Further lab work consists of blood serum glucose, and hemoglobin A1C levels are checked in individuals with diabetes mellitus. Individuals with CKD are at a higher risk for cardiovascular disease, so cholesterol, triglycerides, LDL, and HDL levels are also checked. The most common finding in CKD is high triglyceride levels. Electrolyte levels and an ABG are done to assess for metabolic acidosis. Additionally, with ESRD, albumin levels are also checked, and they're usually low when there's malnutrition. If the individual is at stage G3, then a CBC is checked because CKD can cause a normocytic and normochromic anemia. Additionally, serum iron, TIBC, and ferritin levels are also checked to assess for iron deficiency. In iron deficiency, serum iron is low, TIBC is high, and ferritin is low. Now, to evaluate CKD MBD, phosphate, calcium, PTH, and vitamin D levels are checked. Once the individual is at stage G3, PTH levels usually increase and vitamin D levels decrease. Calcium and phosphate levels can remain normal for a long time, typically until the individual reaches stage G4, where there will be hyperphosphatemia and hypocalcemia. This happens because high PTH gene expression leads to high PTH levels, which in turn increases phosphate excretion. An abdominal ultrasound is usually done to check the size of the kidneys and to look for evidence of hydronephrosis, which can cause obstruction. When PTH levels are high, a parathyroid ultrasound can be done to see if the parathyroid glands are larger. Treatment of CKD starts with stopping any nephrotoxic medications, like NSAIDs and aminoglycosides, and making sure the cause isn't pre-renal, in which case IV saline can be given to restore the intravascular volume. After that, the goal is to slow the progression of renal disease, rather than stopping it. First, dietary recommendations include keeping the caloric intake between 30 and 35 kilocalories per kilogram per day to help manage body weight, since a high BMI is a risk factor for worsening renal function. That works out to just about 2,300 kcals per day for a 70 kilogram adult. Now, if the individual is not on dialysis, then protein restriction is recommended, 0.8 grams per kilogram per day. If the individual has hypertension or volume overload or proteinuria, then sodium restriction is set at about 2 grams of sodium per day, which is roughly 1/3 of a tablespoon of salt daily. Additionally, with volume overload, an oral loop diuretic, like furosemide, is used. If hypertension or volume overload or proteinuria aren't present, then 2.3 grams of sodium per day can be consumed. Next, calcium intake should be below 1 gram per day to prevent tissue deposition. Potassium intake is based on potassium levels, but generally speaking, when the eGFR is below 30 milliliters per minute per 1.73 square meters, potassium intake is limited to a maximum amount of 4 grams per day. General measures include smoking cessation in all individuals with CKD, and having tight glycemic control among individuals with diabetes mellitus. Now, two factors that accelerate the progression of CKD are hypertension and proteinuria. If there's only proteinuria, meaning more than 1,000 milligrams of protein lost per day, then treatment with either an oral ACE inhibitor, like enalapril, or an oral ARB, like losartan, is initiated. Now, if there's only arterial hypertension, then an ACE inhibitor or an ARB is started. The goal is to get the systolic blood pressure below 130 millimeters of mercury, but not below 110 millimeters of mercury, and the diastolic blood pressure below 80 millimeters of mercury. Now, if there's both hypertension and edema, then an oral diuretic like furosemide is given as a first choice. Another risk factor is hyperlipidemia. Now, when individuals are at stage G3, they should be started on a statin, like atorvastatin, to reduce the risk of cardiovascular disease. If LDL levels are high, statin therapy is recommended until the level is below 70 milligrams per deciliter. If there's hypertriglyceridemia, which is when triglycerides are above 200 milligrams per deciliter, then weight loss and exercise are recommended. Next, there's treatment and prevention of complications, which begin to appear in individuals at stage G3. In individuals with chronic metabolic acidosis, like alkali therapy is used to keep the serum bicarbonate between 23 to 27 milliequivalents per liter. Between 0.5 and 1 milliequivalents per kilogram per day of oral sodium bicarbonate or oral sodium citrate is given daily. Treatment of anemia depends on the cause. If there's also iron deficiency, then oral iron supplements are given, which can be taken with orange juice, which is slightly acidic and can help absorption. If oral iron isn't effective, or the side effects can't be tolerated, IV iron can be used instead. Now, if hemoglobin levels are below 10 grams per deciliter, and it's not due to iron deficiency, then treatment using subcutaneous erythropoiesis-stimulating agents, like epoetin or darbepoetin, is started. Treatment of CKD, MBD, starts with treating hyperphosphatemia if it's present. First, dietary phosphorus intake is restricted to 900 milligrams per day. If dietary measures don't lower phosphate levels, then non-calcium containing phosphate binders, like oral sevelamer, are used. Hypocalcemia isn't always treated, because vitamin D supplementation can lead to hypercalcemia, which can then lead to extraskeletal calcifications. However, if PTH levels are above 195 picograms per milliliter, and there's vitamin D deficiency and hypocalcemia, then oral calcitriol or alpha-calcidol is given. In individuals at stage G5, meaning ESRD, renal replacement therapy is recommended, and this also helps prevent or treat uremia. Generally, individuals at stage G4 are informed about renal replacement therapy options, which include hemodialysis, peritoneal dialysis, and renal transplantation. Typically, these options are initiated when there's any evidence of uremia. Other indications for renal replacement therapy are volume overload refractory to diuretics, hypertension refractory to antihypertensive medications, persistent metabolic disturbances like metabolic acidosis, hyperkalemia, hyperphosphatemia, hypo or hypercalcemia that are refractory to medication, or refractory symptoms like nausea and vomiting. Generally, a kidney transplant is the best option for renal replacement, but it's not always possible. Absolute contraindications for a kidney transplant are active infections, like hepatitis B, malignancies, like pancreatic cancer, active substance abuse, uncontrolled mental illness, treatment non-adherence, or any other risk for a shortened life expectancy. In these cases, hemodialysis or peritoneal dialysis can be tried instead. In hemodialysis, there are three major types of vascular access that can be used. First, there's an AV fistula, which is when an artery and a vein are surgically ligated in the arm and then strengthens over 6 months into a strong blood vessel. Typically, a person is referred for an AV fistula surgery when they're at stage G4 and when creatinine levels are above 4 milligrams per deciliter, or when there's a rapid decrease in renal function. The arm with an AV fistula shouldn't be used for blood drawing or for blood pressure checks, and the individual shouldn't sleep on that arm or carry anything over 5 pounds with that arm. And that's because this can cause bleeding or an infection, which can damage the AV fistula, making it unusable for hemodialysis. If an AV fistula can't be surgically formed, then an AV graft made from polytetrafluoroethylene is placed between an artery and a vein from the arm. This can be done just 6 weeks prior to the initiation of hemodialysis. An AV graft isn't always used because there's a higher risk for thrombosis or infection. In situations where hemodialysis needs to be initiated before 6 months, tunneled hemodialysis catheters can sometimes be temporarily placed. These are usually placed in the right jugular vein, and the catheter is tunneled under the skin. This is usually done when an individual needs hemodialysis, and the AV fistula hasn't matured yet, or when an individual is a poor candidate for an AV fistula, like individuals with congestive heart failure. These aren't usually used because they can cause immediate complications like bleeding or pneumothorax, or long-term complications like thrombosis or central vein stenosis. Finally, there's peritoneal dialysis, which is when a peritoneal dialysis catheter is surgically placed in the abdominal cavity and a dialysis solution flows through the catheter and into the peritoneal cavity. The fluid dwells in that space, and toxins and excess water diffuse across the peritoneal membrane. Generally, after a few hours, the fluid from the peritoneal space is drained through the catheter and another dialysis solution is introduced into the peritoneal space. Alright, as a quick recap, CKD has 5 stages based on the EGFR: albuminuria, and kidney damage, which includes pre-existing conditions like glomerular disease, tubulointerstitial disease, vascular disease, or congenital renal disorders. The higher the stage, the most likely progression of the renal disease is. The individual may have edema, oliguria, and hypertension. For individuals at stage G3, complications can develop like anemia, CKD-MBD, which includes hyperphosphatemia, hypocalcemia, high PTH and vitamin D deficiency, hyperkalemia, and metabolic acidosis. With ESRD, there's typically uremia, which can cause uremic pericarditis, uremic bleeding, and uremic neuropathy. Lab work includes serum creatinine, BUN, urine analysis, albuminuria test, blood serum glucose, HbA1c, cholesterol, triglycerides, LDL and HDL levels, electrolytes, and an ABG. With ESRD, albumin levels should also be checked. A CBC is done to check for anemia, and HB levels are under 12 grams per deciliter if present. If there's also iron deficiency, TIBC is high and ferritin is low. For CKD-MBD, serum phosphate, serum calcium, along with PTH and vitamin D levels are done. In CKD, an abdominal ultrasound usually shows small kidneys. The goal of treatment is to slow the progression of disease. This can be done through dietary modifications, controlling hypertension, the goal being less than 130 over 80 millimeters of mercury, and controlling proteinuria to less than 1,000 milligrams per day with ACE inhibitors or ARBs. If there's hypertension and edema, then a loop diuretic is the first choice. Individuals at stage G3 receive statins to reduce LDL levels to below 70 milligrams per deciliter. If there's hypertriglyceridemia, then lifestyle changes are recommended. Treatment of volume overload is done with sodium restriction and an oral loop diuretic. Hyperkalemia can be prevented through diet and avoiding medications that increase serum potassium. Chronic metabolic acidosis is treated with oral alkali therapy. With anemia, if there's also iron deficiency, then oral or IV iron is given. If there's no iron deficiency and hemoglobin levels are under 10 grams per deciliter, then subcutaneous erythropoiesis-stimulating agents are given. With hyperphosphatemia, dietary phosphorus intake is restricted, but if this doesn't work, oral non-calcium-containing phosphate binders are given. If PTH levels are above 195 picograms per milliliter, and if there's vitamin D deficiency and hypocalcemia, then treatment with oral calcitriol or alpha-calcidol is given. Renal replacement therapy is typically started with ESRD, and options include renal transplantation, hemodialysis, and peritoneal dialysis.
Chronic kidney disease is a broad term that includes subtle decreases in kidney function that develop over a minimum of 3 months. In contrast, acute kidney injury refers to any decrease in kidney function that happens in less than 3 months. Now, the kidney's job is to regulate what's in the blood, so they might remove waste or make sure electrolyte levels are steady or regulate the overall amount of water. And they even make hormones. The bottom line is that the kidneys do a ton of stuff. Blood gets into the kidney through the renal artery, and once inside, it goes to tiny clumps of arterioles called glomeruli, where it's initially filtered. And the filtrate, which is the stuff that gets filtered out, moves into the renal tubule. The rate at which this filtration process takes place is known as the glomerular filtration rate, or GFR. In a normal, healthy person, this is somewhere around 100 to 120 milliliters of fluid filtered per minute per 1.73 meters squared of body surface area. This value is slightly less in women than men, and it decreases slowly in all of us as we grow older. One of the most common causes of chronic kidney disease is hypertension. In hypertension, the walls of arteries supplying the kidney start to thicken in order to withstand the pressure, and that results in a narrow lumen. A narrow lumen means less blood and oxygen gets delivered to the kidney, which leads to ischemic injury to the nephron's glomerulus. Immune cells like macrophages and fat-laden macrophages, called foam cells, slip into the damaged glomerulus and start secreting growth factors like transforming growth factor beta 1, or TGF beta 1. These growth factors cause the mesangial cells to regress back to their more immature stem cell state known as mesangioblasts. And then those mesangioblasts secrete extracellular structural matrix. This excessive extracellular matrix leads to glomerulosclerosis, which is hardening and scarring, which diminishes the nephron's ability to filter the blood. And over time, this leads to chronic kidney disease. The second most common cause of chronic kidney disease is diabetes. In this situation, excess glucose in the blood starts sticking to proteins, a process called non-enzymatic glycation because no enzymes are involved. This process of glycation particularly affects the efferent arteriole and causes it to get stiff and more narrow, a process called hyaline arteriosclerosis. This creates an obstruction that makes it difficult for blood to leave the glomerulus, and increases pressure within the glomerulus, which leads to hyperfiltration, essentially pushing more fluid through. In response to this high-pressure state, the supportive mesangial cells secrete more and more structural matrix, which expands the size of the glomerulus. Over many years, this process of glomerulosclerosis once again diminishes the nephron's ability to filter the blood and can lead to chronic kidney disease. Although diabetes and hypertension are responsible for the vast majority of chronic kidney disease cases, there are other causes as well, including systemic diseases like lupus and rheumatoid arthritis, which can also cause glomerulosclerosis. Other causes, though, include infections like HIV, as well as long-term use of medications like NSAIDs, and toxins like the ones in tobacco. Now, normally, urea in the blood gets excreted in the urine, but when there's a decreased glomerular filtration rate, less urea gets filtered out, and therefore it has nowhere else to go besides the blood, and so it builds up in the blood, which is a condition called azotemia. Azotemia can cause general symptoms like nausea and loss of appetite, but as urea levels really build up, they can affect the functioning of the central nervous system, causing encephalopathy. This results in asterixis, a tremor of the hand that kind of resembles a bird flapping its wings, and is best seen when a person attempts to extend their wrists. Further accumulation can even progress to coma and death. This buildup can also cause pericarditis, which is inflammation of the lining of the heart. In addition, there can also be increased tendency for bleeding, since excess urea in the blood makes platelets less likely to stick to each other, and so there's less clot formation. Finally, in some cases, someone can develop uremic frost, where urea crystals can deposit in the skin and they look like powdery snowflakes. In addition to getting rid of waste, the kidneys play an important role in electrolyte balance. Potassium levels are particularly important, and normally the kidney helps with potassium excretion. In chronic kidney disease, though, just like with urea, less potassium is excreted, and so more builds up in the blood, and this leads to hyperkalemia, which can be problematic because it can cause cardiac arrhythmias. Another key role of the kidneys relates to balancing calcium levels. Normally, the kidney helps to activate vitamin D, which then helps to increase absorption of calcium from the diet. With chronic kidney disease, though, there's less activated vitamin D, so less calcium is absorbed into the blood, which results in hypocalcemia, low calcium levels. As calcium levels in the blood fall, parathyroid hormone is released, which causes the bones to lose calcium. Over time, this resorption of calcium from the bones leaves them weak and brittle, a condition known as renal osteodystrophy. The kidneys also release key hormones. For example, normally when the kidneys start sensing a lower than normal amount of fluid getting filtered, they respond by releasing the hormone renin to increase the blood pressure. In chronic kidney disease, the falling glomerular filtration rate leads to more and more renin secretion, which leads to hypertension. Now, remember that hypertension is a cause of chronic kidney disease itself, so this creates quite the vicious cycle. Finally, the kidney also secretes the hormone erythropoietin, which stimulates the production of red blood cells from the bone marrow. In chronic kidney disease, erythropoietin levels fall, and this leads to lowered production of red blood cells, and ultimately anemia. The diagnosis of chronic kidney disease comes down to looking at changes in the glomerular filtration rate over time. Chronic kidney disease might be suspected with a GFR of less than 90 milliliters per minute per 1.73 meters squared. Irreversible kidney damage might happen with a GFR below 60 milliliters per minute per 1.73 meters squared. To confirm the diagnosis, a kidney biopsy can be done to look for changes like glomerulosclerosis. Treatment for chronic kidney disease often involves managing the underlying cause. In severe situations, dialysis or a kidney transplant might be needed. Alright, as a quick recap. Chronic kidney disease is when the glomerular filtration rate falls below 90 milliliters per minute per 1.73 meters squared, over at least 3 months. Chronic kidney disease is mainly caused by diabetes and hypertension, and complications include electrolyte abnormalities, toxin buildup, hypertension, and weak bones. What's happening, guys? Tanner here. Thanks for watching this video on chronic kidney disease. I hope you learned something. It's really exciting because we're almost done with all the renal videos, or all the major kidney or renal type pathology videos, which is really cool because then we'll have like this full set of renal pathology for you guys to look at. So that's really cool, and look out for those in the next couple weeks. Also, if you want to do a deeper dive into this chronic kidney disease or other renal topics, you should definitely head over to osmosis.org, which is sort of like our platform. We have a ton of flashcards, quiz questions, and other awesome resources that our developers have built. So if you're interested in that, for sure head over and make an account. Otherwise, you can always support us by donating on Patreon and supporting us on social media. This video was written by Debal and edited by Rishi. I did the illustration and the voiceover, and then Yifan did the video editing. So thanks, guys. I think this video turned out really well. Till next time, see you later. In the emergency department, 2 people came in with rapid, shallow breathing and tachycardia. The first one is 45-year-old Olga, who also has systemic lupus erythematosus, and the second one is 39-year-old Fred. An arterial blood gas was taken, along with electrolytes. Results showed that Olga had low pH, low bicarbonate and PCO2 levels, and her potassium level was also low. Fred also had low pH, low bicarbonate and PCO2 levels, but his potassium level was high. Based on the ABG results, the diagnosis of normal anion gap metabolic acidosis was made. In order to identify the cause of their normal gap metabolic acidosis, more investigations were done and the urine anion gap showed that both individuals had a low urinary anion gap, which suggests that the cause was renal. Alright, now a normal anion gap metabolic acidosis can have renal causes, like when a lot of bicarbonate is lost through the urinary tract, which happens in type 2 renal tubular acidosis. A normal anion gap metabolic acidosis can also happen when too many hydrogen ions are retained, like in type 1 and type 4 renal tubular acidosis. Now there's also a type 3 renal tubular acidosis, where both the proximal and distal tubules are affected. This is a pretty rare situation, and the causes are not well understood, so it's unlikely to be tested. Alright, now let's review the physiology of the tubules. The proximal tubule is affected in RTA type 2. It's lined by brush border cells which have two surfaces. One is the apical surface, that faces the tubular lumen and is lined with microvilli, and the other is the basolateral surface, which faces the peritubular capillaries. Now, a lot of bicarbonate is reabsorbed here. When bicarbonate approaches the apical surface, it binds to hydrogen to form carbonic acid, which will be split into water and carbon dioxide by carbonic anhydrase. The water and carbon dioxide diffuse into the cells where carbonic anhydrase facilitates the reverse reaction and combines them to form carbonic acid, which dissociates into carbonate and hydrogen. Then carbonate will get into the blood with the help of a sodium bicarbonate cotransporter on the basolateral surface. Now, the proximal tubule is also responsible for reabsorbing glucose, as well as amino acids, sodium, chloride, potassium, phosphate, water, and uric acid. Alright, so now let's look at the distal tubule and collecting duct, which are affected in type 1 and type 4 RTA. First, they're lined with alpha intercalated cells, which also move bicarbonate and hydrogen from the tubule into the cell with the help of carbonic anhydrase. The alpha intercalated cells also secrete hydrogen across the apical surface and into the tubule, with the help of a hydrogen ATPase and a potassium hydrogen ATPase. Once in the lumen, hydrogen binds to phosphate or ammonia to form relatively weak acids, like dihydrogen phosphate or ammonium, which then get peed out in the urine. This allows protons to get removed without making the urine too acidic and damaging the cells lining the tubules and the rest of the urinary tract. The other group of cells in these regions are the principal cells. These cells have a potassium channel that allows potassium into the lumen, and an epithelial sodium channel that allows sodium into the cell. The flow of positively charged sodium ions into the cell helps drive the positively charged potassium ions out of the cell against their concentration gradient. There's also a sodium-potassium ATPase pump on the basolateral surface that again moves 2 potassium ions in for every 3 sodium ions out. All 3 of these channels are stimulated by aldosterone, and the combined effect is reabsorption of sodium and loss of potassium. In type 1 RTA, or distal renal tubular acidosis, the main issue is that alpha intercalated cells of the distal tubule and collecting duct are unable to secrete hydrogen. This leads to a buildup of hydrogen in the blood, resulting in acidemia, which will eventually lead to metabolic acidosis. With type 1 RTA, there's also increased potassium excretion to maintain electroneutrality in the renal tubules, so there'll also be hypokalemia. The underlying cause of type 1 RTA could be a genetic mutation in the hydrogen ATPase pump or the hydrogen potassium ATPase pump of alpha intercalated cells. Alternatively, it could be due to an acquired defect from a medication like amphotericin B, which can allow hydrogen to simply diffuse from the tubule right back into the cell. Other causes include analgesic nephropathy, congenital anomalies of the urinary tract, and autoimmune disease like systemic lupus erythematosus, all of which can damage the distal and collecting tubules and decrease hydrogen secretion. On lab tests, type 1 RTA leads to a normal gap metabolic acidosis, meaning that blood pH will be low and levels of serum bicarbonate, potassium, and PCO2 will be low. But the anion gap will be normal. The urine pH is above 5.5, which is higher compared to other types of renal tubular acidosis, since hydrogen ions aren't excreted. Furthermore, metabolic acidosis increases urine calcium excretion without increasing calcium absorption. In order to get more calcium, bone turnover increases. This increases the risk for developing calcium phosphate kidney stones, which is a type of stone that forms in more alkaline urine. In type 2 RTA, or proximal renal tubular acidosis, the main issue is that brush border cells of the proximal tubule are unable to reabsorb bicarbonate. As a result, bicarbonate gets lost in the urine, and it means that there's nothing to counterbalance the hydrogen ions in the blood, resulting in acidemia and eventually metabolic acidosis. Now, since bicarbonate isn't reabsorbed in the proximal tubule, there will be a lot of bicarbonate in the urine as a result, and the high concentration of bicarbonate in the lumen leads to osmotic diuresis. This in turn causes mild hypovolemia, which activates the renin-angiotensin-aldosterone system, leading to sodium reabsorption and potassium excretion. So levels of potassium will fall, leading to hypokalemia. One known cause for type 2 RTA is Fanconi syndrome, where there's generalized proximal tubule dysfunction, meaning that the entire proximal tubule is damaged and won't be able to reabsorb things like bicarbonate, sodium, glucose, phosphate, uric acid, etc., and they're lost in the urine. On lab tests, type 2 RTA causes normal gap metabolic acidosis. pH is low and levels of serum bicarbonate and PCO2 are also low, but the anion gap will be normal. Potassium levels will also be low since they cannot be reabsorbed. Unlike RTA type 1, the distal intercalated cells are still functional and can secrete hydrogen ions, and can therefore generally still acidify the urine, so the urine pH will be below 5.5. Finally, there's type 4 RTA, or hyperkalemic acidosis, and it's classically due to aldosterone deficiency or aldosterone resistance in the collecting ducts, which would affect both the principal and alpha intercalated cells. An example of aldosterone deficiency is Addison's disease, where the adrenal gland doesn't produce enough of it. Other causes include certain medications, like ACE inhibitors and ARBs, both of which can inhibit the release of aldosterone by blocking the renin-angiotensin-aldosterone system. Other causes include diabetic nephropathy and the use of NSAIDs, both of which can inhibit renin release. Aldosterone resistance can happen with the use of potassium-sparing diuretics, because they can antagonize the aldosterone receptors. Sulfamethoxazole trimethoprim can also cause aldosterone resistance, but the mechanism isn't clear. Whatever the cause, the aldosterone resistance can decrease the function of the sodium-potassium ATPase in principal cells, making sodium levels fall and potassium levels rise in the blood, causing hyperkalemia. Reduced effect on the hydrogen ATPase in the alpha intercalated cells decreases hydrogen excretion, causing acidemia. Also, since hydrogen usually combines with ammonia in the tubule to form ammonium, with less hydrogen there will be less ammonium excreted in the urine. So type 4 RTA leads to normal gap metabolic acidosis, where pH is low and there's also low levels of serum bicarbonate and low PCO2. Due to aldosterone resistance, there's decreased potassium excretion, leading to hyperkalemia. The urine pH in this case is usually below 5.5, but it can be normal if enough aldosterone is produced. Alright, as a quick recap. RTA is a cause of normal gap metabolic acidosis. It can develop in either the proximal tubule or the distal tubule in the nearby collecting duct. With type 1 RTA, the alpha intercalated cells of the distal tubule and collecting duct are unable to secrete hydrogen, leading to metabolic acidosis. Hypokalemia and the urine pH will be above 5.5. With type 2 RTA, the brush border cells of the proximal tubule are unable to reabsorb bicarbonate, leading to metabolic acidosis and hypokalemia. But this time the urine pH is below 5.5. Then there's type 4 RTA, which is due to aldosterone deficiency or aldosterone resistance in the collecting ducts. This leads to metabolic acidosis, hyperkalemia, decreased ammonium excretion, and the urine pH is below 5.5, but it can vary. Alright, coming back to our cases. Both Olga and Fred came in with a normal gap metabolic acidosis. The urine anion gap was calculated, and this showed that the normal gap acidosis was of renal cause. Further investigations showed that Olga's urine pH was above 5.5 and she had hypokalemia, both of which suggest type 1 RTA, which is probably caused by her lupus. Bicarbonate is given to correct the acidosis. Now Fred has a normal gap acidosis with hyperkalemia, which suggests type 4 RTA, but more investigations are needed to determine and correct the cause. Angiomyolipomas are the most common benign tumors found in the kidneys, although they can be found in other tissues, like the liver and on rare occasions in some reproductive structures. If we break down the word, we see that they're tumors that are composed of blood vessels, smooth muscle, and adipose, or fat tissue. Angiomyolipomas are often described as hamartomas, which means that they're focal, abnormal growths of cells which are normally found at that site, but are disorganized. It's a bit like a house with a front door that can't be reached. It's the right part for the structure, but it's not organized in the right way. Angiomyolipomas also belong to the perivascular epithelioid cell tumor family, or pecoma family, meaning that they're made of epithelial-like cells that are found around blood vessels. Now, it's worth mentioning that normally there are no perivascular epithelioid cells that exist. The name just refers to the way that the tumor cells look under a microscope. The actual cell type from which pecomas arise, which includes angiomyolipomas, isn't known. The majority of angiomyolipomas will pop up sporadically, which means that they're not part of a syndrome, as isolated lesions. Interestingly, the tumors develop more often in the right kidney than the left. These tumors, though, are strongly associated with tuberous sclerosis, which is a genetic condition that causes benign tumors to develop in various parts of the body. People with tuberous sclerosis often have multiple angiomyolipomas along the surfaces of both kidneys, and they can be larger in size than the sporadic ones. Regardless of whether the angiomyolipoma happens sporadically or as a consequence of tuberous sclerosis, there's usually an underlying mutation in one of the tuberous sclerosis genes, TSC1 or TSC2, which code for the tuberous sclerosis complex proteins hamartin and tuberin, respectively. These proteins are part of a protein complex that acts as a tumor suppressor by inhibiting protein synthesis, which is why mutations in the complex promote uncontrolled cellular growth and proliferation. If they're small angiomyolipomas, they're usually harmless and don't need treatment. But if the angiomyolipoma is large, then it might start to have a mass effect, pushing on healthy tissue of the kidney and impairing its function, which can ultimately lead to chronic kidney disease. In rare cases, this could eventually lead to end-stage renal disease and the need for dialysis. These large tumors can also develop irregular blood vessels that can steadily dilate and form an aneurysm that could rupture. A ruptured aneurysm would cause sudden flank pain and would have the dangerous potential of causing hypovolemic shock, especially if the angiomyolipoma involves a major blood vessel, like the renal artery. Because these angiomyolipomas often have a high density of blood vessels, they can be difficult to surgically resect. An alternative treatment which can help to preserve healthy kidney function is to destroy the blood supply of large angiomyolipomas using a procedure called embolization. By destroying the disorganized blood vessels that help supply the other disorganized tissue in the angiomyolipoma, it can become necrotic, which shrinks the lesion and reduces the risk of hemorrhage. Embolization can cause significant inflammation, which causes post-embolization syndrome, which is characterized by symptoms like fever, flank pain, and malaise for a few days after the procedure. Okay, as a quick recap, Angiomyolipomas are benign tumors that are comprised of a disorganized mix of blood vessels, smooth muscle, and adipose tissue. These tumors most commonly arise in the kidneys and are strongly associated with tuberous sclerosis. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Wilms tumor, or nephroblastoma, is a type of kidney tumor composed of metanephric blastomal cells, cells involved in kidney development, and is the most common malignant kidney tumor in children. Only rarely is it seen in adults. Wilms tumor is thought to be caused by mutations in genes responsible for normal genitourinary development, which includes the kidneys as well as the gonads. Typically, the genes are located around 11p13, which means chromosome 11, the short arm P, region 1, band 3. One gene critical for normal kidney and gonad development is WT1, or Wilms tumor 1, which is a tumor suppressor gene. Mutations that result in a loss of function of WT1, like deletions, for example, seem to lead to the development of tumor cells seen with Wilms tumor. Wilms tumor as a result of WT1 mutations are sometimes part of a developmental syndrome, meaning other abnormalities are present as well, likely because of a deletion or mutation of other genes in addition to WT1. For example, in WAGR syndrome, a mutation in the 11p13 region causes deletion of both WT1 and the PAX6 gene, among others, which leads to Wilms tumor and genitourinary malformations as a result of the WT1 deletion, as well as aniridia, which is absence of the iris, and intellectual disability, which is formerly referred to as mental retardation, as a result of the PAX6 deletion. Another syndrome associated with WT1 mutations is Denise-Drash syndrome, which is characterized by Wilms tumor, early onset nephrotic syndrome, and male pseudohermaphroditism. Another gene, WT2, also located on chromosome 11, seems to also be involved with other Wilms tumor containing syndromes, like Beckwith-Wiedemann syndrome, which includes Wilms tumor, macroglasia, organomegaly, and hemihypertrophy. All that being said, Wilms tumor, in the majority of cases, happens in otherwise healthy children, and doesn't seem to be associated with WT1 or WT2, or any developmental syndrome of any kind. So in those situations, the mechanism of tumor development isn't well understood. Regardless of what the exact cause of the tumors are, they're usually composed partly of metanephric blastomal cells, which are cells that give rise to other cells like stromal cells, which are the connective tissue cells, as well as epithelial cells, all of which normally help give rise to structures in the kidney. That being said, in the mass there are usually abortive or partly developed structures of the nephron, like glomeruli and tubules. A tumor composed of blastomal, stromal, and epithelial cells is called a triphasic blastoma. Children with Wilms tumor often present with a flank mass that's large, palpable, and unilateral, and they also sometimes have hematuria, blood in the urine, as well as hypertension as a result of renin secretion. Treatment depends on the extent of spreading of Wilms tumor, although the overall prognosis is very good, and people with Wilms tumor often respond well to a combination of nephrectomy, removal of the kidney, and chemotherapy. Alright, so quick recap. Wilms tumor typically affects children, and usually the cause is unknown, though sometimes it can be caused by gene mutations, specifically WT1 and WT2. And the tumor mass, or triphasic nephroblastoma, is composed of blastoma cells, stromal cells, and epithelial cells. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Renal cell carcinomas, or RCCs, are the most common type of malignant kidney cancer in adults, generally affecting older men. Unfortunately, RCC is often considered a silent cancer because symptoms don't typically get noticed until the tumor has grown pretty large. Renal cell carcinomas form from epithelial cells in the proximal convoluted tubule of the kidney. And this is the section of the nephron that's usually located in the renal cortex, the outer rim of the kidney. The most common type of renal cell carcinoma is composed of polygonal epithelial cells, which have funny angular shapes with at least 4 sides, and are filled with clear cytoplasm full of carbohydrates and lipids. And it's those lipids that give the tumors their yellow color. At a genetic level, renal cell carcinomas have been linked to mutations on the short arm of chromosome 3, or 3p. An easy way to remember this is that RCC has 3 letters, and it's linked to chromosome 3. One of the main genes involved in renal cell carcinomas is the VHL gene, which codes for the von Hippel-Lindau tumor suppressor protein, or PVHL, which is normally expressed in all tissues. Mutations in PVHL can allow IGF-1, the type 1 insulin-like growth factor, pathway to go into overdrive. And this does 2 things. First, there's dysregulated cell growth. And second, it upregulates specific transcription factors called hypoxia-inducible factors, which in turn generate more vascular endothelial growth factor, or VEGF, as well as VEGF receptor, leading to growth of new blood vessels, or angiogenesis. Dysregulated cellular growth and angiogenesis are a recipe for tumor formation. Renal cell carcinomas can arise sporadically, or they can be part of an inherited syndrome. Sporadic tumors are usually solitary tumors in the upper pole of the kidney, and most often happen among older men that smoke cigarettes. Inherited syndromes, like von Hippel-Lindau disease, can also give rise to renal cell carcinomas. In this situation, the tumors typically affect younger men and women, and often involve both kidneys. Von Hippel-Lindau disease is a rare autosomal dominant disorder characterized by a mutation in a tumor suppressor gene, which leads to the formation of cysts and benign tumors in various parts of the body, like the eye and central nervous system. The number one cause of death in patients with von Hippel-Lindau disease, though, is the development of renal cell carcinomas. Individuals with renal cell carcinoma typically have one or more of the following symptoms: hematuria, or red blood cells in the urine, which is most common, a palpable mass in the abdomen or lower back, and pain in the flank or near the hip bone. Since the cancer causes a state of chronic inflammation, other classic symptoms include fever and weight loss. Renal cell carcinoma is also frequently responsible for causing various paraneoplastic syndromes, which is where the tumor cells generate a hormone that causes its own set of symptoms. For example, these tumors can release the hormone erythropoietin, which increases the production of new red blood cells. And this can lead to polycythemia, or too many red blood cells, which can cause the blood to start sludging or slowing down its normal flow. Another paraneoplastic syndrome involves the release of renin, a hormone that's part of the renin-angiotensin-aldosterone system and is involved in raising blood pressure. Some other hormones that renal cell carcinomas are known for releasing include parathyroid hormone-related peptide, or PTHrP, which causes hypercalcemia, and adrenocorticotropic hormone, or ACTH, which increases release of the stress hormone cortisol and can lead to Cushing's syndrome. Finally, in rare cases, a large renal cell carcinoma affecting the left kidney can butt up against the left renal vein and impede normal venous drainage of the left testes. This leads to dilation of the testicular veins and formation of a varicocele. Since the right testicular vein drains directly into the inferior vena cava, a blockage of the right renal vein by a large tumor does not usually have the same effect. However, very rarely, in people whose right spermatic vein drains into the right renal vein, renal cell carcinoma affecting the right kidney might cause a varicocele of the right testis. An especially dangerous progression of a renal cell carcinoma is its ability to invade the renal vein, where it literally grows within the vein, eventually reaching the inferior vena cava. This dramatically increases the risk of cancer spreading through the bloodstream, with the most likely targets being the lungs, since that's the first capillary bed that the tumor cells would reach if they broke free of the growing mass. But also the bones, because the tumor cells have an affinity for that tissue. To determine the risk of renal cell carcinomas, each one's individually staged by the TNM system. T indicates the size of the tumor and whether or not it's grown into nearby areas, for example, the renal vein. N describes the degree to which the cancer spread to retroperitoneal lymph nodes. And finally, M indicates the degree to which the cancer spread to other sites, or metastasized. Each of these categories ranked from 0 to 4, with 4 being the most severe. Renal cell carcinomas are stubbornly resistant to both traditional chemotherapy and radiation therapy. So if the tumor is localized to the kidney, surgical resection might be appropriate. In addition, renal cell carcinomas sometimes regress when they're attacked by the immune system, and are sensitive to immunomodulatory agents like certain chemokines and monoclonal antibodies. Molecular targeted therapies specifically aimed at inhibiting the VEGF receptor are particularly effective because it reduces tumor vascularization, thereby cutting off the blood supply and killing the tumor. Alright, as a quick recap, renal cell carcinomas form from the epithelial cells in the proximal convoluted tubule of the kidney. These tumors can arise sporadically or as part of a genetic condition like von Hippel-Lindau disease. Renal cell carcinomas can be tricky to treat because they're resistant to traditional chemotherapy and radiation therapy, and they're known to cause paraneoplastic syndromes. Walker syndrome stands for Wilms tumor, aniridia, genitourinary anomalies, and mental retardation, which is now called intellectual disability. And this is a genetic disorder that's caused when part of chromosome 11 is missing or deleted. Not everyone with Walker has all of these symptoms. For example, only about half of the individuals have Wilms tumor. On the flip side, some have additional symptoms too, like progressive kidney failure, growth retardation, small head size, and obesity. The most specific feature of Walker syndrome is aniridia, which is the complete or partial absence of the iris, the colored part of the eye. And this is an easily noticeable feature, and it's present at birth, so it's usually the first thing to raise suspicion of Walker syndrome. Now, a normal iris controls how much light enters the eye, and it constricts the pupil when there's a lot of light around to keep the vision sharp. With aniridia, too much light gets into the eye, which leads to blurry vision and photophobia, which is discomfort when the eyes are exposed to light. Additional eye features of Walker syndrome can include cataracts, which is a clouded lens, glaucoma, or increased pressure in the eye, and nystagmus, abnormal rhythmic movements of the eye. Wilms tumor, also called nephroblastoma, is generally a malignant kidney tumor that affects children. Wilms tumor is composed of metanephric blastoma, which is a cell type that's seen in the developing kidney, stromal cells, which are part of the connective tissue, and epithelial cells, which self-organize into primitive glomeruli and tubules. Children with Wilms tumor often develop a large flank mass as well as hematuria, which is blood in the urine, and hypertension. Now, that hypertension is a result of increased renin secretion, which either comes from the tumor itself or from healthy kidney tissue that secretes renin because it's physically compressed by the tumor. It's worth noting that Wilms tumor isn't specific for Walker syndrome. In fact, it most commonly happens in otherwise healthy children. And it can also be part of other syndromes, like Beckwith-Wiedemann syndrome. Fortunately, Wilms tumor is also treatable, and has a fairly high cure rate when it's treated with a combination of chemotherapy, radiation, and nephrectomy, which is removal of the kidney. The most common genital defect in boys with Walker syndrome is undescended testes, also called cryptorchidism, as well as hypospadias, where the urethra exits the penis on the underside instead of at the tip. The most common genital defect in girls is streak ovaries, which are underdeveloped and non-functional ovaries that are at an increased risk for developing a tumor called gonadoblastoma. Finally, someone with Walker syndrome might also have ambiguous genitalia, meaning they don't appear to be either clearly male or clearly female. Finally, intellectual disability is present in many but not all people with Walker syndrome, and it's also associated with other conditions like autism or ADHD, all of which are usually recognized in childhood. Now, Walger syndrome is an example of a contiguous gene deletion syndrome. Contiguous means next to each other, so it's caused when two or more genes are next to each other along the same chromosome arm and are deleted at the same time. In the case of Walger syndrome, it's a heterozygous deletion of a small part of the short, or P arm, of chromosome 11. There are two particularly important genes within the deleted region: the PAX6 gene, which causes the aniridia, and the WT1 gene, or the Wilms tumor 1 gene, which causes the increased risk of Wilms tumor, as well as the genitourinary abnormalities. If deleting or disrupting a gene results in an increased tumor risk, then that gene is considered to be a tumor suppressor gene. So WT1 is an example of a tumor suppressor gene. Finally, the specific gene responsible for intellectual disability in Walger syndrome is not known. Sometimes that deletion is also extra large, and also includes the gene BDNF, which is named for brain-derived neurotrophic factor. Deletion of BDNF causes the obesity seen in some patients with Walger syndrome, a phenotype called Walger-O, O for obesity. Walger syndrome is technically autosomal dominant, but it's usually sporadic, meaning that it's caused by a new mutation, rather than being inherited. Diagnosis of Walger syndrome is confirmed using FISH, or fluorescence in situ hybridization, and this involves a fluorescently labeled probe made of DNA that's complementary to the Walger region. In a normal cell, the probes can base pair to both chromosome 11s, so you would expect two bright spots to be seen in a microscope when the cell is viewed under fluorescent light. If a Walger deletion is present, though, one of those Walger regions is missing, so you'll only see a single bright spot. Now, there's no single treatment for Walger syndrome. Rather, each problem is usually addressed individually. For example, for photophobia, you might use tinted lenses. Or for Wilms tumor, you might use chemotherapy. The most important thing is to have a timely diagnosis of Walger syndrome so that there's adequate medical surveillance, like regular renal ultrasounds and blood pressure checks to look for Wilms tumor, as well as pelvic ultrasound in women to look for streak ovaries, and the subsequent possibility of a gonadоblastoma. Alright, as a quick recap, Walger syndrome is a contiguous gene deletion syndrome caused by the deletion of several genes on chromosome 11, including PAX6 and WT1. The result of this is a risk for Wilms tumor, aniridia, genitourinary abnormalities, and intellectual disability. What's up, guys? Thanks for watching. Just want to give a little shout out to Phil in Boston, who is one of our awesome script writers. He helped put together the script on that one. Other than that, you can help support us by donating on Patreon and telling your friends about us on social media, as well as subscribing to our channel. Thanks a lot, guys. Bye.